بتاعت ال Pediatric Transplantation. هو الأول بس في التيم بتاع الهيباتولوجي كله للأسف كوفيد يعني تعب. التيم بتاع الهيباتولوجي اعتذروا عشان كلهم عندهم كوفيد. لو قدروا في تعبانين وفي لا هيقولوا برزنتيشن مش هيقولوا هم تعبانين مش بس عندهم كوفيد يعني لا البوست او اللي لسه مخلصين كورونا وبيعتذروا الدكتوره هناء القراسي والدكتوره توحيده حتى بتوع عين شمس والقاهره الاثنين بس الكومن فاكتور اللي عندهم انهم هيباتولوجيست مش عارفين ايه الريسك ده ان شاء الله. فهنبدا السيشن بقى هتبقى كلها نفرولوجي. الدكتوره ياسمين رمضان lecturer of pediatric nephrology Cairo University هي اللي هتبريزنت الفيرست توك. هتتكلم عن growth and development after renal transplantation.
Good morning, dear colleagues and dear professors. Thank you for having me today. My talk is about growth and development in pediatric patients after kidney transplantation. Kidney transplantation in children doesn't aim only to avoid dialysis and its complication, but also to restore an optimum quality of life. All advances in the last 30 years resulted in a shift in focus of improving recipient survival to improving quality of life. Our target nowadays is optimization of linear growth and developmental skills. Despite well-functioning renal allograft, both physical growth and cognitive skills remain suboptimal. We have to measure height, weight, and body mass index every 3 months in children less than 3 years of age, then every 6 months until final height is reached. Final height is reached as a gross velocity per year minus 1 to 2 centimeters after puberty has occurred. We measure weight and height and plot them on growth curves. Growth is a dynamic process, so we have to do a gross velocity. Nowadays, we depend on standard deviation scores and WHO Z scores. To predict the final adult height, we have to measure mid-parental height, mother's height and father's height using this equation. Linear growth divided into 3 phases. In the first 2 years depend on nutritional status. From 2 years to puberty depends on growth hormone. Then pubertal growth spurt depends on sex hormones. Pattern of growth after kidney transplantation among children with end-stage renal disease. They did a cohort of 389 pediatric renal transplant recipients, ages from 2 to 18 years with a median follow-up of 3.4 years. They compared the age-related lengths of all linear body dimensions in children who had received a kidney transplant and normal children. They didn't depend on the total height only, they depend on sitting height and leg length. Children with end-stage renal disease present with disproportionate stunting. Fortunately, after the kidney transplantation, a sustained increase in standardized leg length and total body height is observed from preschool until adult age, resulting in restoration of body proportions in most patients. Reduction of steroid exposure, optimum metabolic control before and after transplantation are promising to improve growth outcome. In this study, they observed 2 periods of sustained catch-up growth after 2 to 4 years from transplantation and after 12-14 years. What are factors affecting post-transplantation growth? Factors before transplantation related to age at diagnosis of CKD, primary renal disease, presence of renal osteodystrophy, treatment with steroids and nutritional intake. Age at the time of transplantation is very important to predict post-transplantation growth. After transplantation, growth depends on graft function and steroid therapy. What are the predictors of linear body dimensions after kidney transplantation? Time after kidney transplantation, bone maturation, steroid exposure, metabolic acidosis, and parenteral height are very important. The most sensitive body segment is leg length, which being significantly affected by all factors affecting post-transplantation growth. But the most inert body segment is the trunk length, which affected only with steroid dosage, bone age delay, and parenteral height. So the strongest predictor of body proportion is time after transplantation, followed by dose of steroid and parenteral height. What are causes of growth failure after transplantation? There are disturbances in growth hormone, insulin-like growth factor axis. Also, glucocorticoids have an effect on growth hormone and the insulin growth factor axis. They downregulate growth hormone receptors, inhibit insulin growth factor synthesis, and modify the binding protein of IGF. Glucocorticoids has also a direct effect on growth path. They decrease the osteoclast, they increase the osteoclast and decrease the osteocyte and osteoblast. How to optimize growth velocity post-transplantation? The main causes of growth impairment after transplantation is reduced GFR, steroid therapy, bone disease, metabolic acidosis, malnutrition, and comorbidities. So we have to improve the drug compliance, treatment of acute rejection, prevent and management of chronic allograft dysfunction. If we can withdraw or stop a steroid, it will be perfect for optimum growth. But if we can't, we have to use the lowest dose, either daily or alternative daily therapy. We have to correct the acidosis, manage the plasma phosphate and BTH, and improve nutritional intake and assessment control of other comorbidities like cardiac disorders. What about growth hormone therapy in transplanted patients? The target population for growth hormone therapy is prepubertal children, especially early post-transplantation, if they have a height more than -2 standard deviation with poor growth velocity and open epiphysis after correction of all factors that can contribute to growth failure. But what are the contraindications? Absolute contraindication is active malignancy. Relative contraindications, repeated acute rejection episodes within the last month, 6 months, chronic graft dysfunction. Growth hormone therapy in transplanted patients is a dilemma. In USA and Europe, growth hormone is not approved for treatment of growth failure after transplantation. But in Germany, they can use growth hormone if the patient had reduced GFR below 50% of normal. Kidney Disease Outcome Quality Initiative guidelines provided recommendations for growth hormone use after pediatric renal transplantation. It hasn't been proven that growth hormone treatment triggers rejection episodes. But if we have a patient with 2 or more rejection episodes before start of therapy, they have more frequent rejection episodes when treated with growth hormone. Patients with chronic rejection or repeated rejection episodes are at risk of new episodes with or without growth hormone. So, is growth hormone treatment contraindicated in those patients? I don't think so, because those patients don't show satisfactory growth and often receive glucocorticoids. So the decision for using or not using growth hormone is combined between treating physician and patient's family. What about cognitive development after transplantation? Children with renal disease in all stages of therapy performed worse than controls in a series of neuropsychological tests. Kidney transplantation improved linear growth, school attendance, involvement of age-related activities. All studies comparing dialysis and kidney transplantation children confirmed better mental processing speed and sustained attention improvement after kidney transplantation. This is a study about cognitive function in kidney transplantation patients. They documented that patients with end stage have a high prevalence of cognitive impairment that improves post-transplant, but unfortunately, residual deficit persists. Up to 87% of patients on hemodialysis and 75% on peritoneal dialysis have a cognitive impairment. After kidney transplantation, this cognitive impairment is improved, but the prevalence is high, from 22.3 to 58%. What are the etiologies of cognitive impairment in kidney transplant recipient? Traditional risk factor for dementia such as hypertension, diabetes, hyperuricemia, and others, but other factors as effects of immunosuppressive drug, post-transplant delirium, low physical activity. Is this cognitive improvement continuous or transient? This study, they examine whether these early cognitive benefits of transplantation continue to develop over time along with the patient's ongoing recovery. They did a prospective study about 27 dialyzed patients with end-stage renal disease who subsequently received the kidney graft, and 18 patients on dialysis who were awaiting kidney transplant, and compared them with 30 control participants. This study used a mini mental state examination. And they stated that overall successful kidney transplant contributed to a statistically significant improvement in performance on tests of motor, psychomotor speed, visual planning, memory, abstract reasoning tested 1 year later. Allow me to share our center experience regarding kidney transplantation in children. We transplanted 187 pediatric kidney transplant recipients, and they were followed up in our center. 165 living duration of dialysis. We didn't find statistical significant difference regarding frequency of acute rejection or steroid dose. Growth hormone was given in 4 kidney transplant recipients only after a preliminary preparatory investigation. Unfortunately, 2 patients developed acute rejection 1.5 and 2 months after growth hormone, but 2 patients doing well after 3 and 6 months of growth hormone. So, my take-home message, early transplantation has a positive impact on both the transplantation growth and development. Optimizing the growth prior to transplant, metabolic bone disease management, and nutritional care are essential in achieving optimum final height. Until alternative promising treatment strategy is found, individual decisions of growth hormone seem justified. A wait-and-see approach is not a recommendable strategy. Early monitored growth hormone therapy has higher chances of success than treatment attempts long periods after transplantation. Thank you.
ثانك يو دكتوره ياسمين. طبعا موضوع الجروث بوست ترانسبلانتيشن والجروث هرمون والموضوع ده يعني في كلام كتير، وطبعا شكرا برضو على عرض الاكسبيرينس بتاعتنا. دكتور جمال شكله عايز يقول لنا. اتفضل دكتور جمال.
اولا بنشكرك يا دكتوره دعاء على الفيري اكسلنت برزنتيشن، استمتعت بيها واستفدت منها.
شكرا لحضرتك.
هسال حضرتك على كذا حاجه. اولا البيشنتس اوريجينالي هاف ريديوسد جروس بارامترز قبل ترانسبلانتيشن and this is not very corrected after transplantation as you mentioned. There are data now that the gross retardation or gross failure by itself is an indication to transplant, مش الكدني function. Do you have any data or any experience about this؟ يعني لما يكون في gross failure يبتدي transplantation في ال conservative phase of CKD.
تمام.
يبتدي transplantation مش يستنى لما يحصل complete renal impairment.
تمام.
Do you have any data about this?
I read about preemptive transplantation with good result for post-transplantation growth in many patients. So if you I think
انما دكتوره ياسمين احنا ما عندناش experience ان احنا we started transplantation preemptively علشان الجروس فيل.
No.
We can consider it. وانا افتكر ان كنت متفق مع الدكتوره دعاء صلاح ان هي تجمع الحالات اللي فيها بون ديفورميتيز وسكندري هايبر بارا ابنورماليتيز وتكورليت مع الفيتامين دي 3 والباراثورمون والكالسيوم والفوسفور. مش عارف عملت البيبر دي ولا لسه؟ لسه. هي انتوا مكسلين، ده انتوا عندكم كنز من الحالات وابنورماليتيز وديفورميتيز وحاجات كده، خساره انها ما تتعملش. يا ريت يا دكتور حافظ تتولى انت انك تجمع لنا الحالات اللي موجوده عندكم بصورها بالبارامترز اللي ديفكتيف فيها. السؤال الثاني لحضرتك يا دكتوره ياسمين، انت قلتي ال WHO زد سكور بنعتمد عليه. انا يتهيألي ان ده ديفكت خطير نعتمد عليه. ليه؟ قولي لي ليه وبعدين انا هقول لك ليه.
يمكن عشان اختلاف البوبوليشن يعني
الله ينور عليك. الاثنيستي هم عاملينه اون وات بيزس، واحنا السكور اللي احنا عندنا هل هو ينطبق على دول ولا لا؟ يعني عم تقولي مثلا ايشيانز ولا فيلبينيز ولا يوروبيانز وكده، هم عملوها مجمعه وحاجه واحده، مش عاملينها variable according to ethnicity.
لا ما فيش.
and this is a great defect to exclude السكور ده.
تمام.
يعني فاهم انا قصدي ايه؟ Do you have any comment؟ وعندنا ايجيبشن سكور ولا لا؟
عندنا يا دكتور بس ايجيبشن جروث كيرفز بس، لكن ما عندناش زد سكور.
طب ما نعمله واحنا صغيرين.
هو المشكله يا دكتور جمال انه الايجيبشن جروث كيرفز اول حاجه هي بقى لها 20 سنه، ف it needs to be updated.
ابديت يا دكتور.
تاني حاجه انه الايجيبشن جروث كيرفز wait for age وهايت فور ايج، انما ما فيش فيها امكانيه ان انا اوصف البيشنت بالستاندرد ديفيشن سكور، فاحنا بنضطر نستخدم ال WHO من هذا المنطلق. لانه
ليه ما نعملوش يا دكتور حافظ؟ انا اقصد ليه ما نعملش؟
يعني حضرتك عندك حق، هي طبعا هي ده كان ناشونال بروجكت كانت عاملاه طبعا الدكتوره ايزيس.
انا ناوي على الحاجات دي.
it needs to be يعني updated لكن يعني احنا ما عندناش source readily available based on large scale Egyptian anthropometric data اننا نقدر نطلع منه standard deviation، انما this should be a project to be done. انا مع حضرتك
يعني
تمام.
يعني انا اتهيألي نستغل الانيشيتيف من المؤتمر ده، وحضراتكم شرفنا، واختيار الموضوع حلو وجميل ونوت ابروشد ونوت ادريسد انف. يا ريت نعمل. احنا دلوقتي اتفقنا على 3 حاجات هتعملوا لنا السكندري هايبر باراثايروديزم والابنورماليتيز والبايوكيميكال بارامترز اللي فيها. البيبر دي انا بقالي 5 سنين اتفق مع دعوه وتقول لي حاضر 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 وما بتعملهاش لغايه ما راحت اتجوزت ومش هناخد منها حاجه بعد كده. فاخر سؤال ليكي، الكاتش اب بعد الترانسبلانتيشن كم %؟ يعني هو ديفكتيف من الاول والاميونو سبريسيف عامله له سبريشن، وحضرتك قلت لنا ان الجروث هرمون مش بيجيب نتيجه قد كده، فالكاتش اب تو ذا نورمال كيرفز حتى في تقديرك انت بيبقى كم %؟
مش كتير
50%، 20%، 30%؟
لا اعتقد هيبقى 20 كمان او اقل، يعني مش اكتر من كده.
20 او اقل.
هو يمكن له علاقه برضه بالمده. هي يعني انت ياسمين كنت قلتي 0.7 او 0.67 ستاندرد ديفيشن، ده اللي هو الريلاتيف امبروفمنت في البيشنتس اللي ترانسبلانتد. طبعا الجروث هرمون يعني قصه الريجكشن وقصه نبدا امتى وقصه العيان زارع يعني عنده ويندو اوف اوبورتيونيتي فور جروث ولا زارع متاخر، يعني القصه دي ما زال فيها كلام طبعا. ولكن يعني هو من الليترشر يعني البيست بنفيت اوف جروث هرمون بيبتدي 6 شهور بعد الزرع وبينتهي practically 2 years. يعني في ناس قالت يعني فرص اضيق من كده، بس يعني في اكثر الحاجات يعني تفاؤلا هو من 6 شهور ل2 وطبعا في ايشوز لها علاقه بالتامين وتوافر الدواء وهكذا. واحنا ممكن يعني احنا في الجايد لاينز بتاعتنا كان في كرايتيريا، لو الدكتوره فاتينه تحب تقولها لنا يعني مين اللي ممكن يستفيد منه.
هو احنا لما حطينا الايجيبشن او يعني الجايد لاينز في اليونت عندنا للترانسبلانتيشن ان تشيلدرن، حطينا وي كونسيدر طبعا اهميه الجروث. ف يعني احنا الريكومنديشن عندنا، بس هي مش strong recommendation. growth hormone is typically not started during the first 6 months post transplantation. The following precautions should be considered لو هندي بقى growth hormone.
يعني هو انتوا recommending not to use it في first 6 months.
not to be used
ليه؟
في first 6 months.
ليه not to be used في first 6 months؟
يعني
هو هيعمل ريجكشن يعني؟
هو وكونترا انديكيتد لو في لو حصل ريجكشن كمان، لو الطفل بيجي له ريجكشن ابيزودز يبقى ده كونترا انديكيشن ان هو ياخد جروث هرمون. فاحنا
بعض الميتابوليك ديريجمنتس اللي لها علاقه بالفيتامين والفوسفورس.
هسأل حضراتكم حاجه. Do you routinely use vitamin D3 in these cases?
Yes.
Do you routinely use vitamin K2 in these cases؟
لا.
لأن ال K2 هو اللي واحنا عرضناها امبارح في السيمبوزيا، هو اللي بيبوتنشيت الكاربوكسيليشن او ماتريكس جي ال بروتين والاوستيوكالسين عشان الفيتامين دي 3 يشتغل. فاي ثينك ات شود بي one of the parameters. سيبكم من الشركات ومش الشركات، بس الكونسبت از ذير ان فيتامين K2 should be supplemented together with D3. اتفضلي كمل.
عايزين تسمعوا بقيه الجايد لاينز considering growth hormone. Growth hormone therapy may be considered for kidney transplant recipients with growth hormone with growth failure, height less than 3rd percentile, or a height target standard deviation score of less than
يعني اللي
-2.
يكون very defective هو اللي نبتديه له. انا ممكن اختلف مع حضراتكم في الحته دي، ان الاديل اللي حتى اللي كويس شويه هيستفيد منه اكتر.
height velocity of less than 25%.
يعني مش لازم ابتدي باوحش واحد، ابتدي باللي هو كويس يمكن يجيب نتيجه احسن معاه.
هو السكند بارامتر ان الهايت فيلوسيتي تبقى اقل من 25%
less than 25% من الكرونولوجيكال ايج.
مش مختلف مع حضرتك في ال6 شهور، انما انا اقصد ان انا ابتدي، مش لازم ابتدي في الوحش قوي اللي هو البرسنتج بتاعه وحش قوي، ما استناش ال 25% وما استناش اللي يكون الثيرد برسنتايل اند سو اون. ابتدي في الكويسين الاحسن، اجيب نتيجه احسن، اصلح ال يعني فاهم انا قصدي ايه؟ يعني مش عارف انتوا مختلفين معايا ولا متفقين معايا. يعني الحلو اصلحه كويس، واي نوت، الا لو فاينانشال بقى.
لا هي في الترايل، بس هو there is no evidence anywhere ان هو يتاخد في اللي فوق -2، بس it could be a trial.
دكتور لو في اي اكسبيرينس في السودان او اي كومنت.
Thank you for this elegant talk. We are adult transplant nephrologists, but you mentioned that the glucocorticoids also has negative impact upon growth in pediatric. So, have you got any experience about the steroid-free regimen in your center? Because sometimes there is a pediatric patient, young, and you need to give him steroid or any way to reduce steroid day after day or something. What regimen you adopt in your center? Thank you.
We tried it before to rapid early withdrawal of steroids, but the results were disappointing.
Yeah, we had experience actually about this, and we went through a study of early steroid withdrawal, and it was the thesis, the MD thesis of Dr. Imam Fathi. If you want to comment on the results of this study. But actually, as Dr. Yasmin had mentioned, it was, yeah. Yes, of course, the children who were included in this study were all low risk, definitely, yes.
No risk, yeah.
The trial was to include okay. The trial was to include about 30 patients and 30 control. We couldn't include only 6 patients were included. 5 of them developed acute rejection after transplantation. But I tried very early steroid withdrawal after 7 days. Yes. Yes, and every case with early steroid withdrawal took ATG. All cases. And yes, 5 cases developed acute rejection, immediate acute rejection, and 1 was not on rejection and was keeping normal kidney function up to 4 months after transplantation, and then enter rejection.
والبيبر دي published يا دكتورة؟
No.
يا لا مش معقول بقى
because small sample size دكتور جمال.
الناس اللي احنا عملنا لهم ايرلي ستيرويد
كلهم كانوا لو ريسك. يعني احنا الانكلوجن كرايتيريا اوف ذا ستادي ان all the children should be low risk to start steroid withdrawal protocol. فهم كانوا كلهم low risk.
يعني معمول لهم BRA
يس. نفسي افهم هتنشروا الكلام ده ايه؟
small sample size دكتور جمال. 5 patients only.
في الاطفال وفي
هو يعني based on this what we do and what we need to emphasize انه ال avoidance او ال very early withdrawal we cannot recommend بس هو اللي احنا عايزين نقوله انه we need to avoid keeping patients too long on high doses more than necessary. Late. Not in the first 6 months. 6 months to 1 year. على بعضها.
حتى ولو فرض ان في يعني احنا we decided to early terminate the study because of the results
can be published
disappointed. فيعني ده ممكن يعني يبقى تفسير لانك انت عامل 5 حالات او 6 حالات.
Every other day and there are few cases where it was completely stopped but after the first year. I know it's not going very well with adult transplant recommendations, but it needs to be published. حضرتك عندك
مشكلة خالص.
Any more questions from the floor for Dr. Yasmin?
Thank you. الأول أنا بشكر دكتور جمال ودكتورة فاتين على دعوتي لحضور المؤتمر الترانسبلانت، وأنا يعني لسه بحاول نكتب القلم الرصاص كده أول المشاكل، و يعني أكيد أحب أسمع بقى كيس برزنتيشن، يعني كلنا هنحب نسمع كيس برزنتيشن من الدكتور محمد عبد المقدور. اتفضل دكتور محمد.
بسم الله الرحمن الرحيم. Today we will discuss a case in our unit. We learned a lot from it as related to the steroids and the withdrawal and avoidance. It is about a male child, 7 years old, with consanguineous parents and no family history. The patient presented at the age of 3 years with anemia and failure to thrive. While doing labs, there was metabolic acidosis. Serum creatinine was 6.7 and hemoglobin was 6.4. Abdominal ultrasound showed average sized kidney with loss of corticomedullary differentiation and multiple bilateral cortical cysts. The child diagnosed as cystic kidney disease, mostly in nephrolophthisis, and started regular hemodialysis. through a temporary right internal jugular line, which changed after that to permecath. Unfortunately, genetic study was not available at that time, so we couldn't do it for that patient. Preparation for transplantation started immediately. The mother was a donor for him, and the weight was 12 kilograms. The patient was considered a low immunological risk patient. Mismatch was 2/6 with complete matching DR. PRA was negative, cross match was negative. Transplantation started 5 months after the start of the dialysis, and the operation passed with no events. Ischemia time was 40 minutes, and the donor has single renal artery, and the renal artery and vein transplanted directly in the aorta and the IVC. At that time, we started to think about steroid withdrawal protocol and steroid withdrawal plan. The patient received basiliximab, received also tacrolimus, started from day -4, steroids from day -1, about 80 milligram, and mycophenolate mofetil from day -2. Post-operative data, the patient developed good graft function with immediate diuresis. The serum creatinine immediately post-operative was 2.1 until reached 0.5 at day 7. Steroid withdrawal was planned to be done in the and stopped after the 1 week, and we reached 5 milligram at day 7, then stopped the steroids. Tacrolimus trough level was 8.1 at day 0, and at discharge was 8.9, and the dose was 4.5 milligram. During the follow-up, the patient developed good follow-up results with stable graft function until the 3rd month post-transplantation, when the creatinine impaired and the graft function impaired at that time, and the creatinine was 1.2 with normal trough levels, accepted trough levels at that time. The decision at that time was to do graft biopsy, and IV steroids was given for 3 days, then switched to oral steroids. And the suspected diagnosis at that time was antibody mediated rejection. احنا طول الوقت كنا يعني قلقانين، احنا ما بنديش ستيرويدز والولد دوت ماشي كويس. اول ما لقينا الكدني فانكشنز عليت، اول حاجه جت في دماغنا ان احنا عندنا ريجكشن. But the results of the biopsy was different. It showed acute tubular injury, mild arteriosclerosis, and negative C4D. And the patient continued at that time on tacrolimus, mycophenolate mofetil, and received again steroids. وفي الوقت ده احنا قررنا ان احنا هنكمل على الاستيرويدز، يعني قلقنا وقلنا بلاش نعمل steroid withdrawal او avoidance تاني. 2 years post-transplantation, the patient started to develop frequent GI symptoms in the form of diarrhea, vomiting, and abdominal pain. At each time, the patient was investigated, MMF was stopped, withholded at that time, and until the attack stopped. We passed to the investigations. We did the routine investigations, then stool analysis, stool culture, virology, CMV, Epstein-Barr, BK virus, and the results was normal. Then we did upper and lower endoscopy. The results of the endoscopy showed chronic enteritis, and samples were taken for histopathological correlation. The results was disappointing for us. It showed lymphoproliferative small intestinal disease, and immune histochemistry was done also showing positive CD20, CD10, and CD5. The patient at that time referred to the pediatric oncology team. At that time, the patient was on tacrolimus 5 milligram, mycophenolate mofetil 750, and steroids 5 milligram. The decision of the pediatric oncology was to lower the tacrolimus and stop the MMF. At that time, the serum creatinine was 1, and the level, prograph level was accepted. They passed to the investigations, did bone marrow biopsy, PET CT of the whole body, and repeated the virology again. All the results were negative at that time. So they decided to reanalyze the samples again for pathological confirmation. And the results show a chronic non-specific inflammation, not malignant inflammation. And the decision was to follow up and the decision for the patient that it was not a malignancy, and just for follow-up after that. The current situation of the patient now is he is on tacrolimus steroids and azathioprine. The take-home message from this case that long-term use of steroids carry many side effects, including hypertension, hyperlipidemia, impaired glucose metabolism, diabetes, weight gain, infection, and osteoporosis. Steroid withdrawal significantly lower the incidence of the serious infections and diabetes, with less increase in the body mass index. Steroid withdrawal is safe and beneficial in non-sensitized kidney transplant recipients regarding rejection and chronic allographic nephropathy. Early and late steroid withdrawal positively improve growth in children following renal transplantation with improvement of the bone density. Steroid withdrawal protocols اللي احنا سمعنا عنها زي الستيرويد فري مينتنس ريجيمن اللي هو الافويدنس افتر day 7. Lower maintenance dose regimen. It means that we need to reach 0.05 to 0.1 milligram per kilogram steroids by the end of the first year post transplantation. Complete avoidance in these protocols. They don't use steroids even in case of attacks of rejection. And steroid withdrawal protocol, which contain early and late steroid withdrawal protocols. Early means within 3 to 6 months, and late after years of transplantation. Gastrointestinal discomfort is common after renal transplantation and can be caused by use of various immune suppressive drugs. Gastrointestinal symptoms affect the quality of life and may lead to impaired graft survival and increase mortality. Symptoms may be an alarm for dangerous problems like infections and malignancy. The approach to deal with malignancies in the setting of solid organ transplantation should start with preventive measures as avoidance of excessive immune suppression, avoidance of repeated exposure to depleting anti-lymphocyte antibodies. Once detected, a malignancy should be managed with the specific therapies for particular tumor type and with the strategies such as immune suppression reduction, immune suppression withdrawal, or conversion to alternative immune suppression regimens based on mTOR inhibition. Post-transplant lymphoproliferative disorder is one of common malignancies in solid organ transplant recipients. The most common type in the post-transplant lymphoproliferative is B-cell lymphoma, and it has been observed early post-transplantation. Thank you.
Any questions? شكرا دكتور محمد على الكيس.
اولا بشكرك دكتور محمد على البرزنتيشن الرائعه ديت. ودكتور محمد من الناس المجتهدين والمثابرين ويعني فيري اكتيف ممبر في اسم الاطفال. ليه كذا تساؤل، هو في النهايه طلعت PTLD فعلا ولا كان؟
لا، هم قالوا انها كرونيك نون سبيسيفيك انفلاميشن، وقالوا انها فور فولو اب، والبيشنت من ساعتها
عملوا اي ماركرز اوف ليمفوماز؟
لا، هم عملوا ماركرز كاميون هيستوكيمستري تاني
على السلايدز بس، انما احنا كلابوراتوري انفستيجيشنز ما عملناش اي ماركرز. هل في ماركرز انتم متعودين تعملوها تو دوكيومنت PTLD؟ سيرولوجيك ماركرز؟
لا، ما بنعملش غير
لا، في اصلا في ماركرز اوف ليمفوما او ليوكيميا او حاجات كده، مش في ماركرز؟
في ماركرز.
هل حطينا ان اور بلان ان احنا نمونيتور باي اني اوف ذيس تيومر ماركرز؟ لان هي خلاص بقى بوردر لاين. بليز نبقى نحط لما يكون حد سسبيشس نفولو اب باي تيومر ماركرز. هل في الحاله دي يو كونسيدرد ان انت تزود اني اوف ذا mTOR انهبيتورز؟
واحنا احنا كنا عايزين احنا من نفسنا ندي اي حاجه من الmTOR انهبيتورز، بس قلنا هندي يعني الرأي للبيدياتريك اونكولوجي، وهم لما تابعوا الحاله قالوا ان احنا هنقلل. يعني هم برضو كانوا شاكين شويه انها ممكن تبقى كده.
انا تالي ان اتس يو هو شود تيك ذا ليد في الديسيجن اوف ذا immunosuppressive بروتوكول. وتالي ان انتوا عندكم اكسبيرينس اوف ذا mTOR انهبيتورز ان يور سيريز، وكان عندكم الايفرولومس ستادي وحاجات كده. هل وقفت ولا ماشيه؟ كان في البرنسبل ان احنا نقلل الانتي بروليفراتيف وتاد حتى مش لازم فول دوز اوف افرولومس او سيرولومس. مش عارف ده لسه اون جوينج ولا لا، يعني ده فيري سوتبل للحاله دي.
هي الاستادي وقفت
ليه؟
يعني
انت كنت بتعمل ريبليسمنت ولا هافينج الدوز اوف MMF؟
لا كنا بنعمل ريبليسمنت.
ما في بقى البرنسبل انك تدي هاف دوز اوف ذا انتي بريفاتيف MMF وتدي معاه الافرولومس. وده كان عملناه في الحاله اللي كان الدونور كان عنده سسبيشس سيس وطلعت مالجنس مش عارف ايه، عملنا كده.
هي ماشيه لغايه دلوقتي كده.
ماشي، ما هو انت واي دونت يو ابلاي ذس ان اذر سيميلر بروفيلاكتيك كيسز؟ ايوه.
هو البيشنت.
الميكروفون يا دكتور حافظ، اتكلم في الميكروفون.
اللي حضرتك بتقول عليها، وفي another patient كان liver kidney transplantation ودخل في ليمفوما، فرانك ليمفوما، ووقف كل حاجه واكسايزد وخد كيموثيرابي، ولما رجع على امتور فتره، وبعدين رجعنا التكروليماس على لو دوز بعد كده.
ونشرنا الحاجات دي ولا لا يا دكتور حافظ؟ نشرناها ولا لا؟
الاخير ده 12
والاولاني
الاولانيه متهيألي لا الاخير ده 12.
وكل ميتنج نيجي نقول ده احنا عندنا حاله كده، هو كل الناس بتكون بتتكلم عليها ونقول ده احنا عندنا حاله كده. يا ريت ننشر
بس هما الاثنين دول هم عدوا 10 سنين بوست ترانسبلانتيشن، فده شيء كويس.
يا ريت ما تبقوش بخله في ان انتوا تطلعوا الداتا اللي عندكم للناس يتعلموا منها. يعني انتوا بتعملوا شغل رائع وسنتر اوف اكسلنس يس كورك، انما بابليكيشن لا، مش نفس المستوى. فاحنا عايزين نبروباجيت الحاجات المعلومات اللي عندنا لا تضن بيها على الناس.
هو يعني انا طبعا مع حضرتك، بس هو البروتوكول اللي حضرتك قلته هو تم في حالات انديفيديوال،
وليكن
انما مش
كيس ريبورتس. ده العلم بيبتدي كله من كيس ريبورت.
صح.
هو احنا كان عندنا كيس برضو دكتور، كانت من ضمن الاستادي ماشيه. كان ولد سبوراديك FSGS وكان عنده HCV انفكشن، وما كانش كانديديت فور انترفيرون في الوقت دوت، لان كان عنده ريتينال بروبلمز. الولد ده زرع وكان من ضمن الاستادي واتقلب لافرولومس بعد ما عملنا بروتوكول بايوبسي بعد شهر، وبعد 3 شهور عملنا له بايوبسي كان فيها بوردر لاين تشينجز، ما كانش فيه ريجكشن، وساعتها زودنا له لو دوز.
انت ما زلت بتاكد اللي انا بقول، ان انتوا عندكم كنز من المعلومات ومش عايزين
هو الولد ده
مش عايزين تنشروه للناس.
هي الاستادي دي اتنشرت يا دكتور، اتنشرت بس يعني ما كانش العنوان بتاعها
لا انا عايز اعرف الاكسبيرينس اوف امتى الانديكيشنز اوف mTOR انهبيتورز ان بيدياتريك ترانسبلانتيشن اكسبيرينس. المعلومه الثانيه بقى دي عايزه برين ستورمنج، وممكن نحطها بروتوكول، والدكتور منتصر خليك معانا. احنا لما بنيجي نعمل PRA ونقول patient sensitized ولا لا، وبعدين انت قلت ان الحاله از لو ريسك، وانا مش موافقك قوي، لان المذر دونر از هاي ريسك، لان المذر اصلا عندها tendency to sensitize عندها وانها مور tendency to induce rejection في الريسيبينت عن الميل دونر. فالمذر از هاي ريسك. احنا لما بنيجي نعمل PRA بنعمله في مين يا دكتور حافظ؟ امسك المشروع عشان انا هعمل برين ستورمنج معاك. بنعمل PRA بنعمله في مين؟
بنعمله في الانتندد ريسيبيانت.
هل في possibility ان احنا نعمل ستادي معايا يا دكتور منتصر ان احنا نعمل PRA في المذرز who are donors، اشوفهم how far they are sensitized، حتى لو الريسيبيانت نيجاتيف وزيرو، اشوف المذر الدونور الفيميل دونرز، خليها جنرال الفيلم سواء بس لازم تكون في history of pregnancy and so on، نعمل PRA فيهم ونشوف how far are they sensitized، ونكورليت ده مع البوست ترانسبلانت ريجكشن.
ممكن طبعا يا دكتور جمال.
رايك ايه يا دكتور منتصر؟
هو طبعا المين ايشو في السنسيتايزيشن بيكون البي كلونز في الدونر، فدي اللي هي ويل ستارت الامينولوجيكال بروسيس في الريسيبيانت، وهتبتدي الفيرست ويف اوف فورميشن اوف انتي بوديز وكده،
يبقى احنا لو عملنا بي ار اي في الدونورز هنلاقي تترس.
وارد طبعا.
فنعملها.
يعني هو هيبقى فيه اوريدي بقى
برافو عليك، هيبقى فيه. انما ده it is not addressed completely. محدش عمره دور
محدش بيدور عليها في
على بي ار اي. فاحنا لو عملناها هتبقى very novel study ونحطها بروتوكول. وهو ما فيش حد هنا في القاعه غير حد بره، في 2 من السودان بس، ومعانا سمر باين ولا مين؟ سمر اهي. فيعني اي مين ان ده اللي نعمله بروتوكول ما بيننا وما بين الدكتور منتصر، بما ان هو اللي بره القصر العيني، فنعمل بروتوكول.
ما هي
معاك.
البيك لونز هترفلكت على لو عملنا.
طب ما احنا نقاسها واشوف المذر دي هاو فار سنسيتايز، واحطها one of the parameters of risk factors في مش بس الريسيبينت.
بس اي ثينك دكتور جمال، لو فرض ان احنا كان عندنا اوريدي فورمد انتي بوديز في الدونر، كان الريجكشن هيبقى فيري ايرلي.
ما احنا يعني هنشوف
يعني
احنا وي دونت ستادي اصلا.
لكن هو طبعا لما يبقى نتيجه للكلونز اوف بي ليمفوسايتس في الدونر بتاخد وقت عبال ما تو انفايت.
I mean we are blinded about it. We know nothing about it. فاحنا لو عملنا الاستادي دي هنقول donor PRA as a risk factor for early rejection او early graft.
هو اكيد مش هيبقى فيه سبيسيفيك يعني بريفورمد انتي بوديز، لان دي هتظهر في اي كروس ماتش.
وارد نلاقيه، بس احنا we don't search for it. نعملها استادي
نشوفها.
بس مولنا بقى يا دكتور جمال.
نعم.
التمويل مولنا يعني.
انا هقول لك التمويل هيجي منين. انا اعرف واحده اسمها الاستاذه الدكتوره فاتينه فاضل بتجيب الفلوس من تحت تقطيع الارض لتبرعات ومتبرعين.
ده كده كتير
هنطلب منها ان هي تمول الاستاذ.
ده كتير قوي كده. الام كمان.
Any more questions؟ تمام خلاص، شكرا يا دكتور محمد.
احنا اعتذرنا عن تيم الهيباتولوجي انهم للاسف كلهم معزولين في الكورونا. فيعني كده I will close the session now and we have a long break I think before the next session.
Hello?
Hello, dear Beatrice.
Hello, Tatiana.
Yes, this is Tatiana. Yeah. So nice to see you. Yeah.
How are you doing?
All fine, all fine. Thank you so much. Yeah, thank you for joining us.
No,
I think
my pleasure.
I think that the Congress is having like still 20 minutes of break, so we will start our session after the break. Yeah.
Okay. Okay. So you would be. I understand that we close our cameras and our audio until it is our time to present, and then there is time for discussion at the end or after every presentation.
I would suggest we take any questions and do the discussion after all of the presentations.
Okay, so so we give our talk, we close our camera and our micro, and everything at the end. We'll open again our cameras and we have a joint discussion.
Yes, if the time permits.
Okay.
Yeah, because we have 1 hour and 4 speakers.
Yeah.
And our last speaker, Dr. Paskalev, she sent me the video recording. It's 19 minutes. It's a little bit over the limit, I would say. But she just sent me this morning. So, I mean, there is no chance to cut it, as you understand. And we will play it, and then we will see how we are doing with the timing also.
Okay.
Because I also don't exclude some technical issues, and there might be situations whenever the video just won't go, you know, so then we will have more time for discussion. Yeah, and let's play as it goes, because with this technical stuff, you never know.
Okay.
Yeah.
Well, Tatiana, in my case, I would appreciate if when I've spent the 10 minutes, you just tell me you have 2 minutes left.
Okay.
So please do so. Don't feel bad about it. Tell me, because I prefer to have time for discussions as you do. Okay.
So thank you so much, dear Beatrice. Thank you. Will do. And you might also follow what I noticed from previous sessions, they also put a timer on the screen.
That's great.
So you will see.
If I have the timer, don't worry, because I will be trying to stick to my time. It's short, but I understand that you prefer to have time for discussions. I also wanted to ask you, you were planning to produce a tool, particularly for professionals in human trafficking for organ removal. How is that work doing? Because we attended this working group meeting some months ago, but we don't know what was the final result.
Well, from our side, we are now developing together with WHO, with Stratos, who you know very well, and the OHCHR, Ms. Yula Hadadin, who you also probably know, but she will speak also at this session today. So we are developing an issue brief, a policy brief on human rights implications on THB for organ removal. So this is hopefully will be developed this year, and then we will go from there, you know, discussing it further with the medical community, with the anti-trafficking community, and so on. What I know, and we will have a speaker today also from UNODC, Ms. Emma Comrie, and they are working, and we are part of that expert group as well. I believe you might have been participating in it.
Yeah, that's where I participated.
Yeah, on development of this law enforcement manual. Yeah, so this is
so it was a manual more targeted to help law enforcement agencies to investigate these crimes, supported by the expertise of healthcare professionals. I mentioned this because I'm going to give an overview of the different recommendations and issues that have been produced that are of relevance for healthcare professionals. And I was unsure whether UNODC, as you very well point out, had go over with that. What was the situation of that document? But you're probably right that it was more targeted to law enforcement agencies than to healthcare professionals, but based on information provided by healthcare professionals. So,
correct.
Yeah, just to have the picture clear. Okay, great. Thank you. And thank you for your work in this field.
I thank you very much for joining us. I know how busy you are, so thank you so much for joining us.
My pleasure.
Yeah.
Thank you.
Okay. Thank you. Then we'll switch on the video in 15 minutes or so. Yeah.
Okay. See you later.
See you. Good morning, Amy. Thank you for joining. Yeah, seen you on a moment ago. Yeah, thank you.
Good morning.
Yeah, there is a break now, so we are supposed to start in about 4 minutes or so.
No problem. In the end, I did put together a few slides. It should be okay.
That's excellent. That's excellent. Thank you so much.
Welcome.
Good morning.
Good morning, dear Eula. Glad to hear you. All good, all good. You?
I'm fine. I'm fine. Can you see me?
Yes, we can. That's
okay,
good.
because I can't see myself.
Okay, now we can see all the panelists together. Miss Pascale, our last speaker for the session, she sent her video recording. So we will play it at the end because she is now in the United States, and for her it's 3 o'clock in the morning now. So
yes,
the video recording was the option preferred. So we will try to play the video at the end and see how it works. Yeah. Okay, but thank you so much, dear colleagues, for joining, and looking forward to have a successful session very soon. Yeah.
Thank you for the invitation and for the initiative.
Thank you.
Thank you very much.
Hi, Eula and Beatrice.
Hello.
Nice to see you.
Nice to see you both as well.
We're still all working from home.
Yes, now I can see you. Can you see me? I can't see myself.
I see you.
You can't see yourself.
No.
Exit full screen regime. Just press escape. And you should be...
I am in full...
No, but you should exit full screen. And then you will see the main screen below, and then the small tiles of each of us above. Just press escape.
I pressed, nothing happened.
Really? Okay. No, but we can see you perfectly. So
how do I look? Just want to check, how do I look?
You look great. You look
Tatiana,
great.
hello.
Hello, Gamal.
Good morning,
hello.
Tatiana and everybody. Hello.
Good morning.
Hello. I can hear your discussions, and I'm waiting to start 10:30 exactly in Cairo time.
That's excellent. Thank you so much, dear Gamal. We are also ready to start 10:30 Cairo time, which is in 2 minutes, I understand. Yeah?
Yeah, sure. I'm really pleased to have all this nice group together with us. And I thank you very much personally, Tatiana, for your sincere help and collaboration for the African Society through the years, and expecting your support in the coming future and more collaboration. And we don't want it to be limited to the 1-hour sessions. We want to have activities all through the year. And I'm going to set up plans with you about this.
Thank you so much, dear Gamal. Looking forward, and I'm sure that during this session you will hear also from my colleagues from other organizations who are working in the region and beyond. So there will be more opportunities for collaboration throughout the year, I'm sure. Thank you so much for that.
How is the weather? You are in Moscow or where?
No, we are in Vienna. I'm in Vienna now. Yeah. And it's pretty shiny and nice in Vienna, although probably a little bit colder than in Cairo, I assume. Yeah.
But you don't have much snow.
No, not now, not now. It appears from time to time, but not now.
Okay. Yeah. We had a lot of snows in Turkey last few days, and in Jordan and Syria and so on in this region. And we were supposed to have Professor Habral, past president of the TTS, with us. He couldn't take his flight.
No, yeah, I've heard what happens in Turkey. Yeah, so it's really a pity that Professor Habral was not able to join.
Yeah.
Okay.
It is now 10:30, and we can start the session now. It's a real honor and pleasure to have the OSCE or the OSCE among the African Society of Organ Transplantation official first annual. And from Cairo here, I'm privileged to be co-chairing the session with my dear colleague, Dr. Imad Musalhi, President General of Hospital, and have Dr. Onesmo Kisanga from Tanzania co-chairing the session. Please, Tatiana, the floor is yours.
Thank you so much, dear Gamal. Good morning, dear participants of the first annual Congress of the African Society of Organ Transplantation, and warm welcome to a thematic session on trafficking in human beings for the removal of organs. Allow me to start with thanking the organizers of this Congress, the African Society of Organ Transplantation, and particularly its president, Professor Gamal Saadi, for including this important topic in the already very busy agenda of the forum. Sadly, but the discussion on trafficking in human beings is very relevant for transplant community these days. And this is because criminals found another way of exploiting people by luring them or forcing them to provide their organs for donation. Today, we will deep dive into why this is happening and what should be done to prevent this heinous crime and grave human rights violation. Our session will last 1 hour. We will have 4 prominent speakers covering different aspects of the problem. And should the time permit, we would be glad to take your questions after all of the presentations. My name is Tatiana Rudenko, and I'm Senior Coordination Advisor of the Office of the Special Representative and Coordinator for Combating Trafficking in Human Beings in the Organization for Security and Cooperation in Europe. Among other, I lead the portfolio on combating trafficking in human beings for the removal of organs in the office, and it's my great honor to moderate this session. Without further ado, allow me to introduce our first speaker today. Ms. Yula Hadadin is the OHCHR Senior Advisor on Human Rights and Trafficking in Persons. She graduated from the University of Jordan Law School and practiced as a private lawyer. Throughout her professional career, she served as the Deputy Director for the Arab Institute of Human Rights and the Director of the Palestinian Peacebuilding Program. Yula worked with USAID, Adam Smith International, the World Bank, and DFID on legal, judicial, and public administration reform projects. She also drafted an enormous number of laws and bylaws. She served as a Deputy Chief of Party to USAID projects in the MENA region on rule of law, judicial reform, as well as administration of justice. In 2004, she joined the United Nations Human Rights Commissioner Office as a Deputy Representative in Palestine, followed by 2007 appointment by the High Commissioner as a Senior Advisor on Sexual Violence and Conflicts in headquarters. In 2010, she was appointed by the High Commissioner to lead the OHCHR work on the Security Council agenda on women, peace, and security. Ms. Hadadin will speak about why trafficking in human beings for organ removal requires attention from transplant community and highlight human rights aspects of the crime. Dear Yula, the floor is yours.
Thank you, Tatiana. Thank you very much. Good morning, everybody. Sabah al-khair. Let me start by thanking the African Society for Organ Transplantation and OSC, Ms. Rudinka, for the kind invitation. So let me start by putting some key points I would like to address. First of all, trafficking in person for the purpose of organ removal is a crime and a violation of human rights, as identified by the Palermo Protocol, of course, among other types of exploitation or purposes for trafficking. Our understanding that there is a shortage of organs for transplants worldwide. Therefore, the gap between the growing demand for organ transplants and the limited supply is a contributing factor to the increased abuses in the transplant process. Some key issues which we consider as the Human Rights Office very essential is the non-commercialization of organ donations. Otherwise, a money-driven market in organs will definitely favor the rich as opposed to the poor, opening the door wide for exploitation for both sellers and buyers on equal basis. Another point we always stress is that the use of organs executed from prisoners in transplants program should be totally prohibited. Those are very essential principles we think should be applied. When we talk about a human rights-based approach to addressing trafficking in persons in general, what do we mean by that? We mean that there is an existing legal framework around trafficking in persons. It includes the international human rights framework as well, because several treaty conventions have also addressed the issue of trafficking in persons generally and for the purpose of organ removal. At the Office of the High Commissioner for Human Rights, we have developed a set of recommended principles and guidelines on human rights and human trafficking. This approach has fleshed out what do we mean by the rights-based approach, and it was meant to assist all actors in facilitating their work and looking into human rights lenses when addressing trafficking in persons. Of course, I have to admit, it has been applied to all forms of trafficking, but little has been done when it comes to trafficking for organ removal. Let me now walk you through the main elements or the most important elements. Due to the time limit, I won't be able to cover everything. But the main elements we focus on first is identification. Victims need to be identified. If they are not identified, we cannot assess the situation exactly. What are we talking about? So especially, I would claim that victims of trafficking for organ removal are the least identified among all types of victims. The second point is ensuring that we have an adequate legal framework to be able to address the issue. The human rights-based approach to trafficking demands that trafficking and the end purposes of trafficking are criminalized and subject to proportionate sanctions. An adequate legal framework.
Do you have slides to share?
No, sorry. No, I'm sorry, I don't have, but I can share my presentation later.
Fine. I thought you have a share screen. Okay.
No, sorry. But I will share my presentation later if you're interested. So, an adequate legal framework that responds to trafficking in persons for organ removal also requires appropriate legal measures to guarantee fair and transparent organ donation and transplant systems. The ethical and normative framework for organ transplantation also demands that organ donations must be voluntary. We should not pay for organs, we should not buy them. Free and based on explicit informed consent. States must prohibit organ commercialization, as I mentioned, including the sale, purchase, and the offer of purchase of human organs and tissues and cells. The third point is ensuring adequate law enforcement response. If the law enforcement is not aware of the type of crime they are dealing with, it would be very difficult for them to deal with it. So they should act with due diligence, whether the crime is committed by governmental or non-state actors. Although there is evidence that trafficking in persons for organ removal is rapidly increasing worldwide, few traffickers has been apprehended thus far. Very few cases, and I'm sure my colleague from UNODC will be able to elaborate on that. An adequate law enforcement response depends on the cooperation of traffic donors and other witnesses, especially medical professionals. In many cases, medical professionals are reluctant to cooperate with the law enforcement authorities because such cooperation may contravene professional ethical principles and standards such as doctor-patient confidentiality. We need to find a way around that to be able to assist in cases of trafficking in person. The fourth point is protection and assistance to victims of trafficking for the purpose of organ removal. We know all victims need to be assisted, including those who fell victims for organ removal, and they need to receive immediate support and protection from further harm. Maybe they will need very special medical assistance as well, because we all know that those surgeries, operations are done in not very convenient conditions. So it might lead to their health deteriorating and not being properly assisted medically. And of course, we all know it leaves immediate and long-term psychological effects on the victims. So they need psychological support, social support, and legal assistance. Many countries have established already systems and procedures to deliver services for victims of trafficking. However, these systems and procedures seldom take into account the specific needs of victims of trafficking for organ removal. Access to assistance and protective services should be made available and not conditional to cooperating with any legal proceedings. The fifth point is prevention. We all know prevention is the best cure. So trafficking for organ removal is driven and increased by the shortage in organ supply. So strategies aimed at preventing this type of trafficking shall address demand for illicit organ transplantation as the root cause of trafficking. They shall also address the factors that increase the vulnerability of people to become victims of organ removal, such as poverty and all other forms of discrimination. And the sixth point is remedies. All those who have been trafficked are victims of crime and victims of human rights violation. Therefore, they have the right to a remedy, appropriate remedy from the harm committed against them. Let me, before I conclude, I would like to give some recommendations that might help us brainstorm a little bit what should be done and what should be in place. First of all, it's highly recommended that national reviews be undertaken to assess the extent and severity of the problem. In many countries, we don't have those numbers and statistics, and we don't know what is the real situation on the ground. The second recommendation is about trafficking for organ removal should be explicitly included in the national legislation that criminalizes trafficking. So we need to have clear mention of that in our legislation. And of course, it goes without saying that enforcing these laws is very important and crucial. Third recommendation is about the prohibition of commercialization of transplants, and transplant tourism should be imposed. I guess this is very crucial because we know that transplant tourism is flourishing all around the world. A prohibition of the removal of organs, as I mentioned, from executed prisoners, and the donation of organs by persons in official custody, because they don't have the free will to give consent to the procedure. Also, I would recommend extending criminal responsibility and liability to brokers, medical staff, and legal persons such as pharmaceutical and insurance companies for their involvement in trafficking for organ removal. And it's happening, let's face it. On the ground, it's happening. Some of them are involved. I would also recommend working at the national level on building the capacity of law enforcement officials in victim identification, in adopting proactive methods to identify potential victims, because those cases are very hidden. So police, law enforcement needs to be proactive and put measures and regulations in place to help them and assist them in that. Of course, it goes without saying that providing immediate protection and assistance to victims, removing them from the danger, and providing medical assistance is very important and very crucial at that stage. Of course, last but not least, transparent regulations for organ donations, both from living and deceased donors, should be adopted and put in place. And I guess your society is working on that. I would stop here, and I look forward to the presentations from my colleagues and to the discussion and your questions, and I'm happy to answer any question after we conclude the presentations. Thank you.
Thank you so much, dear Eula. And thank you so much for particularly underlining the need to have several elements in place for effective efforts to combat THB for organ removal, including working on national legislations, looking at the issues of tissues and cells, stress and identification and protection and assistance, which quite specific assistance, which victims of human trafficking for organ removal might require, including medical ones, and also underlining the issue of transparency, because whenever there is transparency, there is a possibility to also exercise some due diligence and control mechanisms and prevent this crime from happening firsthand. Thank you so much. We're moving to our next speaker. Ms. Emma Comrie is the coordinator of the UNODC Global Action Against Trafficking in Persons and Migrant Smuggling, which is a $25 million project implemented in 17 countries from 2015 till 2023 in partnership with IOM. GLAAD supports partner countries, currently Afghanistan, Bangladesh, Iran, Iraq, and Pakistan, to strengthen their responses to human trafficking. Emma is a qualified lawyer with over 20 years of experience in investigations, prosecutions, and technical assistance in the area of transnational, organized, and international crime. She has served as an advisor to the OEC Special Representative for combating trafficking in human beings, as an investigator and crime analyst for the Office of the Prosecutor of the International Criminal Court, among other international work. She has been working on trafficking in human beings for organ removal since 2011 and is overseeing the development of the new UNODC toolkit on investigating and prosecuting trafficking in persons for organ removal, which is to be launched this year. Emma will elaborate on global action and practical responses suggested by UNODC. Emma, the floor is yours.
Very much, Tatiana, and thank you to the OEC for convening this very interesting panel, and thank you to the African Society about Transplantation for giving your attention to this very important issue, and I'm delighted to join this panel. Thank you also to Eula for her very excellent introduction. In fact, it's a bit hard to come after her because she's really set the stage and given very concrete recommendations. I think my role in this discussion is to provide a kind of global snapshot from UNODC. So in case you're not familiar with UNODC, I suspect you're not, we're the United Nations on Drugs and Crime, United Nations Office on Drugs and Crime, excuse me. Our headquarters are in Vienna, Austria, where I am working, but we have a very large field presence. So we have more than 114 field offices, which I'll show you a map of in a moment. We have the mandate and the lead in a number of different areas of criminal justice and drug-related work, including human trafficking. And among human trafficking, among the forms of exploitation in human trafficking is organ removal, which my colleague Eula has just mentioned. So our key role at UNODC is to work mainly with member states, but we do also work with civil society, professional organizations such as yours, to strengthen our global response to these kinds of crimes. So here's a map of the field offices of UNODC. The ones which are yellow are actually our regional offices, and I think the key ones for you are Cairo, where you are today, but also we have Dakar, we have the South Africa office, which covers South Africa and Central Africa, and then Nairobi, Eastern Africa. But then we have field presence actually throughout the world. One of our key flagship products at UNODC is the Global Report on Trafficking Persons. This was mandated by the General Assembly in the Global Plan of Action on Human Trafficking. The most recent report was launched on February 2021. You'll see the link to the report. The report provides a global snapshot of trends and patterns in trafficking in persons, and it does look at trafficking for organ removal. And Eula mentioned that data is sorely lacking when we're talking about these cases. And unfortunately, this is also our experience when we produce and gather data for the GLOTIP, as we call for short. The next global report is anticipated for the end of this year or January 2023. We work by asking governments to provide formal official information on cases. And we have very, very limited information on cases of trafficking for organ removal. And I think Yula has touched on some of the reasons why that is, but unfortunately, the vast majority of these cases go unidentified. And so they're not being reported as official data. And more importantly, the victims are not identified and assisted. But that being said, the most recent report from 2021 did mark an increase in the number of cases. And I think we have more than 250 cases from the last few years covering all regions. So it's fair to say that this is a crime which is impacting Latin America, North America, Africa, Asia, Eastern Europe. There is really not a region or area of the world which is not touched by this crime. So I do invite you to have a look at this report and learn more about some of the trends that we see there. In terms of trafficking persons for organ removal, what I did want to touch upon here is that from the few cases that we do have very good information on, we see that this is usually very organized crime with a high profit margin, and there can be complex illicit financial flows involved. So what we see is that there may be a victim who could also be referred to as the donor. Some people may see as a donor, but we would see as a victim someone who has been, through fraud or coercion or abuse of a position of vulnerability, has agreed to give up an organ. And the victim may be in one country, the recipient or buyer, some would say, of the organ may be in a different country, the organizer, the broker is in a third country. The actual transplant would take place in a fourth country. And what we've seen is that the illicit financial flows may go through multiple other countries before they go to the person who is actually really organizing and profiting from the crime. So this makes it complex to investigate. It really requires international cooperation, both at the investigative stage and also judicial cooperation, mutual legal assistance. That's a challenging thing to do for all countries. UNODC does have a suite of tools, and we do regularly do technical support for countries that want to engage in this kind of international cooperation. What we hear so far in our engagement with law enforcement, with prosecutors, and with judiciary is that they kind of have a fear of this crime. They see it as very technical because it has this medical component which they may not be familiar with. There's in a way kind of a reluctance to approach it, and a feeling that they would lack the skills necessary to collect the evidence for these kinds of cases. What we also see is that for police and law enforcement, they may have a difficult time engaging with medical professionals. There's a cultural bias, I think, to see medical professionals as potential offenders, but also in general, I think there could be a need for stronger cooperation between the medical professionals, the law enforcement, also, which very, very importantly is civil society. In all of the countries where there has been an effective response to these kinds of cases, usually it's been triggered by civil society, NGOs who've come in contact with victims, or who can provide the key victim assistance, which may be lacking otherwise. So we really actually stress a multidisciplinary approach in addressing this crime. It's not possible only to look at it from law enforcement, from the medical profession, or from those working in anti-trafficking or in civil society. We really, really need a joined up approach to be able to really effectively address, understand, prevent, and protect those who are vulnerable. UNODC has been working on this issue for many years. I won't go into the details here, but since 2011, 2013, there were expert working groups. There have been multidisciplinary consultations, which I've also been involved in. And we started around 2018 developing different parts of a new toolkit to address this crime. And I'll touch upon that in a moment. We were also tasked in General Assembly resolutions in 2017, 2018, and 2020, along with the World Health Organization and Office of High Commission for Human Rights, where ULA is working. So we were tasked to work together to strengthen our data collection on the issue and strengthen our support to countries to strengthen the response. some of the key challenges here, I think, have already been touched upon. As Eula mentioned, the victims in this case really have long-term needs, medical needs, psychological needs, and there is an issue here where, you know, victims in some countries may be seen as offenders, when in fact we would see them as victims. So under the human trafficking framework, where somebody has been coerced or a victim of fraud, or there has been some kind of threat or abuse of a position of vulnerability, which is a softer and more a trickier means to show, it is still possible that that person is considered a victim. And where a victim has consented to give their organ up, or a victim has consented to their own exploitation, that consent is deemed to be irrelevant, or the consent is vitiated, we say is a legal term. This is similar to other crimes, which often in many legal contexts, you know, one cannot consent to your own, you know, bodily assault, and there's other crimes like that. So the idea is that it's not possible to consent to your own exploitation, and that consent is deemed to be vitiated. And what we see so far in the cases where we do have data is that these tend to be highly vulnerable people who don't have a formal education, who are socioeconomically marginalized. They may form, you know, part of groups that are discriminated against within their societies. And they don't have regular access to good medical care. They don't have medical insurance, because of course one can live without, for example, a kidney quite well with regular access to medical care and checkups, but it's not the case often for victims of trafficking. So the cases that we're following, we see that victims afterwards do have lifelong consequences. We are developing this new toolkit. We kicked off last year with a series of expert group meetings. The toolkit will have 3 components. So it has a manual, which I'll detail in a second, with 6 chapters. It has a virtual reality component where investigators and those who want to understand the crime can actually be taken through a clinical setting that was filmed in a clinical setting. And they can understand what are the kinds of elements which are necessary to prove this crime. And then we also have interview guides and interview protocols for potential victims of the crime. The models here are still under finalization. We're a bit delayed because of COVID and other reasons, but we hope to be able to finalize it in the coming 2 or 3 months and have this toolkit available. We're looking at also potentially having it translated into Arabic and potentially other languages. It talks through some of the key issues. It goes through, there's a very heavy medical chapter, which looks at what an organ transplant should look like and how things should go, according to the correct procedures, and then also areas of red flags for concern. So for lack of time, I'll stop here and look forward to the discussion, and happy to engage with you at any other point. Thank you, Tatiana.
Thank you so much, Amy. That was a great deep dive, I would say, into more specific issues as relates to particularly challenging responses to human trafficking for organ removal, including the need for multi-agency cooperation, but also very substantial capacity building for law enforcement colleagues. And this is great to see the progress with the manual for law enforcement developed by UNODC. Also, not only mentioning the challenges as relates to, for example, new technologies, but also leveraging new technologies through the virtual reality component to help practitioners to address this pretty difficult crime. Thank you, Emma, again. And moving to our next speaker, I'm extremely pleased to introduce Dr. Beatrice Dominguez Hill, who is a medical doctor, specialist in nephrology. She has a PhD in internal medicine, and she joined the National Transplant Organization in November 2006 and became its Director General in May 2017. The National Transplant Organization is the Spanish national authority responsible for the oversight, coordination, and organization of the donation and clinical use of organ tissues and cells. Before this appointment, she chaired the Committee of the Transplantation of the Council of Europe and served as a president of the Ibero-American Network Council on Donation and Transplantation, as well as member of the WHO Task Force to promote ethical practices in the donation and transplantation of organ tissues and cells. She also previously served as a co-chair of the Declaration of Istanbul Custodian Group on Organ Trafficking and Transplant Tourism, and president of the European Donor Transplant Coordination Organization, chair of the Ethics Committee of the Transplant Society, and the Counselor for Europe for this society. She has over 200 publications and presented at numerous national and international events. Dr. Dominguez Hill will speak on the role of healthcare professionals in prevention and reporting trafficking cases. Beatrice, over to you.
Thank you. Please confirm that you can hear me well and that you can see my presentation.
We do hear you excellent, and we can see very clearly. Thank you.
Okay. So first, thank you very much for this very important session, for this very important initiative to OSCE and also to the African Society of Organ Transplantation, and congratulations for this first Congress. So these are data from the Global Observatory on Organ Donation and Transplantation that ONT develops in cooperation with the World Health Organization. And according to data reported by countries, we know that in 2020, there were close to 130,000 solid organ transplants carried out in the world. Despite this seems a very important activity, it barely covers 10% of the transplantation needs of our patients, needs that are growing as a result of an increase in the burden of non-communicable diseases that lead to the need of transplantation. And the disparity between supply and demand has very likely been exacerbated in 2020 as a result of the COVID-19 pandemic, which had a very important impact in transplantation activities with a global decline of about 18%. We not only know that transplantation is not enough to cover the needs, but also that access to transplantation is very unequal across countries. Here you have data for the GODT in 2020, where I draw your attention on the very few African countries that are reporting data to the GODT, which calls us for the need of further oversight and ensuring that registered practices, transplantation practices, are properly reported at a national level and then at an international level at the GODT. But we know that access to transplantation in African countries is very limited, as you very well know. So desperate patients are compelled to engage in legitimate transplant activities that usually have the form of travel for transplantation. They usually have transnational scope. So at the GODT every year, we inquire countries about the number of patients who have traveled for transplantation abroad. And you can see how in 2019, and I haven't used data for 2020 because this number has declined as a result of COVID, but let's say a pre-pandemic year, there were only 36 of the 82 participating countries that were able to give an answer on patients traveling for transplantation abroad. And 31 countries, only 31 countries reported more than 700 patients traveling to all the destinations for the purpose of transplantation. And you can see, if we take a look to the African region as defined by the WHO, and the Eastern Mediterranean region that covers also countries in the African continent, you can see the very important number of patients that were reported by a few limited number of countries traveling for transplantation abroad. Taking a look to African countries in detail, we can see how patients from different African countries are traveling to other destinations for transplantation purposes, either within the African continent, like to Algeria, Egypt, or Sudan, or to countries outside Africa, particularly India being a relevant destination. But there are also patients who are traveling to Africa for transplantation purposes, either from other African countries, but also from non-African countries, as is the case, for example, of patients from the Eastern Mediterranean region, for example, Kuwait. And you can see how countries of destination in Africa are particularly Egypt, Sudan, Algeria, and there is some cases reported that travel to Nigeria for transplantation purposes. So we need to be very, very much aware that we're just seeing the tip of the iceberg of the movement of patients across jurisdictions. And of course, we also need to take into account that not all travel for transplantation is illegitimate. We know that there are legitimate reasons for many of those patients traveling for transplantation abroad: personal or family reasons, financial reasons, unavailability or limited access to transplant services in the country where they live. But what we need to promote is avoiding unethical travel for transplantation, what the Declaration of Istanbul has defined as transplantarism. This would be travel for transplantation that entails either human trafficking, as very well defined previously, or organ trafficking, the buying and selling of organs, or when travel for transplantation undermines the ability of the country of destination to provide transplant services to its own patients. But today, we're going to focus on this form of transplantarism and the way healthcare professionals can prevent and can help to combat these practices, either when they occur locally within a given setting, a given jurisdiction, or as we have seen, when this occurs in a transnational framework in the form of transplantarism. So there are a number of guidance documents that have been provided by different international organizations and professional societies about what can health professionals do to avoid, to prevent, and to combat trafficking scenarios. And I would like to highlight that they are very coherent between one another. It's important to understand what are the underlying principles behind this guidance. We as healthcare professionals and as authorities, as transplant systems, have three fundamental principles to highlight, many others, but I think it's important to focus upon these three principles. We owe transparency to the community because they donate organs, live individuals, deceased individuals. We owe them transparency on the number of activities, the allocation of organs, and post-donation and post-transplant outcomes. We have the duty of traceability. We need to locate an organ from donor to recipient and vice versa for transparency and for safety issues, for example, when there is a risk of disease transmission. And we have the duty of continuity of care when a patient is transferred from one transplant center to another. And these principles should be applied to transplants that we performed locally in our country, or also should be applicable to patients who receive a transplant abroad. So having these principles into account, let's put ourselves in three different scenarios where healthcare professionals can face potential victims, recipients looking for or considering buying an organ, or engaging in trafficking scenarios, or situations where professionals could react some way. So the first scenario would be that of the patient who needs to travel or is planning to travel for transplantation abroad. So it's important, and let's focus just in travel for transplantation in the form of living donor and a recipient pair. Ideally, this should be performed and organized in the framework of international cooperation programs or formal arrangements, at least between a reference center in the country of origin and the destination center in the country of destination. So it's important that before live donor and recipient travel, the validity of consent is in origin evaluated by a specific physician. Pre-donation and pre-transplant screenings should also be performed before donor and recipient pairs travel for transplantation. We should ensure the coverage of these procedures, and of course that this donor and recipient would have some follow-up care upon their return, and that transfer of care is well organized with the transplant center abroad. So all these elements are essential in this scenario. We can also face patients who are considering to engage in trafficking scenarios, and our duty would be to counsel our patients. And I draw your attention on this leaflet that was produced by the Declaration of Istanbul Custodian Group. We need to inform our patients on the consequences of engaging in trafficking scenarios, because we know that illegitimate transplants are more associated with death, graft loss, surgical events, infections, among others. It may have financial consequences for the recipients as well. They should also be informed of the health and psychosocial consequences for the donor victim, because as health professionals, we also have a duty, a legal and moral duty to organ donors, victims, and to the health of others. And we should inform our recipients on alternative ethical therapeutic options. Needless to say that we should never take actions that facilitate an illegitimate transplant procedure. Second scenario, we evaluate a prospective donor-recipient pair, but we have standards like the KDIGO guidelines that tell us that we need to evaluate potential donors, not only from a medical point of view, but also from a psychosocial point of view. We need to ensure that consent has been voluntary, that there is no coercion at all. We need to be especially careful with non-resident live donors and vigilant for red flags. And there is a long list of indicators that we have produced to help you identify situations where you can suspect you are facing a victim of trafficking. And it is very important that in these circumstances, those cases are reported to law enforcement agencies.
Yeah, Beatrice, 2 minutes as you requested.
Thank you. I'm finishing. So the third scenario would be the patient who returns after transplantation abroad, and the 3 magic words would be care, register, and report. We have the duty of caring. That's our primary duty, regardless of whether the patient purchased an organ abroad. Always in emergency situations. In non-emergency situations, we may consider to transfer the care of our patient to another physician, but we need to care for these patients even if they purchased an organ abroad. It's important, nevertheless, that authorities and insurance provider never cover the cost of transplant procedures that involved trafficking scenarios. But again, patients should be provided with the necessary care upon their return, and cost of follow-up treatment should be covered as for any other transplant patient, but subject to the registration of the relevant information at official transplant registries. This is graphically represented here. Ideally, and we're not sure how this is working in African countries, when a transplant procedure takes place in a hospital, this should be reported to the national authorities and information included in a national transplant registry. But when a patient travels from country A to country B, the procedure should be registered where transplantation has taken place. And when the patient returns, ideally, it should be recorded also in country A. If we make the effort, which is necessary, oversight, registration, monitoring, we would be able to provide or to fulfill those principles of transparency, and contributing to the GODD, we will be able to identify situations of patients moving across jurisdictions that could give us some clues about cases that, as we have heard before, are very difficult to identify. And finally, governments and relevant stakeholders should work to create a framework and mechanisms to allow health professionals to communicate information on trafficking cases to law enforcement agencies. We can discuss whether voluntary, mandatory, non-anonymized, anonymized, but what it is very important is this mechanism should protect vulnerable donor and recipients, but also professionals that may be at risk if they report cases. And of course, our intention will be to prosecute participants. I draw your attention on this statement of the World Medical Association released in October 2020 that considers that reporting of trafficking cases should be a permitted exception with a physician's obligation to maintain patient confidentiality. So now we're in a position of modifying our ethical codes of practice according to this clear statement by the World Medical Association. So let me finish by saying that health professionals and authority can now turn a blind eye to the need to regulate travel for transplantation and to prevent and combat these trafficking scenarios. It is our duty to participate in finalizing with crimes that tarnish the magnificence of transplantation practices. Thank you for your attention.
Dear Dr. Dominguez-Hill, thank you so much for your very intense and interesting presentation, highlighting the current data available in your registry, and particularly underlining the shortage of organs, which is really a driving factor for having such issue as trafficking in human beings for organ removal, and also extensive travel for transplantations abroad, which we should pay double attention to. Of course, it's very crucial to have the uniformity of the guidelines, which you underline that we have it at the international level, at the professional level, and this is already a huge initial step to have a common understanding and common approaches to tackling these issues. And also thank you for highlighting the practical steps which medical community can undertake at the national level, and more specifically even at the hospital level, to combat this form of human trafficking. Now we will hear about a national example of the work conducted to prevent trafficking in human beings for organ removal in Bulgaria. Asya Paskalev is a founding director of the Bulgarian Center for Bioethics. She has expertise in biomedical ethics, moral philosophy, applied and professional ethics, including research ethics, food ethics, the ethics of biotechnology, ethical theory, and social and political philosophy. She has received her PhD in applied philosophy from Bowling Green State University in the United States, and held faculty appointment at Howard University, American University, and the University of North Florida in the USA. Her current research and publications focus on the ethics of organ transplantation and the ethical challenges of digital technology in healthcare and health research. Since 2007, she has led multiple research groups exploring the ethical challenges of living organ donation and the efforts to prevent trafficking in human beings for organ removal. Since Ms. Paskalev is now in the United States and it's midnight for her, she sent us the video address, and I would like to check with organizers if we can demonstrate the video address from Dr. Paskalev. Dear Gamal colleagues, are you able to demonstrate the video address? If you prefer, I can also try and share my screen to demonstrate her video. Can you please let me know? Yes, thank you. I am afraid we don't hear the
overview of our efforts as an NGO located in Bulgaria to combat human trafficking for the purpose of organ removal in the country. First, I would like to give you just a little bit of context about the country. So if you would allow me to share my slides here for just a second. There you go. So I would like to start very briefly with an overview of the cultural, historical, geographical profile of the country. It is one of the, it's situated, Bulgaria is situated in Southeastern Europe, and it was founded in 7th century AC, bringing together ancient tribes from the Caucasus, as well as local Thracian and Slavic tribes. It has very diverse and vibrant culture with Slavic as well as Ottoman and Roman influences. And today it's one of the youngest members of the European Union, joining the Union in January of 2007. Now, the more recent past of Bulgaria has been marked by certain challenges. In the 20th century, Bulgaria for 40 years was under totalitarian rule by the Bulgarian Communist Party. In this process, Bulgaria was heavily influenced politically by the Soviet Union, And it also, one of the consequences is that the country underwent forced industrialization, which really changed the profile of the country. So as a result of these developments, Bulgaria today has some kind of concerning numbers in terms of its economic development. It is the poorest country in the EU and the sixth poorest in Europe. The GDP of the country is 1277 euro. 65% of the population struggles to meet their daily needs and expenses. For several decades now, Bulgaria has a negative population growth, partly due to immigration, brain drain, but also because of, just difficult socioeconomic conditions that people don't find very conducive to having children. So families usually have one, maximum two children, and we have an aging population overall. On the other hand, not surprisingly, there are relatively high levels of corruption and high levels of organized crime in the country. And correspondingly, there is low level of trust in the government, the various institutions, political parties, as well as police, and in healthcare workers. So it is within this environment that Bulgaria becomes a fruitful ground for various forms of human trafficking. So it was noticed by the European Commission in its report Together Against Trafficking in Human Beings that Bulgaria remains a country of origin for victims of various forms of human trafficking. Most commonly, this is forced labor and sex trafficking, but also there are instances of trafficking for organs, specifically for organ removal and organ transplantation. And although these are less frequent, they have been noted since at least 2003. Apparently, the issue became particularly prominent during the difficult socioeconomic transition from the socialist state control economy to the free market and the loss of income and loss of infrastructure and social support systems in the country in the late 90 and early 2000 year. So as a result of that, there have been numerous reports of cases, instances of trafficking of human beings for organ removal, and the government hasn't had very efficient ways or methods or strategies to address this problem. So, for instance, even just looking back 2 years ago, in February of 2020, we heard news about 5 suspects arrested in Turkey for participating in an organ trafficking ring between Bulgaria and neighboring Turkey. So what happened there was that a clinic in a private hospital in Turkey was the location of the illegal transplantation surgeries. The donors, however, or we could probably more properly call them victims, both the recipients and the victims were Bulgarians who were paired outside the legal framework, outside the legitimate transplant system in the country. They were paired by a 55-year-old person who was arrested in Turkey for her activities, a woman, who was working at a branch of the Turkish clinic in the capital of Bulgaria, Sofia. So the woman would identify people in need of an organ transplant. Then she would identify poor Bulgarians that would be willing to donate their organs. She would match them. She would, with the help of this network, they would provide them with forged documents, and they would be transported together to Turkey, where the illicit activity would take place, the rest of the activity would take place, and then they would return to Bulgaria separately. So Bulgarian law requires that living organ donors are only people who are related. And also, this is the same in Turkey, but there you could have unrelated organ donation, provided it goes through a committee approval. So in order to satisfy the requirements, these papers were forged and presented. The individuals were falsely presented as relatives. The other shocking example that's even more recent took place in June of 2021. A Bulgarian Ministry of Health actually confirmed that within the last several years, 14 illegal kidney transplants have been performed at a state hospital. In that case, all kidney donors were poor individuals who were presented as nephews, relatives again, from Ukraine and Moldova, some of the poorest countries in Europe. And all the recipients who were presented as their rich relatives or uncles came from countries like Israel, Japan, and Oman. So what happened was that the wealthy recipients received the kidneys using false identities in Bulgaria, in this state hospital. And this was the first occasion where the illegal criminal activities were actually confirmed by the government. And what you have on the slide there is the Minister of Health at the time who gave a press conference announcing these findings. So what could an NGO do in a country to help a country that is a target for various forms of human trafficking, and especially in the case of organ trafficking? Our NGO has a focus on research and policy making as well as education. So we have been working in two directions there. On the one hand, we've been trying to support efforts to combat organ trafficking in its various forms. And on the other hand, we've been trying to support and work in line with this effort to promote and strengthen organ donation and organ transplantation in our country, because we see these two, preventing trafficking and also enhancing and improving the local transplantation system and structures as the two sides of the same coin, and they're both crucial in order to stem out or at least minimize and hopefully prevent human trafficking for the purpose of organ removal. Now, in terms of the combating human trafficking, we realize that this problem is way too big. It goes beyond the capabilities of a single NGO. It looks like it's beyond the capabilities of a single country and a single government as well. So what we did there was we identified partners across Europe, within the European Union, and we engaged in research, awareness, advocacy, and policy making in a consortium with them. We were able to secure funding through the European Commission in order to conduct our activities, and we were able to gain a deeper understanding of the various, modus operandi of the various actors. We looked at specific cases and attempted prosecutions of specific instances of organ trafficking in Europe. We also looked at the ethical and legal frameworks for these that could prevent such activities, what is in place, what needs to be done. And we also ended up developing a set of indicators to help both law enforcement officers, but also healthcare providers, NGOs, and any stakeholders identify human trafficking and prevent it. So we've been also developing tools to train law enforcement, to train healthcare providers in this direction. On the side of promoting and strengthening the national organ donation system, we again engage in an international multi-country effort in this direction. We partnered with 12 other leading institutions across Europe. Some of them were medical centers, such as Erasmus Medical Centers. Others were leading European educational academic institutions, as well as legal scholars. The Central European University was one of our partners. And so we engaged in what is known as a multi-country coordination action. We conducted research and inventory of the living donation practices in Europe, similarities, differences, attitudes. We conducted several focus groups in Bulgaria, as well as in Belgium, Romania, and Estonia. We looked at ways in which the different countries explore and promote living donation practices as a mechanism to lessen the pressure on the healthcare system. And also we looked at ways to develop tools to help improve the quality and the safety of living organ donation, again, as a factor helping and minimizing the need for illegal organ trade in the country. Now, along the way, we experienced some challenges as well as some identified opportunities, and I would like to share with you some of our conclusions or lessons learned. One of the main, the main conclusions of our efforts and our work has been that combating organ trafficking is a very, very major undertaking, and it's a challenging, basically it's a very, very challenging goal. This is because organ trafficking itself, and I should say human trafficking for the purpose of organ removal, of course, because organs rarely travel by themselves, right? So the terminology there has to be probably more precise. But we're faced with complex causes. This is a phenomenon with very complex mechanisms. Some of the causes are medical, other are legal, certain loopholes. There are socioeconomic and cultural aspects to it as well. And again, the factors or the causes operate on various levels in terms of individuals, groups, the nation, as well as global. There is global factors, global dimensions to it. Of course, one of the primary causes that all kind of scholars agree upon is organ scarcity. It's an obvious one, but it goes hand in hand also with the lack of a developed transplantation infrastructure in a given country and region. And of course, there is the psychological, the human desperation, which comes with, end-stage renal disease, with very long waiting lines for transplantation, and the lack of donors. Of course, we could look at the broader causes, the macro problems such as the prevalence of chronic disease due to lack of adequate health care or poor health habits among the population, especially in Bulgaria. We also have, none of these, of course, would really matter if there were no bad actors and organized criminal networks willing to create and support a black market for organs. So this is what also makes this criminal activity possible. We should pay special attention to socioeconomic inequalities at the local and global level as a cause and risk factor for this type of trafficking. And another contributing cause is the corruption and lack of resources to actually prevent and combat the trafficking of organs and human beings for organ removal. As a rule, the resources are insufficient. The country and the government do not provide sufficient support or funding for educating stakeholders, for training, for publicizing the activities, and so on. Now, there are also certain important barriers that we need to keep in mind and work together to overcome. The first one is lack of information about this type of trafficking. It is hidden, it is difficult to identify, it is difficult to track, it's difficult to prosecute, and it is a lot of the cases actually are not brought to a successful conclusion. There is also lack of knowledge about the indicators, how to recognize when an illicit activity is being organized or about to take place. And it's very important both for law enforcement and medical professionals to to be informed and trained in the indicators and to be able to respond not only to suspected cases of organ trafficking, but also to respond to suspected victims and to provide the necessary care there. And of course, there is the legal aspect of this effort, namely that we are dealing with an international crime, a cross-border crime and networks. And so to some extent, they are very often extrajudicial actions that they're making it even harder to investigate and prosecute. So before I close, I would like to acknowledge my colleagues and the people who have been supporting our efforts on the side of the Bulgarian Center for Bioethics. This is at the top my research team, and then at the bottom you see the governing advisory board for our institution. So in conclusion, I would like to just note that we are cognizant of the fact that trafficking for for organ removal is a very difficult problem to tackle. It requires complex measures. It requires cooperation from all levels of both, the government and civil society. It is very important to address all possible loopholes, but also the socioeconomic conditions of our countries that make them source countries for any form of human trafficking, including for organ removal. It is crucial also to develop and strengthen the systems, the national systems for organ donation and transplantation, and to partner with NGOs in the fight against this serious crime. I thank you very much for your attention and would like to leave you with my contact information and to wish you success in your important endeavors. Thank you very much.
I thank Dr. Paskalev and for this interesting presentation, and I hope that helped our audience to get some insight on into how trafficking in human beings for organ removal looks like in real situations, and also how it thrives on vulnerabilities and the need for resources and capacity building and more intense efforts on behalf of the governments, but also all of us, including civil society and academia, in combating this crime. As I understand, we are a little bit beyond the limit of the session. So, dear Gamal, do we have any burning questions to the audience?
Thank you very much for all the speakers, and it's true we are beyond the time, but the subjects and the data given are very stimulating, and we can have 5 more minutes for some comments. The first to Yola is that about the source of cadaveric donations. Is it internationally made on a national level, meaning that donors from a special country would donate only to the citizens of that country? Or it is, as frequently encountered in many centers, that they would have a cadaver from a foreign nationality? And if so, why don't the WHO adopt a transfer or organ sharing from a foreign cadaver to, for example, to share one of the kidneys to the original nationality? This would up-regulate the programs in other countries which don't have this program, and initiate cadaveric program in these countries. Your comment about this, please.
Tatiana, shall I go ahead?
Yes.
Please do.
Okay, thank you. Thank you very much. And I've been talking about building transparent transplantation systems locally. Let me just say one thing before. We all know, or it's obvious if you look at the flow charts in the global UNODC global report, you would see that the flow of cases is from the south to the north. Mainly people would give their organs from the south, poor people, to much richer countries. And of course, let's not forget conflict zones, conflict situations, and post-conflict. We have seen, for example, in the Middle East, a lot of cases of refugees, displaced people from different countries of the region going under conflict, being victims of trafficking. And I'm not an expert on transplantation, but as a human being, as a citizen, I would imagine the country needs to build a national system for transplantation first before going and donating organs to other countries. You need to fulfill the needs of the people in your country. I know it happens. I know a lot of people who had traveled abroad to get an organ legally, of course, not through trafficking, or they went taking a relative, a son, a daughter to another European country to perform the operation because of
I'm not speaking about this. I'm speaking that if a cadaver, for example, any worker who is a foreigner working in that country, not of the same nationality, and
yes,
sometimes he is considered a source of organs. I'm speaking of that category. Why don't we share the organs with the original nationality of his country?
Dear Gamal, I would suggest we also offer a chance to reply to this question to Dr. Dominguez Hill, because she is exactly the specialized in this area, probably better than Ms. Haddadin.
Yes, exactly. But let me just add, of course, if he's a resident of the country, why not? He benefits from the health system and he should be part of the system. But of course, I would refer it to Dr. Dominguez because she should be the expert on that, not me. Thank you.
No, I just want to, first I want to say that your answer was perfect. But I just wanted to stress that the WHO has provided guidance on this. And what the WHO says is that every country should progress towards self-sufficiency in transplantation, which means that every country should make efforts to satisfy the transplantation needs of the resident population. Now, if you have people from other countries living in your country, for logistical reasons as well, because of ischemia time and whatsoever, the logical issue is that organs that are donated in a given jurisdiction are allocated in the corresponding jurisdiction. That's the logical way to go. However, we are very much aware that countries may take time to develop their own transplantation system. And the ideal situation would be that they engage in official cooperation agreements with other countries in order to organize in a proper and ethical manner either the transplantation from live organ donors or transplantation from deceased organ donors. You need to take into account that not even the countries with the most robust transplant systems are self-sufficient. Self-sufficiency is chimera, is an utopic goal, but this should be our aim working in transplantation. So I don't think the solution for any country is that you take organs from your citizens who die in other countries. I think that is unrealistic in my personal point of view, though I take your point. But the most important thing is that every country makes efforts to build their own transplant program, and there are even economical reasons to do so, because most countries are investing in dialysis, and we know that kidney transplantation provides better results and cost less. So there are many reasons why, if governments want, governments may support the development of a transplant program in low middle income countries, countries with no transplant program, and that's the way forward. We need to build the way that low middle income countries may develop their system and may progressively approach that situation of self-sufficiency. I think Eula said it perfectly, but I want to stress that we do have documents from the WHO in this regard.
Yes, your point is well taken, Beatrice, please. Let me ask you, Beatrice, that in a couple of your slides, you demonstrated that there were trafficking to Egypt for transplantation as donors, and the opposite, the transportation of donors from Egypt otherwhere. Do you have official reports about transport of donors from outside Egypt to Egypt, so that we can investigate it? Because if you have these official reports, you need to deliver it to us officially, because we will deliver it immediately to the Attorney General, the administrative supervision oversight, and the medical syndicate to investigate it. We had previous examples by reports coming to us from the ISODP, from Francisco Del Monico, sure you know him, Faisal Shaheen, and but in that situation, recipients were traveling to transplant in Egypt from probably illegal Egyptian donors, and these were investigated, and they were an immediate action were taken, and we have examples of several trials. So I'm
very much aware, but I need to clarify something. So here, I try to say this very clearly. Here we have representation of patients traveling for transplantation. In the case of Egypt, patients traveling for transplantation to Egypt or from different locations. But as I said before, in the GODT, what we collect is aggregated data on patients who travel. This may be proper travel for transplantation or not, we don't know. We just describe the movements of patients, and we don't have.
We need official reports of proper data of those, not only traveling.
Of course, but please bear in mind that Egypt is not even reporting their transplantation activity to the GODT. For years, we haven't received any report from Egypt to the GODT. So the first thing that we should know is the volume of transplantation activity in your country, but it happens with other countries as well. I don't want to point out to any country.
On your slides that Egypt is a source, and receiving foreigners for organ donation, this is a very serious consideration.
Absolutely, that's why I showed the slide.
We need to have very official reports and send them to me, or delete this slide. Either you send me the documents to investigate, or delete the slide including Egypt. You should have it either way. Send me the.
No, but please, what I showed there is what countries have reported of patients traveling for transplantation. You have seen Egypt, you have seen Sudan, you have seen Algeria, you have seen many destination countries. This does not mean that this is unethical travel for transplantation. These are data that countries reported about patients traveling for transplantation abroad. There are no individual data, they are aggregated data. We are not trying to point out to any country, we're just describing the movement of patients.
That's fine.
So this has been officially reported by countries, but in an aggregated manner. I'm very pleased to provide this information to you, so you can work with that information in
about all this. If you give me the reports, you will be collaborating together to
absolutely. I will be happy to do so.
I will be happy to receive any official data.
Hello.
And documents. Professor Dina Al-Bashir will have the last comment from Sudan.
I would like to also add my word to Professor Jamal. I'm Dina Al-Bashir from Sudan, and I'm the Secretary General of the Sudanese Society. So I'm not aware of trafficking in Sudan. We're very, very strict about trafficking. We even had a law, and it's not allowed. When we heard that some people wanted to travel, it was stopped by the Ministry of Justice. So I will require from you documents, or you delete the slide. You do not spoil the reputation of both our countries. Seriously, I'm talking to you seriously. You cannot take a paper, write it down, and just talk about our countries in such a way. When we are fighting,
I'm sorry. I'm trying to be very respectful.
Can I finish what I'm saying?
Yes, but let me explain that this is an official data collection carried out.
Let me finish.
Beatrice, let's wait.
Out of politeness, let me finish, please. You can't sit down, write a paper, and write publications when I am somebody who presented transplant data on Sudan, and I'm telling you seriously, we took it very seriously, just like Dr. Jamal said. We are fighting trafficking. Are you aware that in Sudan, we only have live related donation? And even when we passed the law in 2012 for emotional donation, we found that some people actually lied and tried to traffic within Sudan. We had emotional donation for people's, it was very, very restricted to people who did not have donations, donors who could not travel abroad because they could not afford to travel abroad. So if his neighbor or a very close associate offered to give it without money, we were allowed it. When we felt it could be abused, we stopped this law. So do not talk about our countries unless you have exclusive data. End of story.
Thank you.
May I just please, as a moderator of this session, Beatrice, sorry.
I will give you a chance, Beatrice, to answer. We'll give you a chance.
I need to say something.
To me, please.
Yeah. Give you a chance after the comment of Ines.
Thank you very much, presenters. That was eloquent presentation. I'm coming from Tanzania, and I want to say that we have this problem. This is the benchmark of poverty, ignorance, donor pool legislation, and we cannot fight it alone. A lot of stakeholders and multi-sectorial should be approached. I will request you to extend the horizon to Tanzania so that we can work together to combat this open crime. Thank you very much.
We need at last to share official documents and reports to have it on the international level so that we have proper true data to be analyzed. I think we are much overhead time, and I thank you all for the excellent session and very stimulating, and hope you join our program. And one of the important sessions today will be targeting xenotransplantation and organ regeneration by our colleagues from USA and by Sir Magdi Yaoub. It is in the program, and please keep joining us. Thank you very much for the session.
Thank you very much, dear colleagues.
Now we to the symposium by Sandoz, and it will be presented by Dr. Abir Halim. He will address the topic of MMF clinical outcome in kidney transplantation. Dr. Abir, please.
Okay. يمين وشمال لكن كبوينت عن نفسه. Thank you for being with you. Thank you, Dr. Jamal Saadi, Dr. Maya Hassaballah. I will talk about mycophenolate mofetil, new generic. We want to discuss application. First, mycophenolate mofetil is a prodrug of mycophenolic acid developed to improve the bioavailability of MMF. As you know, mycophenolate mofetil or mycophenolated sodium by metabolism will produce, it's a prodrug to induce mycophenolic acid, then mycophenolic acid ingredients to be excreted in urine. This to remind you with the pathway of metabolism of mycophenolate sodium mycophenolate mofetil. MMF therapy is associated with significant reduction in acute rejection versus standard therapy. As you know, standard therapy is first in the initiation of transplantation were based on corticosteroid and and CNI, and then developed to add anti-proliferative. And since addition of MMF therapy as anti-proliferative for the group of anti-rejection therapy, then the rejection episodes come down and reduced. MMF is associated with a significant lower acute rejection rates compared to azathioprine. As you know, azathioprine is the first anti-proliferative anti-metabolite drugs that used with corticosteroids and CNI. When we shifted from azathioprine to MMF, there is less incidence of acute rejection, less episodes of and better graft survival. MMF therapy is associated with significant improvement in graft survival. Also, as you know, mycophenolate mofetil adding benefit regarding episodes of acute rejection when substituted with instead of azathioprine. Not also that, but also add benefit regarding graft survival. So it's better to use MMF than azathioprine as proved in the study regarding survival. So to conclude, mycophenolate mofetil therapy was associated both with better short-term to avoid acute rejections and on long-term basis as prolonging graft survival. It's a recommendation to use MMF rather than azathioprine. Next, what's the guidelines for immunosuppressive therapy regarding kidney transplantation? Initial maintenance, as you know, including CNI and anti-proliferative agent with or without corticosteroid. Then we suggest tacrolimus be first line CNI used rather than using cyclosporin, as you know. Lastly, we suggest mycophenolate be the first line anti-proliferative agent. These guidelines evidence to be in we use mycophenolate mofetil rather than azathioprine according to the KDOP guidelines. Next. What about MMF? First line drug for the solid organ transplantation. It's approved in 1999. First approval of FDA approved mycophenolate mofetil, first line drug for solid organ transplantation. And now nearly all cases use MMF rather than azathioprine. We see that about 80% of kidney transplant and 50% of liver transplant, 75% of heart transplant, all of these recipients are on mycophenolate mofetil rather than on azathioprine. So MMF is now considered as a member of many different or even all protocols of immunosuppressive therapy. Popularity of mycophenolate is partially based on its reputation as a drug associated with little and least manageable toxicity. As you know, it's safe and with less side effect rather than azathioprine. So what about European Association of Urology guidelines in 2020 on renal transplantation? Mycophenolate mofetil is recommended by European Association of Urology guidelines with a standard doses of, as you know, MMF 1 gram twice daily, or enteric-coated mycophenolate sodium is 720 twice daily. Tacrolimus has no evidence on mycophenolate. As you know, tacrolimus does not affect a level of MMF, but cyclosporin, as you know, may increase the toxicity, and we have to reduce the dose of MMF. Recommendations: perform initial rejection prophylaxis with combination therapy of CNI inhibitor, preferably طبعا التacrolimus, add on mycophenolate mofetil, steroids and induction agents. Recommendations: strong evidence that we have to administer mycophenolate as a part of initial immunosuppressive therapy, as you know. MMF clinical outcomes in de novo kidney transplant patients. MMF and comparison between mycophenolate mofetil and enteric-coated mycophenolate sodium therapeutically equivalence in de novo patients. It's a trial
trial, multi-center randomized double-blind 12 months parallel group trial with a 2-year open-label extension. It's done on 30 centers in Europe, USA, Canada, and we, as we see, enteric-coated done on about 1,440 patients, and we're using enteric-coated. As you see, 2,000 we're using MMF. We found that there is no difference, and there was therapeutically equivalent results between enteric-coated and the mycophenolate sodium. It was equal results. So MMF and enteric-coated mycophenolate sodium, it was therapeutically equivalent in de novo renal transplant. Regarding, as you see, episodes of graft biopsy-proven acute rejection. Regarding biopsy-proven acute rejection without graft loss. Regarding biopsy-proven chronic rejection or even graft loss. We see that the results of the study found that there is no significant difference between mycophenolate mofetil and enteric-coated mycophenolate sodium regarding all of these episodes. Also, regarding any adverse effect or severe side effects or any infections, we, as regard our comparison overall safety or tolerability of MMF versus enteric-coated mycophenolate sodium, were comparable in de novo patients. You see there is no difference between enteric-coated and mycophenolate sodium regarding toxicity or any infections or any adverse effect. So to summarize, to conclude, according to the European Association of Urology, that both mycophenolic acid formulation, either MMF or enteric-coated mycophenolate sodium, are equally effective with an almost identical safety profile. There is no difference between mycophenolate mofetil and enteric-coated as regarding safety. So what about Sandoz mycophenolate, new mycophenolate produced by Sandoz? We see the bioequivalent studies, first with Celcept. This study randomized open label 2-period 2 treatment to crossover study. It was a crossover study done patient using Celcept, then shifted to mycophenolate mofetil, and it was as the results proved that there is no difference, and there is no any differentiation. We can't differentiate using MMF of Sandoz or that of Celcept, and the conclusion that in efficacy results were equivalent. Also, regarding the safety, both formulations were well tolerated with no major adverse effect. No relevant differences in safety profile were observed between preparations, particularly with respect to the number and pattern of adverse events. Pharmacokinetic, based on these results, it can be concluded that the test mycophenolate mofetil is equivalent to the reference Celcept, following a dose of 500 twice, 2 tablets of 500 milligram twice daily in fasting conditions. What about comparison of MMF Sandoz to the enteric-coated mycophenolate sodium? We found that enteric-coated mycophenolate sodium is therapeutically equivalent to mycophenolate mofetil of Sandoz in de novo renal transplant as regard biopsy-proven acute rejection or biopsy-proven chronic rejection. There is no difference between both groups, so the efficacy comparison was equivalent. Enteric-coated mycophenolate sodium is therapeutically equivalent to mycophenolate of Sandoz regarding safety comparison. Regarding any adverse effect or any infection, the episodes or events of infection, it were equivalent. So we have to know that Sandoz MMF is FDA approved, approved in the last 2008, and start to be used in 2009 in the market. FDA approved mycophenolate of Sandoz. Next, transplantation guidelines support generic use. This is the guidelines of KDOQI guidelines, improving global outcome. KDOQI Transplant Work Group clinical practice guidelines recommend the use of generic immunosuppressant to reduce the cost. As you see, that generic products approved by US FDA to meet rigid standard. السبستيتيوشن فور بريدنيزولون الجايد لاينز تقول ان بريدنيزولون وازاثيوبرين and miclophenate mofetil can be undertaken with confidence that efficacy will be maintained without increased harm as they are not narrow therapeutic index agents. Then Sandoz, your trust transplant partner. Why Sandoz are our trusted transplant partner? As you know, strong heritage in transplantation. Sandoz has over 40 years experience in transplant care. Next, Sandoz and Novartis offer a broadest range of transplant medication in industry. Sandoz also is continuously investing in new and innovative solutions in transplant care. Every now and then, there is a new medications produced by Sandoz. Lastly, Sandoz developed and launched Adbort. This is the first generic tacrolimus in the market, and it was proved that it's very effective and there is no difference between it and between the original. This is an experience add to the benefit of generics. Last slide is to why we use generics, why the guidelines support the use of generics. Definitely we will add benefit regarding cost. As you see, if the patient insured Medicare Part D payment, we will see that the reduction in the cost will reach to 50% if we use generics of tacrolimus, and if we use generics of mycophenolate, we will see that the reduction of cost will reach to 60%. Also, patient out-of-pocket money, if not insured, we will save money up to 70% if we use generic tacrolimus, and if we use generic regarding mycophenolate mofetil, we will reach up to 80% reduction of cost regarding generics. This is why the guidelines, this is why our country, this is why all of the world tend to use generics and put it in the guidelines to save more money and to promote use of generics. Thank you, Dr. Gamal.
Thank you very much, Professor Oghr, for your very comprehensive presentation. And actually, the financial issues is a very important issue, but we need to have as well long-term evaluation studies, probably the 3-year and 5-year patient survival and graft survival. This will add more power to the use
in
of
our
generics.
country, but it's approved FDA in 2009.
You have 5-year data
by FDA.
You have 5-year graft survival.
FDA.
5-year.
5
1
year.
year. You have 1 year.
1 year. Yes.
1 year.
Study can 1 year or 2 years.
I need
extension.
When we reach the 5-year graft survival, we will be more supportive to this. Actually, there are important data mentioning that de novo use of the Adbort is better than the original concerning graft survival, particularly in the liver, and with a hazard ratio of 0.6. In the kidney, the de novo versus the original almost equal and marginal better data, probably because these patients are under high observation and more adherence because of the putting them in a new study. But we need to have long-term data.
We observed also we need little dose or smaller dose of Adbort
regardless of the dosage. It will be dependent on the trough levels and so on. But I mean, de novo data are better than switching, so as not to disturb the blood levels. And the data for the liver transplantation indicate that de novo use of the Adbort gave better results. I don't know the exact explanation, but this is what is present. Thank you very much for Sandoz and for Dr. Oghr Halim, and let us go to our prayer immediately. Thank you very much. important session in the afternoon, which will be from 3 o'clock to 5 o'clock. This session is including novel approaches in kidney transplantation, and we will be privileged by distinguished speakers from the United States. They will give us the topic of robotic platforms and recovery protocol for kidney transplantation, and a very interesting talk about xenotransplantation. Are we there yet? Because we have very good options of having humanized organs and the use of the small incisions to improve outcomes in kidney transplantation by Dr. Mohammed Al-Tamami. And at last, but never least, we will be privileged and honored by a presentation by Sir Magdi Yaoub, a very well-known figure to all of us, and he will give us his talk about left ventricular assisted devices, from these devices to regeneration of the heart and valves. It will be a very interesting session, and I hope you will be attending and listening to this very important session. It will be the one after the coming session. Dr. Hussein, اتفضل.
ده انا استنى ما تعملش تايمر، اعمل لي تايمر الاول. تصدق انت ما صدقت يا سيد؟ لا بقى اتكلم عليهم. زي امبارح عاملها فين امبارح؟ يلا. I would like to thank my dear professor Dr. Gamal for his kind words and for his kind invitation for me, and I want to congratulate him for this very successful conference. I would like to thank Utopia Company for their kind invitation for me to speak about a very important topic, which is revision of the European Society of Cardiology and European Society of Hypertension guidelines in management of hypertension. مش عايز اتحرك ليه؟ مش عايز اتحرك. طب اعمل لي بقى الوقت يعني مش كده. Okay. My agenda, I'll speak today about the prevalence of hypertension worldwide in Egypt and in Egypt, complications of uncontrolled hypertension, guidelines, recommendations for treatment of hypertension, what should be initial therapy for newly diagnosed hypertension, monotherapy versus dual therapy, valsartan, amlodipine, and what about their role in control of brachial and central blood pressure, prevention of target organ damage, safety for long-term use. As you know, as the prevalence of hypertension worldwide in Egypt, it estimates about 31.1 of adults, about 1.39 billion over the world had hypertension in 2010. The prevalence of hypertension among adults was higher in, of course, low-income population, 31%, while it was lower in the high-income countries, 28%. The prevalence of hypertension in Egypt ranged from 12.1 up to 59%, and the adherence to antihypertensive medications is very low, is less than 51.9%. As we can see, this was the number of population that hypertension in 2000, about approaching 1 billion, which is projected to be 1.56 billion at 2025. As we know that, what is the problem with hypertension? Complications of uncontrolled hypertension, as we know, it increases all-cause mortality, cardiovascular disease mortality, heart disease-specific diseases, cerebrovascular disease-specific death. But when we have controlled blood pressure, here there is no significant differences in morbidity or mortality between normotensives treated and controlled hypertension. As we know that, the problem that we have a great impact on cardiovascular continuum with hypertension, usually starting with atherosclerosis, LVH, coronary heart disease, myocardial ischemia, coronary thrombosis, myocardial infarction, and of course, arrhythmias may occur with sudden death, remodeling, ventricular enlargement, and ending with congestive heart failure, diastolic power dysfunction with congestive heart failure and death. As we know that, as it can reach with the heart to end-stage cardiac disease. Also, it can start with the endothelium of our tissues, such as in the kidney, with endothelial dysfunction, microalbuminuria, macro, nephrotic proteinuria, and end-stage kidney disease. As we know that these are the very deleterious complications of hypertension, and it produces a very important complications, end organ damage, such as stroke, hemorrhage at the brain, at the heart, LVH, coronary artery disease, congestive heart failure, retinopathy, peripheral vascular disease, proteinuria, and renal failure, so that it affects all the organ. One of the very important determinant for the life expectancy is atherosclerosis, which usually is, of course, assessed markedly by hypertension. As we know, it can affect coronary artery disease, LVH, ischemic stroke, chronic kidney disease, diabetes, and it can lead to different organ comorbidities with high incidence of risk. In 2010, hypertension remains the leading cause of death. It is still on the top of the leading cause of death, so that its control is very important. What about Egypt? As we can see, 26% of hypertension in adults. About 38% of Egyptians are aware that they have hypertension. Only 24% can receive treatment or are receiving treatment, while the only controlled is a very poor incidence, which is 8%. So that what a poor incidence for the control of hypertension, so that we are taking the whole complications of hypertension. As we can see in this diagram, still Egypt, only 8% have controlled blood pressure. So that this is a very really poor results, and it reflects the impact of the complications upon cardiovascular and mortality rates. As we can see, in Egypt, cardiovascular disease is still the leading cause of death. It represents 46%, approaching 50% of mortality in Egypt. So that what a great problem. So that it's very important to take seriously the European guidelines, which is the latest guidelines regarding the hypertension. As we know that we can diagnose hypertension either by office pressure measurement at the clinics or offices to be blood pressure more than 140 and the diastole more than 90. But don't miss, this is not the new trend. The new trend now is for ambulatory blood pressure, because sometimes the patient may came to your clinic with hypertension, and this is not right, white coat syndrome, or they may have developed hypertension in some time of the day, so that you should make the ambulatory blood pressure. As we can see, regarding here, the difference in the guidelines, previously, you only were treating blood pressure when the blood pressure exceeding 140/90. But here, even if you still have a normal blood pressure, you can treat the high normal blood pressure, which means 130 over to up to 140, and the stool 85 to 89. Even, especially if you have high risk cardiovascular disease or established cardiovascular disease, you should start early management for those of high cardiac risk. As we can know, also, usually it is recommended to start by dual drug therapy and to start treatment of hypertension, usually apart if you have systolic blood pressure, just systolic blood pressure below 150, and in fragile patients, frail patients with age above 85, so that here you can postpone the treatment of hypertension up to they can reach 140 to 159. As we can see here, it is recommended that you can reach your blood pressure below 140/90, but if the patient can't tolerate your antihypertensive medications, you may reach the systolic blood pressure up to 130 and diastole below 80. And if you can't tolerate, even you can, according to the Sprint study, you can reach with your blood pressure up to systolic blood pressure 120. But the diastole you should be below 80 millimeter mercury. There is a difference between the European and the American guidelines. The American guidelines were very strict. They have advocated that your blood pressure control to be less than 120/80, according to the Sprint study. But the European guidelines 2018, which is the more recent, have raised the ratio up to 130/80 to avoid the complications of tight control in some type of populations. As we can see, In hypertension, you'll start to treat if your systolic blood pressure above 140 or your diastolic blood pressure is above 90, especially, but if you have high risk, you can start at the lower limited. What is your target? Your target in hypertension to reach 130. If you can tolerate, you can reach up to 120, but don't make it less than 120. And for the diastolic blood pressure to be below 80, which means from 70 to 79 millimeter mercury. So that the recommendations to start antihypertensive medications with dual therapy. It is very important to start with dual therapy so that you can have proper control blood pressure and to avoid the complications of the high dose or the maximum dose of a single drug. As we can see that patients usually can be classified to several risks. If you have grade 1 hypertension with no other risk factors, this is low risk. This is the only patient that in high age above 80, you can start monotherapy. While other type of patients, such as when you have a higher risk, such as hypertensive mediated organ damage, CKD grade 3, or diabetes mellitus, or others, it is recommended to start with a dual therapy. Usually you should start with healthy lifestyle choices, which means avoid harmful habits, reduce salt and high fat diets, to lose body weight so that to correct the obesity, regular exercise, and the 2002 DASH system diet, which is the most appropriate diet until this moment. So that the combination usually it's preferred to start with RAS blockage such as ACE inhibitor or ARBs, plus of course calcium channel blocker, and the third agent you can add diuretics, but other combination in several situations are allowed. As we can see here, the initial therapy, apart from a certain situation, to start with dual therapy. Don't start with monotherapy, and usually you should start with ACE or ARBs plus calcium channel blocker, and diuretics may have a choice when you have salt-sensitive population or if you have volume overload. What about the effectiveness of valsartan amlodipine? Control of brachial and central blood pressure, prevention of target organ damage, safety for long-term use, control of brachial and central blood pressure. It is very, very important, as we found this study, this is a real-life study, that is have controlled the central blood pressure very effectively, and by reduction of systolic blood pressure by more than 33 millimeter mercury, and it was very effective in reduction of the systolic blood pressure reaching about 17 millimeter mercury. As we can see, it was very effective in all grades of hypertension, even in isolated hypertension, to use this combination of therapy, which is RAS blockage plus calcium channel blockers. So that here's measuring the central blood pressure is more important because it is the really predictive value for cardiovascular events, differential effect of antihypertensive drugs compared with brachial blood pressure. Central blood pressure to measure the blood pressure in the ascending aorta. As we can see in this study, which have been advocated, they have found that, of course, this combination, which is valsartan plus amlodipine, was very effective in controlling central blood pressure and prevents the vascular hypertrophy, extent of atherosclerosis, and reduces the cardiovascular events, mortality and morbidity. As we know that central blood pressure is usually lower than the brachial or peripheral blood pressure, so that when you have a proper control of central blood pressure, here in this situation you have a lower mortality and cardiovascular events. As we know that the ACE, the angiotensin, calcium channel blockers, all of these drugs, when compared with nitrates, were very effective in controlling central blood pressure. And when you have compared the combination between amlodipine valsartan versus amlodipine atenolol, it was more effective in controlling the systolic blood pressure, the pulse pressure, and the systolic blood pressure regarding the central blood pressure. What about the prevention of target organ damage? They have found that the combination between amlodipine plus valsartan, they have associated with reduction of the renal albumin creatinine ratio, secretion of course, and it prevents the brachial nocturnal systolic blood pressure, was very effective in its reduction and control of the central nocturnal systolic blood pressure, so that it was very effective in nephroprotection and reduction of complications of hypertension. Another study have compared the effectiveness of angiotensin receptor blockers for preventing macrovascular disease in patients with diabetes. They have found that telmisartan and valsartan who are very effective in protection of diabetic patients against AMI, hospital administration, and admission, myocardial infarction, stroke, or heart failure. And another study showed the association between a change in central nocturnal blood pressure and urine albumin creatinine ratio. So that this is the SPET study. They have found that this combination was very effective in lowering the blood pressure and in controlling of urinary albumin creatinine ratio. Comparative effect of the ARBs plus to reduce the macrovascular complication disease, they were really very effective regarding the acute myocardial infarction, stroke, and heart failure. So that this, especially in diabetic patients, so this combination was very, very important. What about safety for long-term damage? This is a very wrong concept that some populations start with triple therapy using thiazide. This is extremely wrong because thiazides have great problems in hypokalemia, hyponatremia, sometimes hypercalcemia, and the fall, post-hypotension, dehydration, especially in the new era when you have started in the cardiac and renal patients with the SGLT2 inhibitors, which may have produced, of course, diuresis, so that it may make volume depletion, so it may be very deleterious for our patients. So that don't start from this from the start, apart if you have a patient known to be salt sensitive or he has increased volume load. As we can see here, diuretics is a compelling contraindication. Of course, you have gout, or if you have relative contraindication in metabolic syndrome, glucose intolerance, pregnancy, hypercalcemia, and hypokalemia and hyponatremia. As we can see here, regarding with SGLT2 inhibitors, the combination with ARBs such as valsartan plus amlodipine is much better to be used without the use of thiazide diuretics because 1 minute, please, sir.
1 minute only.
1 minute only. As we can see, calcium channel blockers through its direct arterial vasodilator, it reduces blood pressure. And of course, in cases of valsartan, through of course its angiotensin receptor blockage through direct vasodilator and inhibition of the angiotensin 2, and at the same sympathetic, of course, blockage and aldosterone system antagonist, it can produce very effective issue. Calcium channel blockers mainly act on afferent arteriole and also efferent arteriole, while here the RAS inhibitors also as a potent vasodilators for the efferent arteriole. As we know that there is a synergism between both of them because calcium channel blockers, it is arteriodilation, and of course it can produce peripheral edema, effective in low renin patients, reduces cardiac ischemia, while the others such as it can produce RAS activation with no renal or congestive heart failure benefits.
Thank you very much,
Here,
Dr. Hussein. Thank you very much for delivering
this is the balance
this
message.
We understood the balance
Yes.
and the benefits of combining afferent and efferent arterial dilatation. It's a great honor to have your very comprehensive presentation.
Yes.
I believe we need to switch to the next session, please, which will be delivered by with the sponsor of Sandoz, and will be delivered by our dear colleague, Professor Ahmed Hassan. He will give us his talk about generics. What value do they add? 15 minutes, please, يا دكتور أحمد. تفضل.
إن شاء الله. Thank you, Dr. all of my colleagues, and Dr. Gamal Stanley for inviting me for this conference. So we'll start today for generic. What value do they add?
شغل الوقت يا حبيب. فين الوقت؟
So our agenda today to identify the pharmacokinetics parameters which are evaluated to determine bioequivalence in healthy volunteer, review the current bioequivalence data with generic immunosuppressant in kidney transplant recipient, identify impact and adaptation of generic tacrolimus on United States transplant recipient. So bioequivalence is the absence of a significant difference in the rate and the extent to which the active ingredient becomes available at the site of drug action when administered at
the same dose under similar condition in an appropriately designed study. So generic must be the same as active ingredient dosage, route of administration, strength, concentration, and may be different in shape, scoring, release mechanism, packaging, and excipient and expiration time. So for SANDS, which is a deliverance study for comparison between brand and generic, 24 to 36 healthy volunteers randomized to 1-to-1, and this is in a two-way crossover, and a single dose used for each brand and generic. The comparison will be on the maximum concentration levels of the drug and at the maximum time, and also area under the curves as comparison between brand and generic for bioavailability. So the FDA bioequivalence standard 2-1 site test procedure, statistical procedure guidance recommend confidence interval from 80 to 125% for area under the curve and Cmax after log transformation. So this is a randomized pharmacokinetic study of generic tacrolimus versus reference tacrolimus in kidney transplant, a dual center study, 68 patients included in the study, randomized as 1-to-1, screening with 2 weeks before randomization. And for this randomized 1-to-1 patient, some of them will given for reference tacrolimus for 14 days and the other for generic tacrolimus for 14 days. Those on referent tacrolimus will shift it after 2 days for another 14 days for generic tacrolimus, and also who started generic tacrolimus will shift it to reference tacrolimus for another 14 days. Then pharmacokinetics profiling day 7, 14, and 21 and 28. So this figure showing the comparative study regarding referent tacrolimus and generic tacrolimus regarding the mean concentration nanogram per ml and the time. There is no significant, statistically significant difference between both drugs. So a randomized pharmacokinetic study of generic tacrolimus versus reference tacrolimus in kidney transplants as regarding area under the curve and Cmax as regarding ratio of geometric means and confidence interval. Both generic and the brand are comparable to each other. So Sandoz generic tacrolimus Adbort is bioequivalent to Prograf in kidney transplant patient. So as regarding generic summary, we'll concentrate on that formed by the Sandoz, first on 2009 for microphenolate Movitel generic marketed, and also for tacrolimus generic marketed on 2009 also. So what about the de novo data of Adbort in kidney transplantation? So Connor et al., this is a retrospective single center study for de novo transplant recipient patient from November 2009 to November 2011, 48 patients treated with Prograf and tacrolimus, and 51 consecutive patients treated with Adbort. Immunosuppression in the form of basimilixumab, tacrolimus, MMF or MBA, steroid taper, trough level maintained from 8 to 12 nanomol ml. Outcome after 6 months post-transplant, point of comparison, tacrolimus trough level at 1, 3, and 6 months, and acute rejection survivor, graft function side effects. So this figure is showing comparative study between Adbort and Prograf regarding biopsy proven acute rejection, patient survivor, graft survivor. There is no statistically significant difference were found for these parameters. Comparative study between Adbort and Prograf as regarding delayed graft function, CNI toxicity. There is no statistically significant difference was found as these parameters also. And the comparative study between Adbort and Prograf with the serum creatinine, median serum creatinine, and mean estimated GFR. There is no statistically significant difference between both brand and generic. So as regarding safety profile, regarding CMV viremia, CMV disease, Becky virus, polyoma virus, and post-transplant lymphoproliferative disorder. Both brand Adbort and both generic Adbort and Prograf as a brand for clinical outcome at 6 months were comparable to each other, and also the results support Adbort as a potential cost-saving measure. What about the conversion data of Adbort in kidney transplantation? So Rosenberg et al. From Sweden, this is 20 center within patient comparison, Jan and to December 2012. 63 stable patient converted from Prograf to Adbort. Conversion will be dose to dose, milligram to milligram conversion, tacrolimus trough level, 3 levels were taken pre-conversion and 3 post-conversion at 1 to 4 weeks. Changed from tacrolimus level more than 20 would invalidate conversion. Outcome after 4 weeks post-conversion, change in tacrolimus levels and need those for those changes and changes in renal function. This is the points of comparison. So on the figure on the left side, the pre-conversion incidence for patient need for changes dose around 19% and post-conversion around 13%. The figure on the last side, the right side, the comparative study between Adbort and Prograf. As regarding serum creatinine estimated GFR, there is no statistically significant difference. So, patients were converted from Prograf to Adbort without clinical significant adverse events or acute rejection. Mean tacrolimus level did not change, and comparison of minimum concentration of the drug demonstrated by equivalent of Adbort to Prograf. Annual drug cost in saving per patient were realized. Strength in the study derived from a prospective sample size power driving protocol. Meta-analysis study, immunosuppression with generic tacrolimus in liver and kidney transplantation, systematic review, and meta-analysis on biopsy-proven acute rejection and bioequivalence. So the rationale and objective of this study, rejection prevention in innovator is one of the key factors for long-standing graft function. The use of generic tacrolimus is still under debate. Thus, systematic review and meta-analysis were performed to provide an overview on the current body of evidence for the effect of generic tacrolimus in adult liver transplant and kidney transplant, with focus on both biopsy-proven acute rejection and bioequivalence. Study design, a systematic literature search for trial comparing generic versus innovator tacrolimus was conducted accordingly. 17 studies, 5 liver transplant, 11 kidney transplant, 1 liver kidney transplant, including 1,412 patients were identified. So outcome, about 93% of study reported the same or lower biopsy-proven acute rejection with generics. De novo study showed a significant lower risk with generic tacrolimus. Bioequivalence was demonstrated primarily in the study on conversion. So there was no significant difference in terms of biopsy-proven acute rejection. There is some evidence suggesting lower biopsy-proven acute rejection risk with generic tacrolimus for de novo use. So this is a first plot of study comparing risk of biopsy-proven acute rejection between generic and innovator tacrolimus stratified by organ transplant as regarding liver and kidney transplant. Comparative between generic and innovator, the risk ratio will be less than 1, and this is favor generic tacrolimus. First plot of a study comparing geometric means ratio of area under care and between generic and innovator tacrolimus stratified by organ transplant as regarding liver and kidney transplant. Here, the gray shaded ratio between from the 90 to 110, and this is indicated by equivalence by the European Medicine Agency, acceptable for bioequivalence between the brand and generic. So first plot of study comparing geometric means ratio of maximum concentration between generic and innovator tacrolimus is stratified by Oghr transplant regarding liver and kidney transplant. Here's the gray shaded area between from 80 to 120, and this is indicate this bioequivalence between both drugs. So the cost, one de novo study with generic tacrolimus evaluated cost effectiveness and reported cost saving within the first 14 days, whereas one conversion study indicate higher cost with generic tacrolimus due to monitoring and hospitalization, whereas one conference abstract confirmed cost effectiveness. The systematic review of immunosuppression with generic and innovator tacrolimus in the prevention biopsy-proven acute rejection in adult liver transplant and kidney transplant did not reveal a difference. There is some evidence suggesting lower biopsy-proven acute rejection risk with generic tacrolimus for de novo use, bioequivalence regarding area under the curve and Cmax, and was demonstrated primarily in studies on conversion. Generic product have the potential to reduce cost for patient and therefore and healthcare system, and potentially account for greater adherence in healthcare system. So what about the purpose for generic tacrolimus formulation if they are similar to brand? We said before that manufacturers by Sandoz for generic tacrolimus and meclofenilate will be on 2009. Here the curves showing with the use of generic, there is increasingly years by years on the same time decrease the use of brand and reach this follow up from 2009 to 2013 for both tacrolimus and microfenilate. So in conclusion, Adbort is a bioequivalent to brand tacrolimus in healthy volunteer. Adbort is bioequivalent in a stable kidney transplant recipient with no observed change in organ function or adverse event profile. Over 50% of the United States liver transplant population has received generic tacrolimus since 2011. Introduction of generic immunosuppressant has lowered the cost of the immunosuppressive agent to the provider. So this is the last study for cost of the trans immunosuppressive agent after introduction of generic. This is a retrospective study for the cost effectiveness for the drug as regarding Medicare part of D payment. Here we saw that the tacrolimus decreased the cost by around 50% and miclofluoride around 55 to 67%, and also decreased cost for patient out of pocket cost in the form of as regarding tacrolimus from 60 to 70%, and miclofenilate decreased by around 70 to almost 80%. So it is cost effectiveness and cost will be with Adbort much more less than tacrolimus as regard program. Thank you very much.
Thank you very much, Dr. Ahmed, for your very comprehensive presentation. And I extend my thanks to Sandoz for your support. And being short of time, we will move to the next session, please. May I ask the chairpersons to attend and start the next session immediately, please, because we have international online talks and we need to be in time. دكتور أحمد فتحي اتفضل. اتفضلي يا دكتورة منال والدكتورة الدكتور مجدي الشرقاوي والدكتور منى عبد الرحيم دكتور ناهد بدور. معلش لو باي باس خالص بس
دكتور مجدي.
بسم الله الرحمن الرحيم. نبدأ السيشن. الكلينيكو باثولوجيكال كيسز. First case will be presented by أستاذنا دكتور أحمد فتحي، أستاذ الباطنة والكلى جامعة الإسكندرية. دكتور أحمد اتفضل.
السلام عليكم ورحمة الله وبركاته. بسم الله والحمد لله والصلاة والسلام على رسول الله صلى الله عليه وسلم، وأشهد أن لا إله إلا الله وحده لا شريك له، وأشهد أن محمدا عبد الله ورسوله. Thanks Mr. Chairman. شكرا دكتور جمال، دكتورة مي، والأورجنايزنج كوميتي على السيشن. الحقيقة بقت ثيم لطيف في كل المؤتمرات النفروباثولوجي، وقد إيه بتكون مفيدة وكلينيكال براكتس. احنا وي بريبيرد ماي سيلف اند وسام 5 حالات، بس دكتور رياض المفروض ان هو هيقول واحده منهم، هوبفلي انه كان ميك ات. هو كان معانا امبارح ومجهز الحاله كلها، بس مش عارفين هو ايه ظروفه دلوقتي. anyhow الكيسز بتاعتنا هيكون فيها شويه مسجز both clinical and histopathological messages، واحنا عايزين هنمشي throughout الكيسز ان احنا هنقعد بسرعه clinical scenarios brief in 3-4 minutes، ثم الباثولوجي بتاعه برضو in 4 to 5 minutes. بعد كده هيبقى في كومنتري على البوينت المهمه في الكيس برضو in another 5 minutes and then 5 minutes for discussion for each case. يعني فالديسكشن مهم جدا مع المودريتورز ومع حضراتكم يعني as a top elite KOL في النفرولوجي والترانسبلانتيشن. نبدأ بأول حالة هي unusual antibody mediated rejection. simply الكلينيكال برزنتيشن بتاعت البيشنت ده هو 25 years old HLA identical sibling transplant. ده واحد من الجروب بتاعنا اللي عرضناه اول امبارح في اول سيشن، والحقيقه انه luckily enough اخذت جائزه احسن بيبر في المؤتمر نمبر 1. العيان ده كان unknown primary، ما كانش عنده اي هيستوري قبل كده، بيز لاين كرياتين 1.1 وماشي على MMF مونوثيرابي. ده البروتوكول اللي ماشي مع ال HLA identical sibling اللي بدأناه من حوالي 6 سنين. الكريات بتاعه روز اب ل 1.5 وبعدين 1.7. ده كان في بلده في ليبيا، وجالنا بعد شهر على ما عرف يطلع التأشيرة ويوصل كان 2.7. جرافت سايز كان نورمال، ان سبايت انها سلايتلي ايكوجينيك. السي ام ديز اوكي، والار اي كان بريتي هاي. اليورين شود بروتين 1 بلس، شويه ليوكوسايتس ار بي سيز. He received empirical steroid for 3 days، وبعدين البريدنيزولون على 40 ملغ per day، واتعمل له السبسيس ماركرز والسي ام في بي سي ار والبي كي بي سي ار والبي ار اي and they were all negative. يعني احنا عندنا rising renal function with negative DSA and negative viral markers. Graft biopsy was done بعد 6 شهور. الكريات نزل ل 1.7 وبعدين رجع عالي تاني ل 2.4. ده قبل البيوبسي ما تطلع، جاست على الستيرويدز النص جرام اللي كان بدأوا. So what is the next step? Would you repulse the patient؟ احنا دلوقتي خدنا البيوبسي ومستنيين النتيجة والكريات رجع يعلى تاني. Would you repulse the patient or would you start empirical IVIG? Would you wait the biopsy result? So what's your choice?
Can I ask you a question, Professor Ahmed? What is the induction for this patient, or no induction?
No induction.
No induction.
No
at all.
induction.
You started with Silcept only.
Yes.
And
only
no,
ده اللي عرضناه في اول يوم. ده بروتوكول بس مش هنضيع وقته. بياخد ستيرويدز اول 3 ايام فقط، وبعدين بيكمل على 30 ملغ. By the end of the first month بيكون زيرو ستيرويد و only MMF therapy based على انه first transplant negative PRA وفول ماتش من سيبلينج، مش فول ماتش من حد تاني، فول ماتش من اخوه. يعني دول 15 حاله واحنا عرضناهم، بس مش عايزين ندخل في الحته دي. يعني المهم انه ده واحد من العيانين. احنا we had 3 patients with rejection في ال 15 عيان دول. ده واحد منهم، ده واحد من العيانين اللي جاله rejection. مش identical twin، كلهم مش identical twin، كلهم just sibling full match sibling. So
the same gender.
ايوه
اخوات.
اخوات.
No gender male to male.
ال 15 كان فيهم 2 females to male. في few papers، يعني في حوالي 7 papers منهم اخر واحده منشوره في الاي اس ان اللي فات. معلش انا بس بعد اذنكم مش عايز اخلي ده الثيم بتاع الدسكشن، لان ده اوريدي دان في اول يوم. Pulse steroid again. Okay. The biopsy result showed microvascular inflammation compatible with active antibody-mediated rejection C4D positive plus chronic active TCMR with mild IFTA. والكرياتين by that time was 2.7 milligram per deciliter.
دكتور احمد في history of non-compliance to
الحقيقه اصله ما كانش بياخد غير مونوثيرابي، فهيبقى نون كومبلاينت ليه؟ انا يعني I don't think ان ده كان موجود يعني. كان بياخد 2 جرام سلسبت، كان بياخد 2 جرام سلسبت. طيب خلينا ده سو فار اللي حصل مع البيشنت، وهنشوف الباثولوجي بتاعه.
اوكي، هي البيوبسي showed mainly زي ما حضراتكم شايفين slightly او moderately mild to moderately atrophic tubules. بس عايز اتاكد ان ده البوينتر. اهو اوكي، وكل all of these tubules showed tubulitis. Again here you can see the basement membrane tubule, the size of the tubule was reduced in size. The basement membranes were slightly thickened, and you still have active tubulitis, which is mainly the definition of what we call a chronic active T-cell mediated rejection. It's mild because the degree of infiltrate was not really significant, or the interstitial inflammation. Glomeruli, other areas of the biopsy showed normal glomeruli, no capillary basement membrane changes, no glomerulitis, and he only had a moderate peritubular capillaritis, or what we call PTC2. And I was surprised to see that his C4D was actually positive. So the diagnosis is that he had an ongoing chronic active T-cell mediated rejection. This is usually a subclinical process, but the cause of his recent rise in serum creatinine was actually the active antibody mediated rejection. It's active because there is no signs of any chronicity which is related to antibody mediated. And of course, his C4D was positive. Ahmed? So this was his final diagnosis, and he had already mild interstitial fibrosis and tubular atrophy. No, they were not plasma, they were mainly lymphocytic.
دكتورة وسام، الجلوميرولس دي فيها 2 patches of segmental sclerosis?
No, I think
6 o'clock and at 11 o'clock?
No, this is just a plasma exudate. No, this is not sclerosis.
امال ده ايه؟
ده بس كده من الصبغة. It's just a plasma stained بالإيوسين.
Okay, so we're left with a combined chronic active TCMR plus some sort of a mild antibody-mediated rejection, C4D positive, although the DSA was negative. والحقيقة احنا كان اللي بالنسبة لنا عجيب انه يكون في antibody-mediated rejection وهو full match. على فكرة الفول ماتش دول كانوا 8 of 8، يعني معمول لهم الدي كيو والدي بي كمان. اتفضل. تي سيل ليمفوسايت. صح.
It's a T-cell mediated rejection. ما عندهاش capacity to be cytotoxic.
طيب. اوكي. سو ده الهيستوري بتاعنا وده اللي حصل. البي ار اي اللي احنا عملناه ان احنا عملنا له بي ار اي فور نون اتش ال اي انتي بوديز، وده ريدلي افيلبل وبيتعمل زي البي ار اي العادي، والحقيقه انه طلع بوزيتيف للاجرين انتي بودي. وده بالنسبه لنا لما we dig down in the literature لقينا انه can explain the antibody mediated rejection in such a group of patients. في معمل الدكتوره ميرفت الانصاري هو موجود على فكره، الكلام ده بقاله 3 سنين، الحاله دي من يعني موجود وطبعا الريبيت كروس ماتش يعني تو اد اون احنا جبنا الدونر بتاعه اللي هو اخوه وعملنا لهم تاني فلو سايتومتري كروس ماتش وهو في الريجكشن رغم ان البي ار اي كان نيجاتيف، لكن عدنا حتى فلو سايتومتري وطلع برضه توتالي نيجاتيف، وده معناه انه ديفينتلي ما كانش دي اس اي خالص يعني. So we treated the patient by plasmapheresis IVIG, 1 shot of rituximab, and his creatinine stabilized around 2.3, 2.5. Then shifted him to Prograf MMF instead of MMF monotherapy. وناوداي هو بعد تقريبا 3 سنين وكسور من الزرع الكرياتين بتاعه 1.7 to 1.9 up and down between الرقمين دول وثابت على كده. يعني اتفضل. اتفضل.
ما هوش دونر سبيسيفيك انتي بودي،
مش اتش ال اي،
نون اتش ال اي
مش
دونر،
نون اتش ال اي نون اتش ال اي. لا خد اي تي جي كمان عشان السي ام ار، يعني هو اخد حضرتك، هو كان اخد بالس ستيرويد، لما طلعت نتيجه العينه اخد 3 دوز اوف اي تي جي، اخد اي في اي جي بلازما فارسز وريتوكسيماب. ممكن تكون وقعت لكن هو خده ديفينتلي، خده مفيش كلام، خد 1 دوز اونلي. اتفضل يا مين. ما هو ده
It's not for discussion in this.
ده كان موضوع امبارح، ده كان موضوع اول امبارح.
كان هذا كومنت دكتور احمد. ماشي اوكي.
ده كان موضوع كامل اول امبارح، ويعني في بيبر كامله اتعملت و15 حاله والاوت كم بتاعهم موجود وريبورتد، وانا اي كان شير كل الداتا بتاعتهم يعني.
بمعنى اخر لو الحاله دي مع الدكتور مجدي او الدكتور جمال او الدكتور صبري هيعمل لها كده.
بص يعني هقول لحضرتك شورتلي ارد على دي يا دكتور دولت باختصار. خلاصه الموضوع ان احنا عملنا كومباريزن للاوت كم بتاع ال 15 حاله دول اجينست الحالات اللي اتزرعوا في نفس الوقت عندنا في المواساة الجامعي اللي كانوا واخدين التريبل ثيرابي. لكن الليميتيشن اني ما عملتوش اجينست الفول ماتش اللي واخد تريبل ثيرابي، وعملت كومباريزن اجينست اليونس داتا لليونيفرسال ريت اوف ريجكشن، وعملت كومباريزن للفول ماتش اللي من سنه 97 ل 2000 سوري من 77 ل 2002 الاي ان زي دي داتا اللي هم فول ماتش، ولقينا بس طبعا دول كان فيهم جزء على اذاثايوبرين وجزء على سايكلوسبورين بس عشان بدري. وانا الانسيدنس اوف اكيوت ريجكشن عندي وذر كان انتي بودي ميدييتد او تي سيل ميدييتد كان 20%، 3 من 15 which is much less عن اي incidence of acute rejection في كل الليترشر في كل الحالات الثانيه اللي على تريبل ثيرابي. حاجه اخيره البيشنت سرفايفل كان 100% لغايه ما واحد داي من انتركرينيال هيموريدج والثاني دايد من كوفيد. الجرافت سرفايفل جرافت سنسور ديث سرفايفل 100% لغايه دلوقتي. اعلى كرياتينين عندي 2.2 2.3 تقريبا حتى في اللي جالهم ريجكشن. والديتا بتاعتنا دلوقتي وصلت لحوالي كام 1000 مانث بيشنت تقريبا، يعني اطول واحد 72 شهر 6 سنين واقل واحد من 6 شهور. بس ده كل ده بقى خدنا بعيد عن الموضوع.
I would have compared this cohort with another cohort of single monotherapy with tacrolimus. لا مش تكرولمس. لو عايز مونوثيرابي I would if you are going
to الحالات دي مش كتير يعني دول يعني الحالات دول بالعافيه على ما لقينا دول يعني عشان تلاقي حضرتك 15 عيان فولي ايدنتيكال ماتش وهم اخوات. واحنا ليه اخترنا الام ام اف مش التكرولمس؟ علشان اللونج تيرم سايد افكت بتاع سي ان اي. يعني قلنا
يعني بس for the lines of treatment of immunosuppression يعني انا personally I wouldn't choose this line.
Yes, I have a comment.
Let me just we need a point of
order.
Yes, order. Let me ask you, why didn't you use campus like everyone is doing outside?
هو هتمشي for life على كامبس؟
Yes, no, once and then you
induction يعني يومين.
Yes.
عشان الستيرويد فري يعني؟ عشان تدي ستيرويد فري يعني
دكتور حسين.
Yes.
معلش ممكن
I would like دكتور دولة.
I want to go back to basics. احنا بنقول ان هم non-HLA antibodies. يعني الفلو سايتومتري is positive with a negative luminex. دول النون HLA.
لا
يعني في positive reaction.
لا
واللومينكس مش مطلعاهم.
لا ده الفلو كان نيجاتيف.
انا عارفه ان هو نيجاتيف. اللي انا اعرفه على النون HLA انا عرفت ازاي ان في انتي بوديز ان الفلو بوزيتيف واللومينكس نيجاتيف. مفيش.
ما هو حضرتك هو مش لازم يكون النون اتش ال اي از دونر درايفد.
دينوفو.
امال منين؟
ممكن يكون دينوفو. طبعا مش لازم يكون دونر درايفد. هي دي النقطه بقى انه مش لازم يكون دونر درايفد.
ممكن يكون his own antibodies against his own tissue. كمان كان لازم اعمل اوتو كروس ماتش.
النون اتش ال اي لا.
يس.
طيب هناخد اخر كومنت يعني 15 سكند من دكتور حسين عشان الوقت.
ثانك يو دكتور احمد فور يور.
الاوتو كروس ماتش يا دكتور احمد. الاوتو كروس ماتش مش
نيجاتيف. لا ما هو عامل فلو نيجاتيف اساسا.
بما ان دي بيقول لك نيجاتيف.
لا ما عملناش سي دي سي.
طيب بما ان دي ميكس ريجكشن. نعم. ده اللومينكس. ما هو بيطلعوا نيجاتيف. الساب بيطلع نيجاتيف.
ايوه بالظبط. ما هو طب هو ده جاي.
اتفضل. طيب دكتور حسين for sake of time just few seconds.
انا بس few seconds because very important issue. حضرتك انا طبعا بشكر احمد for his kind طبعا ليكتشر، بس انا مختلف معاه في الكونسبت لان احنا لما بنقارن حضرتك ال6 ماتشنج كل البريفيوس انترناشونال ستاديز قالت ان احنا عشان امشي على مونوثيرابي عندي حاجه مهمه جدا. اول حاجه يبقى بارت اوف ماي بروجرام بروتوكول بايوبسي. بروتوكول بايوبسي ريجولارلي عشان اقدر تو ديتكت ان كيس اوف مونوثيرابي لو في اي ايرلي افتا او اي ايرلي نون سيجنيفيكانت سواء تي سيل ميديتد ريجكشن تو بي. فديس نمبر 1. فما دام ما عنديش بروتوكول بايوبسي
احنا ما عملناوش. عملنا بداله بي ار اي. ده لا كنا بنعمله كل 6 شهور.
بي ار اي كانت اكسكلود بروتوكول بايوبسي. ده طبعا فاهم احسن مني الكلام ده. فما دام انا ما عنديش بروتوكول بايوبسي it is very critical that you may endanger your graft. This is number 1. لما نيجي نشوف الستاديز والريكومنديشنز اول تايم
this is more than 15 second. دكتور جمال بيشاور لي
هقول حاجه بس. مونوثيرابي لو همشي مونوثيرابي يبقى after 3 months after dual therapy and with tacrolimus only.
اوكي دكتور احمد هو ده احنا for sake of time we'll get to the second case.
عملت head to head study.
Yes we can discuss this if we have time at the end of the presentation.
اخر حاجه بس في المانجمنت ليه ما اديناش الفول دوز بتاع زي ما الانترناشونال بروتوكول 6 سيشنز اوف بلازما فارسز
عمل 7
دوز اوف اي 6 دوز اوف اي بي اي جي
عمل 7 بلازما فارسز و4
اي دوزز اوف اي تي جي 5 دوز في جي. ما هو ده حاجه بروتوكول.
هو عمل 7 و4 و3 وهي ريسبوندد.
يعني انا اقصد حتى لو ريسبوندد يو شود كونتينيو اب تو 5 دوز اوف اي تي جي.
Yes we agree but this is not the time or the session to discuss this issue. We'll move to the next case of course by Professor Ahmed Al-Qurai'i again.
اوكي طبعا احنا خدنا كتير في هو ستاكد. اوكي احنا كده الديسكشن بتاع الكيس طبعا عدى. هو بقى كان ده الكلام على ان ازاي نشخص الانتي بودي ميدييتد وامتى نفكر في النون اتش ال اي انتي بودي ميدييتد. احنا للاسف ودريفتد كله لاتجاه البروتوكول الثاني وده ما كانش وقته يعني، لكن كان ديسكاسد في اول يوم. دي الكومنلي بريزنت نون اتش ال اي. وتاني زي ما استاذ الدكتور صبري قال ده موجود. حضرتك بدل ما بتكتب بي ار اي فور كلاس 1 اند كلاس 2 بتكتب في بي ار اي فور نون اتش ال اي انتي بوديز which is available وبيطلع لك برضه بسنجل بيد على which انتي بودي منهم هو اللي موجود. ميرفت، دكتوره ميرفت انصاري. هم 40 بيطلع على 40 واحد، بيطلع على 40 منهم هم الموست كومنلي بريزنتد، هم الميكا والانتي البيركالين اللي هو السي دي 3 والانتيوتنسين والانتي اندوثيلين. تمام. الاوت كم بتاعها ما بيفرقش كتير، والحاله لما بتتابع يعني بتريسبوند، ويمكن يكون مايلدر كمان عن الاتش ال اي، وده اللي حصل مع البيشنت بتاعنا. طيب we'll move to the second case. السكند كيس كان Mr. M is a 55 years patient of unknown original kidney disease, transplanted من 5 سنين from unrelated donor, and there was no history of perioperative complication. Baseline creatinine was 1.6 on classic triple immunosuppressive protocol. He lost follow-up for 2 years. يعني بعد ما بقى كرياتينه 3 زي ما احنا عارفين، سوري، بعد ما عدى عليه 3 سنين اطمن وكرياتين ستيبل، بطل يتابع. Then he presented by general fatigue, lower limb edema, creatinine of 4, urea 142, and hypertension 160/100. Graft size can slightly enlarged, increased echogenicity, good CMD with elevated RI a bit, والurine fee proteinuria والleukocyturia and RBCs. 1+ لسه ما فيش quantification. دلوقتي ده عيان lost follow up for 2 years، baseline كرياتين بتاعه 1 و6، وجاي لنا بكرياتين 4 مع هايبرتنشن مع الداتا اللي قدامنا دي. 1+ ما كانش quantified لسه. would you consider ده ان خلاص ده chronic graft dysfunction based على انه البيز لاين بتاعه كان already مش نورمال قوي، وبعدين هو lost follow up مش عارفين اللي حصل فيها، ولا would you give him the benefit of doubt and would you start immediately by pulse steroid، ولا لان الحاله دي ما هياش very acute وما كانش امبارح كرياتين 1 و6 والنهارده 4، فهتقول ده ممكن يكون بيعلى، بلاش نبقى بسرعه شويه، يعني الاثنين دول عكس بعض في التفكير، ولا would you do a biopsy وتستنى ما تعملوش حاجه لغايه لما تطلع نتيجه البيوبسي. كل الانفستيجيشنز هاف بين دان بقى، يعني ويتنج للريزلت، لكن دلوقتي في السيتويشن ده يعني
you must do biopsy.
do a biopsy ومش هتدي له active treatment لغايه لما تستنى البيوبسي.
Yes, you must do biopsy.
تدي له بلس. تمام. ولا نعمله CMV PCR. طيب ايه اللي حصل؟ ان الراجل managed conservatively unfortunately، يعني الدكتور اللي كان بيشوفه اعتبره نمره 1، راح مزود له كده الستيرويدز شويه وخلاص، وما عملوش بايوبسي ولا عمل له اي حاجه. بعد اسبوعين الراجل جاء بهاي CRP وفيفر وليمفوبينيا والكرياتين عالي من 4 ل 5.8 and he was diagnosed as COVID-19 positive. Biopsy was done والريبورت بتاعه جه. يلا يا وسام.
Okay, now this was a bit of an interesting case because as the title, there were too many findings in the biopsy. Now this is a trichrome stain and it shows you that there is already some extent of chronicity with interstitial fibrosis. And I'm not sure if it's working. So we have interstitial fibrosis. You can look at the blood vessels. There is a mild sclerosis, but there is also evidence of a widening of the subintimal area by what looked like mucoid degeneration. The glomeruli itself were variable. The picture is not complete, but this is a shrunken, what typically we call shrunken bloodless tuft. And one glomerulus showed what could be a cellular crescent. On a closer look, you can see that you have a glomerulus with extensive congestion and red cell fragmentation. This is consistent with thrombotic microangiopathy. You have other ischemic glomeruli. You have some glomeruli here with active glomerulitis and some early hyalinosis. And then again, this glomerulus with what looked like a crescent. With the silver stain, you can see, as we said, that there are obviously, this is not the first episode because you had ischemic glomeruli with wrinkled and thickened capillary basement membranes, typically what a previous endothelial injury would cause, like in a TMA or a consistent antibodies, for example. And on the other hand, we had another glomerulus with an acute evidence of TMA, like the previous one we'd seen, with a classic basement membrane duplication and basement membrane vacuolation here, some glomerulitis, endothelial swelling, and so on. Back to the glomerulus with crescent, and actually this was not, this is a pseudo crescent because it's mainly all formed of epithelial cells. You get no inflammation, no choriorexis, no fibrinoid necrosis, and it showed these epithelial cell proliferation was actually collapsing segments of the tuft. So this fits with what we call a collapsing glomerulopathy. Again, another field of the biopsy, and you can see here that you had onion skinning of the arterioles, and again, ischemic glomerulus with basement membrane duplication, this time with not significant activity and significant microvascular inflammation. So, considering that this patient was post-COVID and considering the findings which was present in the biopsy, we know the glomerular lesions, one of the first glomerular lesions which were reported with COVID was a collapsing focal segmental glomerulosclerosis, which was called COVAN, similar to HIV, high VAN, but also thrombotic microangiopathy was reported with COVID, as well as other reports of glomerular disease. And whether could glomerulopathy be an early presentation of COVID-19 infection in kidney transplant recipients, we had also reports, and I'm going to show you this again, of these patients who developed transplant impairment due to the collapsing glomerulopathy. So the next step was to determine whether this patient all was related. It's usually good, or what I would like to do is that to collect all the findings under a single diagnosis if you can. But with this patient, it was difficult because we had too many factors going on. The C4D was a very helpful tool to actually consider that the thrombotic microangiopathy was the active, was related to the active antibody-mediated rejection, and the collapsing glomerulopathy was related to the COVID. As much as we can, this was the best interpretation which could be founded, because remember that, so this was my final diagnosis or my evaluation, that this collapsing glomerulonephritis was actually COVID related and that it was associated with active ABMR. It's the active ABMR which caused the creatinine 4, and the collapsing GN, which usually comes with a impairment of the functions, is what caused the creatinine to jump to 5.8. This patient is not his first episode, so he had already evidence of early transplant glomerulopathy, moderate EFTA around 30%, and moderate arteriolar hyalinosis. Bearing in mind that the first cause of collapsing glomerulonephritis post-transplant is actually a severe form of antibody-mediated rejection, as well as severe CNI toxicity, which is not, of course, the case with this patient. Viral infections, we also always considered parvovirus 19 and HIV, which is not so common in our transplant population, but with the cough SARS-2, then the differential diagnosis has to be changed, especially knowing that the patient was COVID-19 positive. Plus, of course, there could be other more uncommon etiologies, like possibly recurrent FSGS, although not commonly, it recurs as collapsing. And a collapsing glomerulopathy with acute kidney injury was reported very early on within the COVID epidemic. And usually these patients were related to high-risk APOL1 variants, and this is why they called it a COVAN. And also in another paper, in this paper, they had 5 cases of collapsing glomerulopathy, but they were all in the native. And within, again, they did genotyping, and again, the patients had APOL1, and this is the same study I showed earlier with the patient in the transplant recipient who presented with AKI. The important point, actually, I want to raise, and it was also raised in this paper from Mayo Clinic, that in their patient cohort, they had 8 biopsies with collapsing glomerulopathy, but they had a concurrent pre-existing glomerulopathy in around 5 of them. So within the setup of COVID, you can get a collapsing glomerulopathy, which is superimposed on already what's present in the kidney. And remember, the collapsing glomerulopathy can cause a proteinuria, but it mainly presents with acute kidney injury. In our own cohort, we had an equal incidence of post-COVID patients of 36 transplant biopsies. The glomerular regions were not the dominant ones were the ABMR. However, we had an equal incidence of thrombotic microangiopathy and collapsing glomerulopathy within our biopsies. Thank you.
Thank you, Sam, for your nice case. Third case by Dr. Riyad.
clinical discussion هو جه في النص بس. البيشنت ده لما تشخص ان هو كوفيد ومعاه active او chronic active antibody mediated rejection, how would you treat him? Would you give him plasmapheresis, IVIG? Would you give him tocilizumab? Would you give him remdesivir? How would you proceed with this patient? هتنفع في الاثنين. تنفع في الاثنين. طب والاي في اي جي؟
بس انت you biopsied him 2 weeks after COVID يا احمد.
ايه؟
You biopsied this patient 2 weeks after COVID.
يبقى هتأسس الكوفيد سيتويشن بتاعه يستاهل ولا ما يستاهلش؟ اللانج بتاعته شكلها. ايوه. لا مش 2 weeks after COVID. البيوبسي اتعملت اول ما تشخص، بس هو ده كان بقاله اسبوعين من الكرياتين ل4. ما هو احنا ما نعرفش بقى الكرياتين ل4 ده كان ساعتها معاه كوفيد ولا هو لما رفع الاستيرويدز بعدها.
الشيست بتاعه as a COVID patient الشيست بتاعه اخباره ايه؟ هنا بقى you have to wait.
في الاول ما كانش باد قبل البيوبسي.
When you get the biopsy result, you have to declare the situation of COVID. If it is cleared, you go ahead aggressively.
طب معلش، ما هو في سؤال تاني بس. ما هو نفترض ان الشيست كويس واحنا معانا collapsing glomerulopathy في البيوبسي. we would say ان ده this is a COVID finding and we should treat.
No, ignore the collapsing and treat the antibody mediated rejection for this patient. دكتور حسين برضه عنده كومنت 5 ثواني.
خلاص في الجايد لاينز دلوقتي او الكونديشنز لسه نازله من 3 ايام. قسموها. لو انا عندي PCR COVID positive في certain steps I should do. The priority is for patient life. You should stop the anti-metabolite. You shouldn't adjust the dose of calcium inhibitors to 4 to 6 nanogram per milliliter. You should start the new monoclonal antibody, antiviral, either
دكتور حسين let me interrupt you.
Yes.
But I need a comment on this case.
Yes, this
not
case.
in the guideline.
لو PCR positive.
Yes, what will you do? Just tell me
لو PCR positive.
Yes.
Stop the guidelines. Stop anti-metabolite. Give tacrolimus at a level of 4-6. Number 3, give the new.
ده وانت في active antibody mediated rejection.
Yes.
يعني انت بتضيع الكدني.
No. The priority for أكمل بس.
ما هو ممكن يكون الكوفيد مش
أكمل بس الكلام. أكمل الجملتين مع بعض.
After دكتور حسين بروفيسور جمال and then أحمد.
ندي المونوكلونال انتيبودي اللي هو المابينيماب أو الاستيولوميناب أو حراكي سيزاري لوميناب انتيبودي. نبدأ الأورال مونيوبريل until your COVID became positive after being 3 days to be negative. Here you are allowed to regain again the full dose بتاع calcium inhibitor. You can regain the anti-metabolite and you can start aggressively with IVIG plus
دكتور حسين stopping the anti-metabolite أو anti-proliferative is dependent on his general situation.
أيوة.
But please we should not stop it at all. We can reduce the dose only.
يا دكتور جمال PCR
ده اللي مكتوب في
PCR with any organ.
دكتور حسين احنا اليومين دول مع
الأوميكرون
only reduce PCR ما عندوش حاجة خالص.
You only reduce the dose of anti-proliferative positive but you stop it only if the general condition and
بس
the
كمان
PO2 is very low.
والحقيقه دكتور مجدي دكتور جمال ان احنا عندنا عيانين كتير جدا ما قللناهمش حاجه خالص لانه كلينيكالي كويس خالص.
ايوه بس هنا الكوفيد وصل للكدني. انا متفق دكتور جمال لو PCR positive without any symptoms or any organ affection no reduction in the dose when
بس
يبقى
you have to check the status of COVID first before doing anything.
يا دكتور مجدي في ستادي نزلت.
هو انا قلت اللي انا عايزه خلاص. يلا كمل.
يلا دكتور احمد عايز تقول حاجه؟
او في سيمتوم ماي مودريت سيفير بنقلل الانتي ميتابولايتس ده في الجايد لاينز الجديده. ولكن في الحاله دي I should start plasma pheresis whatever this is not contraindication. IVIG as low dose because patient creatinine 5.8 and there is risk factor to increase serum creatinine for this case later on because it deteriorates kidney function. فانا هديله من 100 ل 200 international milligram per kg for this case and increase serum اللي هو increase اللي هو and I can decrease the anti-metabolites according to the situation of the patient and even stop it.
ماشي. هو كلينيكالي كان كويس.
In 1 minute دكتور احمد just summarize what happened to this patient.
What happened ولا حاجه.
يس هو ده ما احمد قال بوضوح.
وكل الادفايسز دي اولا ديبيتد كلها حتى في الحالات اللي ما فيهاش انتي بودي.
صحيح.
انما الحالات اللي كوفيد انتي بودي ما فيش في حاجه في الليترشر عليها. واي ثينك انها تبقى ليفت to the judgment of the treating.
تمام. هو برضو back to the guidelines في الحته دي. guidelines بتقول انه لو العيان ما عندوش progressive desaturation oxygen independent ما فيش cytokine storm وما فيش high fever والجي جي اوز اقل من 10% do not reduce immunosuppression in such a patient especially في عيان زي ده.
You just save the patient from COVID and then treat him from rejection.
Let's move to the next case. دي اللي كان المفروض دكتور رياض يقدمها. للاسف هو مش افيلبل معانا واحنا كنا محضرين حاله ثانيه غير حالته. ماشي خلاص. يبقى ندخل على كيس نمبر 4. الكيس نمبر 4 اسمها the often forgotten diagnosis. هو عيان 44 سنه transplanted من 4 سنين from unrelated donor. البرايمري kidney disease بتاعه diabetic kidney disease وhypertension comorbidity baseline creatinine 0.7 بعد الزرع على triple immunosuppressive therapy classical و incompliant to the immunosuppression يعني من اللي هم شويه بيقطعوا. He presented with a fever 37 type 2. Presented with a fever 37.8 vomiting and blood pressure يعني borderline. هو اصلا hypertensive. graft size okay slightly echogenic good CMD but high resistive index. hemoglobin بتاعه كان 9 والعد الابيض 10. الكرياتينين 6.8 واليوريا 230 CRB 43 صوديوم بوتاسيوم ار اوكي. الصوديوم slightly low والبروتين 2 plus again with بايوريا او ليوكوسايتوريا 50 ل 60 و RBCs 5 to 7. He was started on pulse steroid based على الجامب الكبير ده under cover of meropenem علشان الهاي CRB والليوكوسايتوريا اللي لسه مش عارفين ايه حكايتها. كان الاي ان ار بتاعه ليتل بيت عالي موستلي مع السيفير سبسيس اللي هو كان فيها. البيوبسي الاي ان ار بقى كنترولد. then the biopsy was done and urine and blood culture were requested و PRA was done و renal function test gradually started to improve. الكالتشرز طلعت no growth بس هو كان already started الميروبينم. ال PRA was negative. خلي بالكم الار اي بتاعه كان very high. كانت بعد بدا الانتيبيوتيك. هو اخذ الانتيبيوتيك immediate قبل البرزنتيشن حتى. وده السؤال هو what is the limit of empirical immunosuppression before biopsy. يعني قصدي هل كل بيشنت هيجي لنا مش عارف اعمل له بايوبسي النهارده على طول ابدا بالس ستيرويد ولا ده سؤال for discussion ولا في situations معينه ندي و situation ما نديش and what to do.
Well, let me ask you a question, Dr. Ahmed. Why you are doing PRA for patients? You should do DSA.
ايوه ما هو الدونر بتاعه مش موجود.
What about the file?
العيان زارع عندكم يا باشا واحنا ما نعرفش عنه حاجه.
ما فيش حد عندنا
عندكم يعني في القاهره يعني اقصد.
We never transplant unrelated patients.
في القاهره فاحنا ما نعرفش عنه حاجه. الكلينيكو باثولوجيكال بارادوكس بقى البيوبسي والدايجنوزز ونشخص البيشنت ده ازاي ولا وي شود دو ذا بايوبسي. هل البيوبسي دي دايجنوزز اونلي يعني ولا ليها بروجنوستيك فاكتور ولا هتمبلاي عليا في التريتمنت اعمل ايه؟ كلهم صح. طيب يعني وسام هي كسبانه.
As usual. Okay. Now, I just want to show you that this patient had a part of his kidney completely looks very fine with very nice glomeruli and just a mild acute tubular injury with these just a bit of granular costs. But another section of the biopsy showed these. So you have a more florid tubular injury, more busy costs. They look like they have inflammatory cells. And you have the background of mild fibrosis. On a closer look, you can see that these costs are actually full of neutrophils. And you have a lot of neutrophils here, and you have an interstitial edema and a mixed inflammatory infiltrate. And you also have active neutrophilic tubulitis, which is a very important finding in a diagnosis of what we call infectious tubular interstitial nephritis / bacterial. I also want to remind you that it's not always bacterial and that fungal infections will give you the same picture. And it's going to give you a suppurative form of infection, which is going also to mimic what we usually call bacterial infections. As I mentioned, again, you can see, I think you can see in this biopsy that the patient had also a microvascular inflammation here. He had peritubular capillaritis, focal within this area, but in other areas of the biopsy, you can see a very nice kidney with almost a nil or a minimal MVI, and this MVI here mainly consists of neutrophils. And this actually case is one of the examples of when microvascular inflammation or peritubular capillaritis are very non-specific, and that this finding always has to be interpreted within the rest of the findings of the biopsy, and that when you even get neutrophils, which we consider them highly specific, this is also a very common finding in pyelonephritis. Patient C4D was negative, and so the final diagnosis with an acute infectious tubular interstitial nephritis, probably bacteria, and only a mild IFTA. So the patient did not have any sign of rejection, whether T cell or ABMR, and he was also not a chronic patient, although the query history of the non-compliance. And as Ahmed mentioned, his PRA was already negative, so we did not have causes to worry. Just very quickly, you all know that infections, of course, you know better than me that they rank second as the cause of death in patients. But the important point is that diagnosis is not always straightforward, as transplant recipients may not manifest typical signs and symptoms of infection, as well as you also know better than me that the treatment regimens usually are complicated by drug interactions and the need to maintain the immunosuppression. And the risk of infection for the recipient at any point in time after transplant is a function of two factors: the epidemiological exposure as well as the net state of immunosuppression. Epidemiological exposure covers everything: virus, bacteria, fungus, parasites, those known as nosocomial exposures, and the community exposures. As well, the net state of immunosuppression, of course, you know this well, but remember that it's not always related to drugs. Technical complications should be counted, drug-induced complications like neutropenia and lymphopenia, underlying immune defects, metabolic conditions like diabetes and alcoholism, and a pre-existing viral infection will also put the patient at risk, especially for a bacterial infection. And you know the association of immunosuppression and infectious syndromes when two of our main pillars of immunosuppression like corticosteroids and CNI, and MMF are direct causes of bacterial infection. Now, I just want to show you this a graft, because a graft, when we come to consider the paradigm of infections, and usually we plan it that in the first month you get a higher risk of nosocomial technical or donor related infections, donor derived viruses, and so on. And then during the first year, you get more of an increased incidence of opportunistic infections, and this reflects usually that the overall dose of the immunosuppression, including the induction therapies and the prophylaxis, then followed on by the community acquired. Although this is a nice paradigm to follow, which we think that the infections or the risk of infection for the transplant recipients over the course of transplantation can be predictable, and that we can know which type of infections can happen when. Remember that this actually changes, and the changes depends, the pattern of infection will change with alterations in the immunosuppressive regimen, with the duration and the type you choose of the prophylaxis and management of the microbial agents. So although we have that bacterial infections are common, we have patients who develop pyelonephritis 10 and 15 years post-transplant, as well as that you can see viral infections very late post-transplant, and so on. So it's not always that straightforward. Coming to neutrophilic tubulitis is a very important marker for the presence of urinary tract infection, even in renal allograft biopsies who are C4D positive. And you can always get, as we know, concurrent infection and rejection, because the presence of infection is going to trigger a rejection process. And this concurrent rejection could be T-cell mediated or could be an ABR mediated. And so the presence of neutrophilic tubulitis in a biopsy or within the report, even if it's focal, signals the fact that this patient could have a concurrent infection. And UTIs in specific has a persistent fingerprint over the graft, knowing that it can causes eventually fibrosis and decrease in the overall rate of graft survival. Thank you.
This is a very illustrative biopsy finding and figures for post-transplant graft infection, pyelonephritis. My question, Dr. Ahmed, before the biopsy, the urine analysis and culture was no positive data indicating?
عشان كان أخذ الانتيبيوتيك initially. يعني هو he started the antibiotic before collection of the urine
sample.
وده كان طبعا غلطة، بس كانوا يعني بيتعاملوا aggressively. يعني كان في باستلز طبعا، بس الباستلز ما نقدرش نفرق بيها بين الريجكشن والانفكشن. الحقيقه
ما هو لما يبقوا في النص
الباس سيلز and the sample urine test and
كان فيها بالظبط، او هو الليوكوسايت ستريز والنيوتروفيل جيلاتينيز والحاجات دي برضو ممكن تبقى هيلبينج اذا كانت دي بايوريا ولا ليوكوسايتوريا، والنيترايت نيتريت ريديوسينج تيست والحاجات دي كلها. الحقيقه هو السؤال المهم وبيفد على اخر سلايد وسام حطيتها، هل we should consider انه الانفكشن is precipitating، بالذات لما يكون pyelonephritis، مش بنتكلم على lower UTI، is a precipitating factor for rejection and it invites rejection. واذا كان البيشنت in such a situation ما هواش in severe sepsis وخايفين عليه من septic shock، should we give him steroids along مع الانتيبيوتكس to prevent fibrosis that might develop later on as a chronic result?
I think you have to start treatment early
in
the infection.
Yes.
And you have to revise if the patient have previous infections before UTI in the history. Very important, this will eliminate the etiology. And you mentioned that this patient is a male 44 years old.
مش common انه يكون عنده infection. Yes. ما هو مش متشخص بايلونيفرايتس بقى، ما هو ده الكلام يعني. بالعكس ده انا بسأل عشان كده يعني، انا ده اللي انا بقوله ده. على فكره مش حالاتي والله مش حالاتي انا، يعني بشوف الحالات at a later stage، لكن هو السؤال اللي هو ده فعلا common practice يعني، ده للاسف اي عيان زارع يعني هيعدي على ليفل بي نفرولوجيست مش ليفل ايه، وكرياتينين وارتفع شويه، اول حاجه هعملها انه هيديله ستيرويد للاسف.
يعني انا عايزه اقول لحضرتك ان انا I consider الانفكشن is a red tag. لما بتطلع البيوبسي فيها انفكشن، يعني اول اللي بكلم النفرولوجيست on the spot علشان to hold the immunosuppression، علشان بيبقى obviously it's not in the differential in diagnosis. Yes. دكتور مجدي كان عندك سؤال؟ No. No.
هي محطوطه فورمالين يا دكتور مجدي. هي محطوطه فورمالين.
ما محطوط لا we can't. What we can do is no.
Usam, I have a question. Were there any microabscesses in the interstitium?
No, he was not up to this. No. Or maybe it wasn't sampled.
Okay. Did you test for CMV?
For this patient, yes, we did. His PCR was negative.
Okay.
No.
دكتور احمد طبعا صار موضوع مهم جدا. لو احنا عندنا simple pyelonephritis طبعا you will treat as an infection and it's over، بس هو صار موضوع مهم جدا احنا بنشوفها في حياتنا، وانا هقول له my opinion. لو انت accompanied pyelonephritis with rejection, this is a very difficult situation. We should assess for the parameters of sepsis. ولو ما عنديش evidence of significant sepsis, I can start antibiotics, and very soonly after 3 days we can start just high dose of steroids and to follow up my clinical situation, and according I can adjust my treatment of the rejection according to the progression of the creatinine and the situation and the parameters of infection.
بس في الحقيقه الحاله دي الانترستنج فيها ان البيوبسي كانت بيور بايلونيفرايتس، ما كانش فيها element of rejection خالص، والمسج اللي فيها انه الكرياتينين بتاع البيشنت وصل ل 6.8 just out of the pyelonephritis. يعني ولو احنا رجعنا تاني بقى، لو العيان ده مش زارع وجاب الكلينيكال برزنتيشن دي وجاب الاي كي اي ده، كان ممكن ما يبقاش بايوبسيت، صح؟ كان في الغالب هيتعالج على انه بايلونيفرايتس بس، وهنعمل له كلتشر ونديله الانتي بايوتكس ونستنى عليه لما يفك. لكن لانه زارع يعني، وده يدل على انه في الكلينيكال باك جراوند بتاعنا او في السبكونشس بتاعنا الاليفيشن transplanted patient number 1 و 2 و 3 هو rejection. وعشان كده احنا سمينا الحاله ده often forgotten diagnosis.
I think we have to move to the next case.
It is very serious اهو الراجل. صحيح. It's very serious اهو. تمام. هو راجل فك الحمد لله خالص يعني. مسج ثانيه مهمه قوي، معلش هي عدت بس. الار اي از نون سبيسيفيك. الراجل ده الار اي بتاعه كان 0.9، وده يخلي الواحد يفكر ان هو انتي بودي ميدييتد كمان يعني على الار اي العالي ده، وفي الاخر طلع سيمبلي بايلونيفرايتس.
دكتور احمد برضو الار اي ممكن يبقى يعلى في اي بارنكيميتس.
ايوه ما انا عارف، ما انا بقول يعني دي المسج يعني تو كونفيرم ات. طيب اخر بيشنت يعني او اخر رابع كيس عشان اللي فاتت ما اتقالتش. could it be too late؟ لازم افكر في UTI، لازم افكر مع الريجكشن. يعني الريجكشن موجود بس لازم احط معاه بايلونيفرايتس.
بس يعني كلينيكالي كده ممكن قوي زي ما بتقول احنا كنفرولوجيست لا
هنقول ريجكشن. ما انا بقول لحضرتك ما انا بقول لحضرتك هي دي the often forgotten diagnosis. برضو دكتور مجدي اشار لنقطه مهمه، ودي نقطه مهمه قوي. العيان ده معلش دي نقطه مهمه. العيان ده 44 سنه، ميل، زارع من سنين، مش لسه جديد. يعني قصدي ممكن ما يتفكرش فيه انه اول حاجه ان هو UTI، يعني مش كلاسيكال سيناريو. تمام. حاجه على الماشي كده، انا شفتها 3-4 مرات يعني. لازم تتاكد ان العيان مش منسي فيه الدبل جي، مش منسيه فيه الدبل جي. يعني انا شفت دبل جيهات بقى لها 3 سنين و4 سنين وانكرستريتد وهي اللي عامله المصايب كلها يعني. طيب اخر بيشنت ان شاء الله. could it be too late? Mr. S is 65 years old male patient, unknown original kidney disease. He is transplanted من 19 سنة from unrelated donor. طبعا لما بيجي لنا واحد زي ده أول حاجة بنعملها إن إحنا ريلاكتنت قوي معاه يعني 19 سنة حلوين كده خدت حقها وزيادة يعني. We should not be that inertia, الفيزيشن inertia. ليه بقى؟ لأنه البيز لاين كرياتين بتاعه 1.1. يعني even ان هو زارع من 19 سنه لكن الكرياتين بتاعه 1.1. He is on triple therapy بس cyclosporin based with MMF and steroids. He had once DVT وكان مكمل عليها for unknown reason انه مكمل بقاله سنتين على نيو اورال انتي كواجولانت، وعشان كده اول ما جاء مع الدي في تي اللي شافه ما عملوش بايوبسي. الكرياتين بتاعه رفع ل 2.5 واليوريا 160 وبروتينوريا 2.4 جرام. راجل فيري كومبلاينت الحقيقه، يعني ضابط جيش قديم ومحافظ على نفسه قوي. الجرافت سايز 11 سم، انكريز ايكوجينيستي، بريزرفد سي ام دي، والار اي از نوت تو ماتش هاي. اليورين فيه بروتينوريا 1 بلس والوايت بلاد سيلز 10 ل 20 زي ما استاذ دكتور صبري قال، يعني مش السيفير قوي بتاع الانفكشن بقى، وار بي سيز 5 ل 7. والبيوبسي ذات هي ديد بعد ما وقف النيو اورال انتي كواجولانت كانت unfortunately inadequate، يعني طلعت البيوبسي ما فيهاش جلوميرولاي ولا ارتريول ولا مضله يعني. So he came for a second. ما كانش فيها حاجه، وسام ما كتبتش فيها حاجه. قالت لهم عيدوها. نعم. اللي انا فاهمه انه كان over 6 to 8 months. انا till this point انا ما شفتش العيان، ما اعرفش عنه حاجه. هو جالي for rebiopsy. كرياتينينه عالي من 1.1 ل 2.5.
اي ليمفوسيتك انفلتريت، اي بلازما سيل انفلتريت مفيش. تيبيولايتس. الميكروفون عندكم ميكروفون باين.
Okay, يعني what we can deduce from medulla is very limited, but C4D positivity, yes, we can do it in medulla. If you have suspicious costs, you can think of it in medulla. If you have amyloid deposits, yes, in medulla.
يعني
full stop, nothing else.
يعني partially الantibody mediated rejection partially.
No, because you have focal C4D, so it could have been not just represented in the medulla.
Okay.
Yeah.
بس هو يعني اي بايوبسي لازم انا بيحضرني وانا في انجلترا شورتلاند مره جات له بايوبسي وجاي يعرضها لنا في كلينيكال باثولوجيكال ميتنج، كانت سبلين. يعني اللي اخذ البايوبسي طلع سبلين ما طلعش كدني. سبلين والله، نيتف كدني طلع من ليفت كدني طلع سبلين. والراجل بعد ما قال لنا انفورشنتلي ميس ساره اللي كانت واخده البايوبسي دي طلعت سبلين، بس احنا شخصنا العيان طلع اميلويدوزس كونجوريد بوزيتيف، يعني عمل عليها كونجوريد وطلعت بوزيتيف، وطلع انه عنده برايمري اميلو وهي تايبد ات وطلعت برايمري اميلويدوزس من السبلين، فما فيش حاجه تترمى. البي ار اي كان 30% في كلاس 1 و0 في كلاس 2. So we repeated the biopsy. يلا يا أسامة.
Okay, this is an overview of the biopsy, and you can see this is an H&E stain already. You can see that there is tubular interstitial damage with interstitial fibrosis, a bit of a mild to moderate lymphocytic infiltrate with few plasma cells, eosinophils, extensive tubular atrophy, and not a normal glomerulus, as we can see on this power. Another field shows that yes, we have an element of tubular injury, more or less a globulosclerosed glomerulus, but there is also red cell fragmentation here within the tubules. and edema, and again here, and a very congested peritubular capillaries. Back to the glomeruli, you can see that this glomerulus looks like what you can call an MPGM pattern with peripheral segmental peripheral duplication of the capillary basement membranes and some endocapillary hypercellularity and glomerulitis. With the silver stain, you can detect the changes in the capillary basement membranes better, so you can see the duplication, yes, the duplication of the basement membranes, what we call the CG lesion. Again, here, a duplicated capillary basement membrane, and we have segmental glomerulitis here, typical endothelial swelling and lymphocytic infiltration, and early signs of mesangial sclerosis. As per his arteries, you can see this artery, it's thickened, but it's not only thickened. Yes, there is evidence of elastosis, but there are also some lymphocytes running into the media. And so although this looked more like a classic hypertensive lesion, especially with the hyalinosis, I also had a tendency to call this a form of CV or transplant arteriopathy. With the trichrome, you can appreciate more the fibrosis and the eye ifta, which is there, the inflammation on top of the interstitial fibrosis, but with no active tubulitis. So this does not count to be a chronic active T-cell mediated. And then you can see the C4D of this patient was positive. It was diffuse C3. So the patient had a transplant glomerulopathy and arteriopathy compatible with chronic active antibody-mediated rejection, C4D positive. He had a focal global glomerulosclerosis of 35%, moderate IFTA 40%, and moderate arteriolar hyalinosis. Ahmed?
دي الدايلما بقى، هي اصلا دايلما لوحدها، ولما تيجي بقى في عيان بقى له 20 سنه زارع تبقى دايلما اكتر. يعني عيان زارع من 19 سنه looks like انه كان ماشي كويس، كرياتينين بتاعه بيز لاين within the very good range، يعني 1.1 لغايه 6-7 شهور. لما وقع وعمل البيوبسي طلعت وحشه، يعني 40% افتا وسيجنيفيكانت سي تي جي، يعني دبل كونتورينج وترانسبلانت جلوميرولوباثي، which means انه definitely في كرونيك سي 4 دي بوزيتيف، البي ار اي بتاعه 30% بوزيتيف، فهو typical chronic active antibody mediated rejection. بلاش ندخل في الريفيو اوف ليترشر واللي انا محضره عشان الوقت يعني، لكن let's discuss كده مع بعض. يعني who would treat this patient aggressively؟ لا ما طب خلينا نقول الاول تريت وبعدين نقول aggressively. تريت. طيب خلينا بقى نقول اللي مكتوب في الليترشر في التريتمنت: بلازما فاريسز، اي في اي جي، ريتوكسيماب، اكلوزيماب، توسيلوزيماب، بورتيوزيماب. just increase او shift، بما انه هو سايكلوسبورين خليه على تاك ام ام اف. choices بقى. اللي هو اخر حاجه حضرتك اخترت، اخر حاجه انا قلتها.
Yes, you first you shift to tag.
ما هو ده اسهل حاجه يا دكتور مجدي عملناها دي من واحنا مغمضين.
There is no response.
ايوه. تديله قد ايه؟ يعني الراجل كرياتينه 2.5، عملت له شيفت تو تاك ام ام اف.
You will improvise. So if he's my patient, I will shift to TAC and I'll wait for 2 to 3 weeks. And if there is no improvement, I'll give him rituximab because of the less toxicity. I won't go aggressive because this patient might die of the aggressive immune suppression.
طيب دكتور مجد، دكتور جمال، ممكن نبقى
I would first screen this patient for any possibility of malignancy, carcinoembryonic antigen or de novo lymphoma. This might pave the way for a rejection or deposition of C4D and so on, and particularly we are doubtful about the basement membrane. هل ده glomerulopathy of chronic toxicity ولا ده membranous de novo؟ يعني can you tell us ان هو ده de novo membranous ولا transplant glomerulopathy؟ هل دي ترانسبلانت جلوميرولوباثي ولا دونوفو ممبرنس نفروباثي؟
يعني
لا ما هو الدبل كونتور ده ما انا فاهم يعني كان وي دايجنوز ممبرنس نفروباثي؟ اتفضلي.
Yes, of course, we could have you can have an associated membranous glomerulonephritis وعليها transplant glomerulopathy أو العكس. Yes, we know that de novo membranous GN is associated with de novo antibody-mediated rejection, especially type 2, which is late. But the beauty of C4D is that if you have a membranous glomerulonephritis, it's going to light up within the glomeruli because it has a different pattern than the linear pattern you can see within the transplant glomeruli. We can exclude membranous nephropathy.
PTC صح.
According to the data we have in the biopsy, according to the aggressiveness, I will be aggressive, yes or no.
ما ده اللي بسأله.
ما هي لو هي أنا شايف إنها aggressive.
Yes or no.
I would be to the aggressive side a bit.
Yes.
وعايزين الديتيلز اوف ذا اجريسيف مانجمنت. وات وود يو دو دكتور جمال؟
زي اللي انت قلته بالظبط. I would switch from cyclosporin to
ده مش اجريسيف كده.
ما هو ثواني بس هسويتش اول خطوات الاجريشن ان انا هنقل من السايكلوسبورين للبروجراف.
دي كلنا متفقين عليها يا جماعه ودي مسج لكل الناس. يو هاف تو اوجمنت وده بيسموه الريسكيو ثيرابي.
الحاجه الثانيه ان انا مش هستنى كتير. I would give a single dose of rituximab or IVIG with plasma exchange and see the response. هشوفه بيتصلح ولا لا to continue.
very expensive.
الحقيقه
yes I have a comment.
الحقيقه يعني معظم الحالات اللي زي كده presenting that they don't usually respond للبلازما اكسشينج والاي الاغلبيه الاغلبيه
30% بوزيتيف في HLA1.
دكتور احمد
الحالات اللي زي دي انا لما بلاقي فيه marked microvascular inflammation as a marker of activity بديله ريتوكسيماب على اساس ان هو هيقلل لي المايكروفاسكولار انفلاميشن وساعات اديله ستيرويدز كمان معاها وان ات از نوت اكسبنسيف. يعني انت لما تيجي تحسبها هتلاقي ان هو بيكلف له بالكثير خالص 20,000 جنيه.
So and I just want to say I have a single comment before we close up this type of management, which is actually out of personal experience with some يعني more or less recent papers regarding الissue بتاعت transplant glomerulopathy والprognosis. هو in these patients when you have يعني the factor
انا عارف ان انت متعاطفه جدا مع العيانين
لا والله لا خالص ثانيه. طب هقول لك الكوست بنفيت يا دكتور صبري اصبر علي. I have a cohort of patients who've been diagnosed transplant glomerulopathy والعيانين دول were treated with retox and plasmapheresis and with several repeated biopsy واحنا we're preparing them now to be published for over مثلا 2 or 3 يعني over the span. البيوبسي كانت repeated in 12 months to another biopsy in 10 months. اللي بيحصل ان العيان الكرياتينين بتاعه بيلاند وبعدين بيرجع يعلى تاني. And what's really impressive is that it's as if you're looking at the same biopsy. التارجت في العيانين دول if you can maintain فعلا the kidney state وده في مصر يعني احنا مش بقى يعني in some centers and you can see that الترايل at an aggressive طبعا weighed out a management but preserve the status of the kidney. You prolonged this graft for 2 to 3 years with evidence and with pathological evidence. فهو مش كله بيبقى التارجت the graft as it is will stable with a stable state. Then I think it's always worth a try.
يس دكتور احمد انا بس هقول هنا نقطه واحده بس. انا مش هدخل through الليترشر ريفيو لكن في الجايد لاينز there is a differentiation between الكرونيك اكتيف والكرونيك inactive.
يس
ف we should take كلمه كرونيك اكتيف طالما فيها وهي ما نعرفش نفرقها غير بالبي ار اي والهيستولوجيكال ايفيدنس. سي 4 دي واخد ليفل 2 ولا 3 بي تي سيز تقيله. العيان ما عندوش هيستوري قديم لانه كان معاه قبل كده كرونيك اكتيف وجاي لي بعد 6 شهور فخلاص هقول بقى خلاص ده بقى كرونيك مش كرونيك اكتيف يعني. اتفضل بيه
حضرتك. طبعا كل اتقال مظبوط بس انا هقول ماي اوبينيون لان ده several cases I have confronted by this aspect. في برضه recommendations في الجايد لاينز مهم جدا. الديوريشن انا بتكلم دكتور احمد بيقول كدني بقى لها years 1.6 1.8 ولا احنا بنتكلم 7 months ago احنا عندنا كان totally normal kidney functions. انا عارف ممكن تكون في histological changes even if we have a normal kidney functions. وحصل within few months rise of the creatinine. I think وعندي several cases مع الدكتوره وسام اشتغلناهم مع بعض. I will give 3 sessions of plasmapheresis plus IVIG followed by rituximab and I will see the response. If the response that I have declining kidney functions and improvement of kidney functions, وعندي several cases like that, I will continue to reach 5 to 6 sessions plasmapheresis. If I have no relevant improvement, I will hold the 3 sessions.
على الخط الجامد خالص ان هو بيعالجه كانه
لا لو حصل
improvement
يا دكتور احمد لو improvement of the creatinine after 3 sessions.
دكتور حسين بس let me
ولكن
انا هقول كلمه وهسيبك تكمل. There is no guideline. Which guideline are you referring to?
لا مش guidelines.
Which guideline? You said the guideline.
ان انا في عندي recent.
It is a center oriented management.
Recent. بص يا دكتور مجدي انا عندي recent kidney كانت few months ago.
لا بس انا مش معترض على كلامك. انا معترض انك you tell us in the beginning it is a guideline.
لا مش guideline. مش guideline. هي مش guideline حضرتك. هي عباره عن experience وفيها جزء منها ان انا بشوف السيتويشن على بعضها كلها.
طيب بص بقى ده الفاينل وزي كل مره بنفلس وبنرجع لوسام تاني. البانف حلت لنا الموضوع في الابديت بتاع 19 وقالت ان الحالات تتقسم هيستولوجيكالي. اذا كانت فيها سيفير جلوميرولايتس وبيريتيوبولار كابيلارايتس وفي نفس الوقت الساينز اوف كورنيستي عندها الكرونيك انفلاماتوري انفلتريت والتيوبولايتس والسي 4 دي عالي، كل ده ماشي مع انه في اكتيفيتي تقيله وكورنيستي قليله. شبه كده ما بنعمل في اللوبس لما بنري بايوبسي عيان لوبس عشان نشوف هاي اكتيفيتي اندكس ولو كورنيستي اندكس نكمل اميونو سبريشن ولا العكس نوقف اميونو سبريشن. وفي انترميديت كيسز وفي العكس بقى مايلد اكتيفيتي وسيفير كورونيستي. فلو الفايندنج بتاعه البيوبسي بتبوينت تورد ان انا معايا ستيل سيفير رغم انها كرونيك لكن فيها سيفير اكتيفيتي ومايلد كورونيستي we should go for زي ما دكتور حسين قال. فاحنا في بقى شويه كلينيكال فايندنجز ثانيه ربما من اهمها البروتينوريا والبي ار اي ليفل. البروتينوريا كل ما كانت ازيد كل ما كانت باد اومن to lose the kidney over the next 6 months وكرونيستي عاليه والفايده في الاميونو سبريشن اقل. لا عامل بي ار اي 30% في كلاس 1. لا ما انا مش عارف دي اس اي بس الام اف اي كان فيهم حاجات 6000 و8000 يعني ما هو ما عنديش دي اس اي بقى انا مش عارف الدونر. عالي ام اف اي 6000 و11000 تمام يعني دي كده تمام. ودي الباد اومنز فور جرافت لوس زي ما احنا قلنا يعني من اهمها البريزنس اوف بروتينوريا طبعا والبي ار اي برضو العالي وبقى اللاين اوف تريتمنت يعني ده الاكسبرت كونسنسس لانه زي ما قلنا برضو ما هواش يعني جايد لاينز والكلام فيه خلاف كتير يعني. اتفضل.
السؤال ده هو فعلا في سب سنتر اكسبيرينس لها بس حاجه زي دي في
الكرونوستي السيفير what is the benefit of that if I have 3 or 4 patients like that and I make aggressive and even the interstitial fibrosis is less than of this around 25 and they retard the deterioration of kidney function for how long? 1 year? And so I expend more than cost more than 1,000 pounds.
بص حضرتك
لا this patient I talk all about this patient.
من 6 شهور كان كرياتين 1.1.
This patient is 19 years.
ايوه لكن كريات كان 1.1 من 6
احمد
شهور.
الجي اف ار
ايوه عشان البيوبسي مطلع 40% افتى.
لا
but you told
يعني وده يدل على انه الكرياتين لوحده مش كفايه.
you inform us this patient is compliant with medication and he is stable
1.1 creatinine
and
to
you
start
don't
with
have
is not normal
and you don't have any
65 years old male
and you don't have any biopsies before
صح.
to inform about the kidney what is happened for that. So, and sometimes for acute antibody mediated rejection there is subclinical and creatinine is normal and on biopsy you have this problem.
يا جماعه احنا بلد فقيره واحنا اللي بندفع الفلوس دي في الاخر للحكومه. يعني احنا اللي بندفع الثمن، وفي كل البلاد اللي خلقها ربنا وفي اعتى واغنى بلاد الدنيا في حاجه اسمها كوست بينيفيت. لازم تحكم عقلك. وبعدين انت هتصرف لي 150,000 جنيه على عيان كويسنبل وفي الغالب مش هيخف. طب ما انا ال 150,000 جنيه
ازرع له تاني،
ازرع 10 عيانين تانيين، ازرع 10 كلاوي
بس مفيش كليه.
دكتور حسين الفيشاوي.
خليني بس معلش
صبري، انا بس عايز اقول حاجه بس صبري، ان انا حضرتك مش
دكتور حسين انا هسالك سؤال عشان احنا we need to be illuminated.
Yes.
What is the survival of such patient? What is the
اهو يا دكتور مجدي وراك اهو الكابلن ماير اهو.
ثواني انا احب اقول
في فرق significant in the 5-year survival.
How much؟
اهو
كم سنة؟
الفرق 5 سنين. فرق ال 5-year survival حوالي 40% بين الاجريسيف والكونسرفتيف تريتمنت. 82 عيان.
هي الفكره يا دكتور صبري في حاجتين بس.
82 عيان.
الفكره في حاجتين يا دكتور مجدي. الفكره حضرتك ان أنا اول حاجه ان انا عندي،
ما هو دول بقى اللي على البان في 19 خدناهم لا خدناهم في الجزء اللي فيه مايلد كرونيستي وهاي اكتيفيتي.
البوينت
ما هو خلاص، ما احنا يعني خلينا بس نتفق ان احنا اتفقنا اول حاجه ان احنا هنكلاسيفاي اكوردنج للباثولوجي. ده اهم حاجه. لو طلع هاي كرونيستي ومايلد اكتيفيتي هديسكارد التريتمنت. اكتر حاجه هعملها له ان انا هاسكليت التريبل اميونو سبريشن اقلبه بروجراف بيست. لو طلع الليفت هاند سايد يعني هاي اكتيفيتي ولو كرونيستي هدي اجريسيف بقى.
موافقين
بس خلاص.
ما دكتور احمد انا هنا مش لازم ادي اجريسيف من الاول.
ما هو اجريسيف ده اللي هو
مش تدي
في بوينت بس انا احب ادسكاس مع استاذي الفاضل الدكتور صبري جوهر ان الفاينانشال ايشو از ريلي امبورتنت. يس
طبعا،
بس وي شود كونسيدر
ان مفيش اورجنز،
ان مش بس مفيش اورجنز، ان with retransplantation we should have a living donor and a very highly matched donor، ولازم يكونوا 2DR احسن من 1DR.
طب انا بقى
فالافيلابيلتي ده تبقى
لا انا هقول لحضرتك حته زياده على الحته دي من نفس النقطه دي. في بيبر بتتكلم على انه العيانين اللي عندهم، ما هو احنا عارفين ان دول اصلا في السكند ترانسبلانت هيبقوا وحشين.
ايوه،
العيانين اللي عندهم chronic active antibody mediated rejection and they have been treated aggressively, they will do better in the next transplant.
Yes, I agree.
لأن أنت already عملت له some sort of desensitization قبل ما تزرع.
We should not deny any patient any chance of improvement حتى لو عرفت أطول الجراف survival 1 or 2 years. دي برضه I believe of benefit. دكتور أحمد.
Dr. Ahmad, we enjoyed your interesting cases and the updated review of literature, and we all have enjoyed and have update. And because of the time, we have to close the session and to shift to the next session.
Now we have a very important session which will be including several speakers, eminent speakers from the United States, and we will have the last talk to be presented by the eminent figure, Sir Magdi Yaoub. He will give us his talk about left ventricular devices versus regeneration. And we will start the session exactly by 3 o'clock, and you can have your coffee break and come be attending here. We might have time for discussions, but I think we'll be starting just on time.
انا ما عادش والله حق كلامك انا عايز اشرح نقطه بس حضرتك بقى استاذ ده حق عليا ما اقصدش طبعا حضرتك وراسي
الدكتور هشام بدوي والدكتور حازم الشاطر. يا رب ايوه بتقول طبعا تحت رعايه هو مش هيجي بس الدرع والصابون
يا دكتور صعب حضرتك ايه هو كله تمام زي دكتور مي حضرتك ايه
الساعه كام معاك بالظبط
عضله مش هيدي برودكت مانجر يوتوبيا ان شاء الله بقى حضراتكم تقعدوا حد بعت لحضراتكم الشنط بتاعت
احنا عندنا
لا ايه سنتي لسه بقى خلاص انا هكلمهم على قدها بس الكميه اللي انا
let us start this very important session about the novel approaches in kidney transplantation. which will be moderated by our dear colleague, Dr. Mohammed El-Tamami. It will include 4 main topics, and we will be privileged at the end by having another talk, which will be delivered by the eminent figure, well known to all of us, Sir Magdi Yaoub. He will be presenting the topic of left ventricular assisted devices versus regeneration. We will start first by the topics which will be presented by our colleagues and professors from USA, and the session with the moderation of Dr. El-Tamami. He is an associate professor in the Lerner College of Medicine and Staff Physician in Cleveland Clinic main campus. He finished his medical school and urology residency at Cairo University. He completed the kidney and pancreas transplant fellowship at Cleveland Clinic from 2016 to 2018. He completed a second fellowship in minimally invasive surgery and robotic surgery at Cleveland Clinic in 2019. He joined as a staff. Dr. Magdi, the floor is yours to moderate the session and lead the discussion as well, and we are joining with you.
Well, thank you very much for having us. It's a great pleasure as always. Thank you for having us all. I would like first to start right away by introducing Dr. Jihad Kayuk, who will be delivering the first talk about the use of robotics in kidney transplantation. Dr. Jihad Kayuk is the director of the Center of Robotics and Image-Guided Surgery here in the Cleveland Clinic. He is also the vice chair for surgical innovations and enterprise and the past president of the Society of Urologic Robotic Surgeons. For those who do not know him, Dr. Kayuk is one of the most prominent names in the field of urology, not only because he's one of the best surgeons, but because he invented many of the surgeries and techniques that we are using now. On a personal level, I was lucky enough to have him as my mentor during my training, and I'm proud to call him my colleague, partner, and older brother. Dr. Kayuk, please go ahead.
Thank you so much, Dr. El-Tamami, for your kind introduction. I am honored to join you today in this esteemed meeting with all the esteemed chairmen, moderators, and panels today. You picked an exciting topic, but before I go to my topic, I want to say that any successful team is built on successful group of people. And here at the Cleveland Clinic Urological Institute, we are fortunate to have talents from all over the world. And Dr. El-Tamami is a great example where he came with a talent of kidney transplant, acquired a superior talent in robotic surgery, and his baseline amazing open skills. So a well-rounded surgeon that every surgeon would like to have him beside him when doing difficult cases. I'm proud to call you a friend too. My topic is about what's new on robotic applications in kidney transplantation. And let me just share my screen, please. I will start my slides now. You see my screens, Dr. El-Tamami? Okay. I will start by a couple slides introducing where this presentation is coming from today. We are in Ohio, at the northeast part of the United States, in Cleveland. This is the campus of the Cleveland Clinic. In the last 22 years that I joined the
الصوت يا جماعة.
Can you hear me, Dr. El-Tamami?
Yes, we can hear you now, Dr. Kayuk, yes.
Okay. All right, great. So this is in my last 22 years that I joined the Cleveland Clinic. The campus keeps growing. It's like a mini city, as you can see there. Definitely, it's really cold nowadays here. This was my commuting to work just 2 days ago. Good for hypothermia, organ transplantation. The kidney transplantation and robotics is not a new topic. It started around 2002 by Dr. Hosnek, who at that time got the Da Vinci system to do parts of the first robotic kidney transplantation. At that time, it was done open surgically, but he docked the robot to do the anastomosis through the open incision and complete the transplantation. This was published back in 2002. Since then, many developments happened in the applications of robotic for kidney transplant. And the main goal was to try to decrease the morbidity in obese patients. And we have a population that's really heavy in this part of the world. Many publications, as you can see in this small list here, have went through all the different applications of robotics. And you can see that the incision is 5 to 7 centimeter plus few other small incisions for the robot arm. Although it's mentioned here that they are done retroperitoneally, the approach is actually robotically transperitoneal, and then the kidney may be positioned in an extraperitoneal position. Some, after the maturation of this initial robotic application, now we start seeing some comparison between the robotic and the open approaches. Dr. Ahlawat is a very prolific surgeon using the robot for kidney transplant in India. And you can see when comparing open to robotic, what really makes a difference here is that the incision may be a little bit smaller, the pain score is a little bit less, but with the same good outcomes as the open approach. Over all these first 10 years, from 2002 till 2012, not only the procedure was improving, but also the robot system itself kept improving, and we kept getting better generations of the robotics. The most recent one is the single port robot that you can see a picture up there in the right upper corner. And the main feature of it is that it has a low profile, and this low profile allows us to put all the instruments through a 2.5 centimeter incision. You can have the camera, you can have 3 instruments, and the other feature is the camera. It's articulating, so you can steer it around corners to look, in different areas without much clashing with other instruments. So to summarize, now we have a new robot that allows us to do a small incision, 2.5 centimeter, with instruments that are double jointed and with a camera that articulates, and we can float duck the robot, move the robot almost to the skin level so that we can do surgery in shallow areas robotically. We took advantage of this new robot since it is a narrow profile, so that we wanted to limit the surgery to where the organ is. So if the organ is extraperitoneal, there is no need to go transperitoneal, move the bowel, cause ileus maybe, and then go to the extraperitoneal. We want to limit our surgery to the vicinity of where we have the organ we're operating on. And we want to do that through the least invasive way possible, smaller incision, less dissection, and by that hope that we can minimize further minimal invasive surgery. Since we were the first to get this system in the country in September of 2018, since then we've done now more than 600 cases of all different applications. We did not try to replicate what we do with the multi-port robot. We rather, as I said, try to go through narrow areas that the multi-port robot could not allow us to do. So we do a lot of our prostatectomies, for example, by going percutaneously through the bladder, transvesical, as you can see. We do the perineal prostatectomy, not open, but with a robotic incision between the legs of the patient, and so on. And one of the applications is the kidney transplantation. And I'm gonna go into the details. This is the first publication that we presented our first 100 cases experience. And the kidney transplant itself done with a single port, we started it in October of 2019. We've done now about 12 cases or so, and with great initial success. I will go into more detail about that. This is here just a quick animation for those who are not used with how we get the robotic access. So there is a special port that allows you to keep the robot tip outside the patient body so that you can work in shallow areas and not need to go through the big abdominal cavity. We can do all this from an infraumbilical or periumbilical midline incision and stay extraperitoneal throughout the case, that we can get the kidney in from that incision after preparing the vessels and do all the steps that you elegantly presented throughout the day in your esteemed meeting today. This is the way the operating room is set up. So there is a mild tilt of the operating table, and we make the incision that's just in the midline, infraumbilical, as you can see, and then we put the ports in, and all this is extraperitoneal. And this is how a quick clip of the preparation of the vessels. Here's the external iliac artery, and same as you would have done robotically, multi-port, or even with the laparoscopic approach, because some of our colleagues even tried this surgery laparoscopically. It's definitely a little bit more cumbersome and ergonomically challenging though. And this is the iliac vein. The vessels are being prepared, and we use really no fancy instruments here, a grasper, a scissor, sometimes a hook, and vessel loops. And this is all in the extraperitoneal space, so you don't have to worry about the bowel coming close to you, because once you insufflate and create this gas bubble, it will push the bowel out of the way with the peritoneum. And here are some of the really contributions of Dr. Altamami here, that small tweaks make a big difference. So this is when the kidney is benched, so nothing new about benching, right? But one of the tips and tricks is that you want to keep the kidney dry as much as possible when you transplant it. So Dr. Altamami came up with the idea of having the vessel sealer or ligature to on the bench, prepare the kidney so that all these tiny vessels will be sealed and will not have oozing. Also, a double J stent is placed in the specimen on the table before we get the kidney in, since it's less cumbersome than intracorporeally. You can see this kind of a bandetta there, a ribbon, so that we can have a handle to grasp the kidney and position it. We've done it in some cases. I know that the common thing is to wrap the kidney with a gauze and have ice inside, but that is not as slippery to go through a very tight incision. So we had a glove that we cut the fingers of the gloves there and put the kidney in it. It has a slippery wall that allows us to squeeze that kidney in. Also preparing the markers, as you can see, this striated blue lines, this is what's gonna be anterior facing the camera when we are doing the anastomosis before we flip the kidney to the side. These are the golden hands of Dr. Altamami here, preparing the kidney to be inserted through the tiny incision, just enough to squeeze the kidney in. And we have the ice already inserted, the vessels already prepared, and then we focus on the anastomosis. Here you can see the marked blue lines, as I mentioned before, and here is the clamping of the vessels, and then the venotomy, and then the surgery will be kind of business as usual. It's almost routine. One advantage that, again, one of the tips of Dr. Al-Timami in this case was to introduce the Gore-Tex suture to us in robotics. And here we're using a 6.0 Gore-Tex sutures that have no memory, so it doesn't, coil in front of you much. At the same time, it's very resilient to hold the stitch. Remember, the robot have no tactile feedback, but even with no tactile feedback, the 3D visualization allows the surgeons to adapt, and without tactile feedback, we can suture with 6.0. Actually, we've sutured even with 8.0 when we used to do nerve grafts in some cases after prostatectomy. This is the completion of the venous anastomosis. And now we are gonna put some of these bulldogs. So the bulldog is still work in progress. There are some procedure-specific bulldogs that are being in the making as we speak, and hopefully we'll have more intuitive kind of bulldogs that we can use. This is the puncher, and you can see that the puncher can be introduced through a stab incision at the ipsilateral lower quadrant of the patient. This is the heparin flush. And after that, we start the anastomosis with the same kind of Gore-Tex suture, as you can see, and with the same sequence of event that otherwise this procedure is done open surgically at our center. You can see that we have excellent visualization. So this procedure is perfect for obese patients or patients who've had significant amount of pelvic and abdominal surgeries previously. We can really stay extraperitoneally and not worry about what's happening, how much scar tissue on the other side of the peritoneum. We're still in our learning curve, but even with our early learning curve of about 12 cases, we're very happy to tell you that, knock on wood, we've not had a single major complication so far. Sure, patient selection is important, and so is the team experience and attention to detail. So that completes the anastomosis. And then we put only 2 clips to hold this glove together. So we thought about everything we can that will not make it cumbersome for us to move on. This is here the urethral anastomosis. So see, this is one of the older movies that we didn't put a stent first, but nowadays routinely we have the stent pre-placed so that by the time we come to the anastomosis, we don't have to spatulate. The ureter is already spatulated, the stent is in, the bladder is full with saline, and we just do the anastomosis, as you can see there. I'm gonna move a little bit this movie forward. Oh, before that, you can see at the bottom of the screen that cartoon kind of a picture with the camera in blue and all the other instruments. That's another feature of this robotic system, that it gives you a map of where your instruments are at all time. So by that, you can minimize clashing and keep the instruments in a safe location. And here, that's the completion of the anastomosis. And the procedure is done. This is the graph showing the kidney function based on the creatinine post-op, and you can see that all patients that we've done so far did really enjoy a good outcome and function of the kidney from as expected in a good follow-up. We also compared our initial robotic single port to our open approach. Remember, we have a very high volume open kidney transplant approach, so it's not easy to compete with a top team. And even with that, we could see that there is a trend to less use of pain and medicine and narcotics. So the patients enjoy less ileus and less pain control when we are doing the single port. We expect to have this approach even more competitive when we select patients who are only obese, heavy, and pose a challenge to the open approach. So again, to summarize, really this use of a single port robot that allows us to keep all our instruments in an area very close to the organ we're operating on. So here it's the extraperitoneal location of the kidney itself. This is immediately post-op at the very end of the case. This patient had a lot of previous abdominal surgeries. This is the incision that we used. And on the side, you can see that tiny incision where we put the puncture that we do in cases of living donor transplantation. The last couple slides, we presented our initial series in the last European Urological Association, and it was very well received. I must really give credit to the Transplant Center at the Cleveland Clinic, that without them, we would not have been able to get that single port applications in. The Center of Transplant is directed by Dr. Alvin Wee, and Dr. Muhammad Al-Tamami is really the center of gravity of this program, given his transplant and his robotic expertise. Couple of acknowledgements for preparing the slides for our fellows who really do all the heavyweight lifting, Dr. Abu Zainab and Dr. Tuna Beksak. This is my Twitter handle at Dr. JKUK. We put a lot of our new surgical applications on it. And with that, I want to thank you so much for the opportunity to present today. Thank you for your good listening. Dr. Al-Tamami?
Yes, thank you so much, Dr. Kayuk. As always, very interesting applications of the robot. The most novel approaches you will always see by Dr. Kayuk. He's a surgeon who is known to push the envelope and innovate and also improve on what we already have. Thank you so much for the kind words and for the excellent presentation. And now moving on, I would love to introduce Dr. Santosh Nagaraju. Dr. Santosh completed—
Dr. Muhammad, can we ask a question, please, Dr. Muhammad?
Yes, yes. You want to have the questions after each presentation?
Yes, for this presentation, yes, please.
Please, please.
You mentioned that it is dependent on the patient choice, and this is very clear. But do you have any incidence of switching from robotic to open surgery, and what was the outcome?
Do you want me to answer that?
Yes, Dr. Kayuk, please. Yes, please.
Oh, all right. Yeah, that's a very good question. Sorry if I didn't clarify. Converting to open surgery from any minimal invasive approach, if done electively and with a thoughtful way, it's not a complication. And we should always have that as a second option, even if the surgery is not, having a complication, but let's say slow progression or so. So far, in all the cases we've done, we've really spent a thoughtful time selecting the patients, and we've not had any patient that we emergently aborted. So all the cases we've done so far, and this presentation today, have been done, as planned with the single port robot.
Any other questions from the floor?
All right. Thank you so much for the invitation.
Thank you. Thank you, Dr. Kayuk. Thank you. All right. So we moving on now. It's my honor also to present Dr. Santosh Nagaraju. Dr. Santosh completed his fellowship training in transplantation in Indiana University, one of the powerhouses of transplantation in the United States. He had done basic research on xenotransplantation in the lab. and he is currently my partner in Cleveland Clinic. He is based in Charleston Area Medical Center in West Virginia, one of our busy affiliated transplant programs. Dr. Santosh, please go ahead.
Thank you, Mohammed, for the kind words. So my presentation today is about xenotransplantation. I had the good fortune of doing research in xenotransplantation at UPMC before I started fellowship in Indiana. And during my time in the lab, we did xenotransplantation on non-human primate models using transgenic pigs. And we did experiments on heart, liver, kidney, and in islet transplantation. I have no industry or financial disclosures. When we talk about the history of xenotransplantation, we can almost trace it back to mythology and early human civilization. Greek mythology talks about Icarus, who had wings that were made by his father, and in their attempt to cross the sea, Icarus flew close to the sun and met his demise, but his father was able to successfully complete the trip. In the Hindu mythology, there are many deities who are considered half human, half animal, and early civilizations like Mesopotamian civilization had Lamassu, who had the head of a human and the wings of an eagle and the body, and this kind of has been also chosen as the mascot for the International Xenotransplant Association. But xenotransplant, if we really think about it, started early in the 17th century when doctors experimented with blood transfusions from animals to humans. And later on in the 18th century, we had some experiments showing skin xenotransplant as well as corneal xenotransplant. Solid organ xenotransplant came into being mainly in the 20th century when Alexis Carrel was doing his experiments early on, perfecting the technique of vascular anastomosis. And subsequently, Dr. Jebolet in France was the first one to try a xenotransplant wherein he did a pig kidney that was anastomosed to the arm into the cubital fossa, anastomosing the vessels onto the cephalic vein and the brachial artery. There were other experiments that were carried out without much success. And in 1964, at Tulane University in New Orleans in USA, Dr. Reemsma was the first one to report successful transplant of chimpanzee kidneys into humans. He did a series of 13 patients, and they all had an average survival about 1 to 2 months. However, one patient survived as long as 9 months, went back to a functional life, was actually a teacher in a school, and survived for 9 months. Even at the time of his death, which was unfortunate, there was no issues with the kidney as such. He probably had electrolyte imbalance and suffered cardiac arrest. In the same year, Dr. Starzl in University of Colorado did baboon kidney transplants and had 6 patients that received baboon kidneys. And he had survival rates of 19 to 98 days. Both series, of course, reported early graft function, urine output, and a drop in serum creatinine. But because immunosuppression was still in its infancy, they were not able to have long-term outcomes. And in both series, they actually did the transplant in the extraperitoneal way, anastomosing both kidneys from the non-human primate into the pelvic retroperitoneal space. In terms of heart transplantation, inspired by Dr. Reemsma's kidney transplant experience, Dr. James Hardy tried a chimpanzee heart into a patient who was in severe heart failure and semi-comatose. This was met with a lot of critique because of questionable medical ethics and the role of informed consent. So Dr. Hardy did not proceed with further advancements. But in 1984, there was a worldwide attention that was brought to Loma Linda University in California when Dr. Leonard Bailey did the baboon heart transplant into baby Faye. This baby was born with congenital hypoplastic left heart and received this baboon heart and survived for 20 days. She had acute rejection, and this was presumed to be secondary to blood group incompatibility. And however, this also raised a lot of ethical questions, which were mainly related to the role of consent and the role of parents in medical care for children and infants. However, this did spark some interest in xenotransplantation. The early experiments were all wherein the donors were non-human primates, because in the evolutionary terms, non-human primates are closer to human beings than pigs. But when we think about an ideal source of organ, why do we use pigs? Well, there are a lot of advantages of pigs, because over the period of time, we have identified that pig physiology is more closer to human physiology. And the best thing about this would be that there is already a good way of breeding and availability of pigs. And the time period and reproductive maturity for pigs is much lower than for primates as such. So with all of these factors in mind, over a period of time, we transitioned from non-human primates to pigs as the donors. Wild-type pigs are definitely not a match, because in the evolution, there is a change in the genetic composition, mainly in the blood genes and the blood group antigens. So we had to come up with ways to make genetically modified pigs called transgenic pigs. In early 80s and 1990s, the advanced technology that was available was called somatic cell nuclear transfer, wherein the nucleus of a fibroblast or cell line was modified, and the nucleus was extracted and implanted into an empty ovum obtained from a pig sow, and then this ovum was inoculated and cultured into embryos, and finally the embryo was transferred to obtain a pig. This was not as efficient and was more cumbersome, and this had limitations in the extent of genetic modifications. In the early 2000s and in the 2010s, newer technologies came into being, especially called gene scissors, and which have specific ability to divide gene segments at specific locations and also insert selective genes. The most common ones nowadays are the zinc finger nucleases, the TALENs, and CRISPR. And the advancement of CRISPR and CRISPR-associated protein technology, now we are at CAS9, and that has enabled a lot of modifications of genes to help come up with pigs which are mimicking human immunology. So this is just an illustration to show what these gene editing looks like, wherein an empty embryo and the gene targets are isolated, and you can either delete gene segments for unwanted antigens or insert human gene segments that can express human antigens on pig surfaces, and then you make this transgenic embryo and use it into a surrogate and do the get the genetically bred pig. So to understand the immunology, the main immunology in transplant comes with the blood types. Blood type A and B are the common blood types in the humans that are studied, and the equivalents in pigs are blood type A corresponds to the alpha-gal antigen that is present ubiquitously on all the tissues and blood cells, and blood type B corresponds to NuGC, which is a neuraminidase based carbohydrate antigen that is present on the cell surface. Similarly, like HLA, there was also identification of swine leukocyte antigen, which are responsible for immune activation in the pig immune system. And we have identified class 1 and class 2 swine leukocyte antigens. Interestingly, when we are doing in vitro experiments with these, we've noted that some HLA epitopes can generate anti-HLA antibodies, which can also be cross-reacting with the swine leukocyte antigens. And some humans have anti-swine leukocyte antigen antibodies, but these antibodies are not reactive to the human leukocyte antigen. So it makes this immunological mix interesting and challenging. So after identifying these basic glycoproteins on the cell surface, we've gone on to do transgenic pigs by deleting these antigens. So first was the GAL knockout pigs, and then they came up with the NewGC knockout, which were called SEMA because that is the enzyme that codes for NewGC. And then they came with the beta-4-gal NT2 gene knockout pigs. So a combination of all 3 gene knockouts is called a triple knockout. And apart from that, we were able to insert human genes into the pigs, like I said. And of this, complement and coagulation factors like CD55, which is the decay accelerating factor that is seen in nocturnal hemoglobinuria, and human CD46 and thrombomodulin, etc., have been inserted to reduce coagulation activation and complement activation. The graph on the right shows actually the reaction of these different type of pig WBCs to human antibodies. And when you see the graph, we see that the wild type has excessive binding to IgM and IgG, and the single knockout and the double knockouts have much lower. But when we come to triple knockouts, the binding of the immunoglobulins to the pig RBCs is so comparable to that of humans that we have finally able to accept triple knockout pigs as close as human tissue and human organs. Now the quest for the perfect donor pig, because it is not just deletion of few antigens and addition of few human genes, but it's an ongoing process. From what started as a single knockout pig, now we have pigs that have at least 10 gene modifications that have been used in clinical settings for xenotransplant experiments. In the non-human primate models, we have had success wherein pig kidneys were transplanted into non-human primates, and we've had survival for greater than 1 year. The experiments were ended at 1 year because of financial constraints and meeting the expected goals and endpoints, but more than 1 year survival with a functional organ and normal serum creatinine was noted in kidneys. Similarly, in islets, monkeys were made diabetic by giving them streptozotocin, which is a pancreatotoxic drug. And after that, they received intraportal islet infusions from transgenic pigs, and they were able to successfully convert these diabetic monkeys into normal glucose metabolism, and they've had survival for more than 1 year, even in this model. There has also been studies of heart transplant into non-human primates. The early studies were wherein they were trying to assess just the feasibility and monitoring. So the heart was transplanted into the abdomen, wherein there was easy access for percutaneous biopsy as well as ultrasound monitoring. And then subsequently, orthotopic heart transplants were also done, and they both reported success with survival and function for more than 6 months. The interesting thing was that they had to address gene modifications to prevent the heart from growing and hypertrophying, because in orthotopic transplantation, the size of the heart becomes extremely important. With all this history and ongoing research, the first public report of a clinical xenotransplant wherein a kidney was obtained from a transgenic pig and transplanted into a human was reported by the group in New York. This was a single knockout pig, a gal knockout pig, and the kidney was transplanted into a patient who was a brain dead donor but was not a candidate to donate any organs. The kidneys were transplanted extracorporeally and anastomosed to the iliac vessels, and the kidney's function was studied in terms of urine output and creatinine clearance for the first 54 hours. The results of this study were not published yet, and this was just reported in the news as the first ever trial. Similarly, Maryland University also reported in the news about successful heart transplant from a transgenic pig into a patient. The recipient was a 57-year-old man with terminal heart disease who was not a candidate for heart or an LVAD, and he could not receive a human allotransplant. So with informed consent, they did a orthotopic heart transplant from a donor pig which had 10 gene modifications. Again, the results of the study are not published, but as far as we know from the news reports, the patient is still alive and has function. And this has been about 2 weeks now since the transplant. That brings us finally to the actual study that has been peer-reviewed and published about a clinical grade porcine kidney xenotransplant into a human. This was done in the University of Alabama in Birmingham, Alabama. The study was planned in such a way that the recipient was a patient who was a brain dead donor and was not a candidate for organ donation. After appropriate family authorization and consent, he underwent bilateral native nephrectomy to make him anephric, and then subsequently had bilateral porcine xenografts placed in normal position as you would do for a regular kidney transplant. They were both placed retroperitoneally. The right kidney was anastomosed to the ureter, and the left kidney was anastomosed as a percutaneous urostomy. The donor pig again was a 10 gene modified pig, which had the triple knockout as well as insertion of human genes. And then the patient was actually observed in the operating room for the course of the experiment and monitored for kidney function in terms of urine output, creatinine trend, as well as serial biopsies. They did use immunosuppression that is traditionally used in clinical model right now with use of thymocyte globulin, rituximab, and calcineurin inhibitor and steroid, as well as mycophenolate. The goals of the study was not to actually get complete success, but they had to address the first few initial hiccups that were supposedly, the roadblocks. The main thing was the hyperacute rejection because of the xenotransplant. The other things were complications that were unexpected, transmission of infection, and just to assess the viability of the kidney itself when anastomosed to a human physiological system. Like I said, the patient was in the operating room for the entire duration of the study, which lasted for 3 days. And he developed progressive brain death physiology and multi-organ failure, which was managed with supportive measures. And by day 3, he developed severe coagulopathy and hemorrhage, at which point they terminated the study and obtained all the results. Then this slide shows that the urine output and the serum creatinine trends from both kidneys. We can see that there was good urine output recorded. However, the serum creatinine was always in the upward trajectory. Again, the goal of the study was not to assess the full success in terms of lowering the creatinine. It was more to establish the idea and concept. One of the reasons they suggested the elevation of serum creatinine was that even native kidneys in the brain dead physiology state would not function and have worsening renal function. So this was not a true mimicking of the actual physiology of a transplant, but however, it did give proof of concept. And as we can see on the panel on the right side, all the kidneys remained well perfused and had, at the end of the day, on biopsies showed some evidence of microangiopathy, but otherwise were intact anatomy of the glomeruli and the tubules. When we talk about what immunosuppression to use in xenotransplant, the conventional regimen that's used for human allotransplant does not work. This has been established in many studies. The graph on the right actually shows the group A, which was given traditional immunosuppression, and group B, which was actually given a co-stimulation blockade based on CD40, CD154 pathway, and the co-stimulation blockade actually works much better than traditional calcineurin inhibitor-based therapy. With all this in product, there is definitely federal regulations, and the FDA actually has had definitions for xenotransplantation, as well as governing bodies which make sure that there is quality control as well as adherence to ethics. The main risks that are considered with xenotransplant is the risk of transmission of infections, but ideally transgenic pigs are bred in a very sterile environment and are free of exogenous organisms. There is concern for porcine endogenous retrovirus, which is a retrovirus that is present in pigs, and we also have a human equivalent that is present in humans, and both of these are non-pathologic. And we also now have genetic manipulations which can actually knock down these viral expressions and can give you non-virus based pigs. And finally, we come to the ethical issues. When we are talking about xenotransplantation, the benefit is, of course, it addresses organ shortage, it ameliorates the effects of brain death and DCD physiology, it addresses human organ allocation and sharing to reduce disparity, it can be a bridge to allotransplantation, and there is definitely no risk to the donor as seen in human living donor surgeries. But there is question of incomplete understanding of all these gene modifications, and there is still a question about the longevity of the grafts, as well as potential issues with the recipient when they have a animal organ in them, with questions of self-identification, as well as considering this as unnatural. And lastly, this may turn altruistic donors away because there is another alternative available. So in conclusion, xenotransplantation is a possibility that may happen sooner than we thought, but there is definitely more studies needed to figure out all the details. Thank you for your time and allowing me to present.
Very nice and elegant presentation, Dr. Santos. Really, I myself benefited a lot, covered a lot of the aspects of xenotransplantation, whether it's the surgical aspect, the immunological aspect, also the ethical aspect. So very, very nicely done. And are there any questions, Dr. Gamal, on the floor?
Yes, please. Thank you very much for your very elegant presentation, Professor Santos. And let me ask you about the specificity of the CRISPR-Cas for selected sites for editing. Do we have more effects beyond the selected sites which might hamper the use of this technology?
The thing with gene editing, that is the thing. Like, gene editing came into being like probably 10 years ago, and now that CRISPR has come in, we have made all these transgenic pigs. But in the first place, we do not understand the role of genes. We don't know what exactly these genes do in humans, as well as what happens to humans if you knock them out. And without complete understanding, now we are making these changes and using them, so it can, work out in a negative way. So that is something to see.
The other question, how far did we proceed or progress in the process of blastocyst chimerism?
That is something that probably I'm not that aware of. Chimerism is, again, that's something that I'm not that aware of.
A short inquiry to you, Dr. Muhammad. Are the speakers staying with us until the end, or any of them will be leaving?
I think Dr. Kayuk has surgeries. I'm happy to answer any questions that are directed towards robotic kidney transplantation, but and I don't know if Dr. Santosh will be around as well, but I'm not sure he might not be here.
Okay, if he's not staying with us till the end, let me deliver to him the shield of appreciation of the African Society, and I might as well deliver the shield of appreciation to Professor Santosh as well.
Thank you. Thank you so much.
You're welcome. Proceed, Ya Muhammad, please.
Okay. So again, Dr. Santosh, thank you for your very, very inclusive and great presentation.
Thank you.
Right. So allow me just to join quickly there. I have a small problem here that I'll fix in a second. Hold on 1 second, please.
This meeting is being recorded.
Again, sorry about this. The presentation will be ready in about 1 minute. I just like to start and say that I think the first half of this session was more futuristic, was talking more about the future and of transplantation and the things that are still a little bit close, but not that close. In the second half of the session, I would like to present, I'm presenting first, and then followed by Dr. Wee, two more attainable, two more concepts of improving kidney transplantation that can be applied right now. It does not require a lot of
innovation, does not require a lot of advancements such as the use of robotics or genetic modification like the xenotransplantation. It's something that can be adopted now, especially in our countries. And what I'm going to be talking about first will be the use of small incisions in kidney transplantation. Following that, Dr. Alvin Wee will talk about the enhanced recovery protocol for kidney transplantation, which is really a game changer and really improves outcome, as he will speak in a second. Now allow me to share my screen. Okay, so I will start now, and what I'm going to be talking about, as I said, is the use of small incisions to improve outcomes in kidney transplantation. Can you hear me?
Yes, go ahead.
Okay, so just a quick introduction. The first kidney transplantation between monozygotic twins was done in 1954 by Dr. Joseph Murray, who went on to receive the Nobel Prize for his efforts in kidney transplantation. Over those years, the incisions that were used in kidney transplantation were either the midline incision, the paramedian incision, the hockey stick incision, and more commonly and more recently and more generally used is the Gibson incision, which has become the gold standard for kidney transplantation all over the world. Now, over those years, there have been major changes in the medical aspect of kidney transplantation. There's been a lot of improvement in the immunosuppression drugs, there's desensitization protocols, a lot of real changes that happen in the medical aspect of kidney transplantation. However, there has been really a minimal to no change in the surgical technique. I think what we are doing now in kidney transplantation is exactly what we have been doing for the past 30, 40, or even 50 years. And the Gibson incision, by definition, it's a muscle-cutting incision, and it really is, as I said, the gold standard for kidney transplantation, and that is because it provides great access to the vessels and to the bladder, and it's very reproducible, very easy to copy and do, and it's generally what is used all over the world. It has a relatively low complication rate. When we talk about wound infections and facial diseases, relatively low numbers in an already known sick population of patients who are the kidney transplant recipients. However, I don't believe that this is enough. I feel like if you are not progressing, you are regressing. We have to keep moving forward. We have to keep pushing the envelope and try and improve on what we do and deliver better service to the patients. So the question is, could we do better? Could we do better than the Gibson incision, which stood the test of time? And the first question would be, can we make those incisions smaller? And classically, in my mind, kidney transplant incision really depends on two things: the patient's body habitus and also the kidney size. So generally speaking, you would require a larger a larger transplant incision for a patient who's bigger. Also, if the kidney is bigger, you usually would require a bigger incision. And this is basically to allow you to visualize the kidney and comfortably do a vascular anastomosis and the bladder anastomosis during the surgery. Now, the other questions would be, can we avoid the muscle cutting? As I said, the Gibson is by definition a muscle cutting approach. Can we avoid that aspect? And paramedian incisions, which is a non-muscle cutting incision, has been used and is still being used by a good number of people now for kidney transplantation. However, there is this question of having a slightly higher hernia rate when compared to the Gibson incision. But it's still, as I said, used, and some surgeons do prefer to use that technique. So in order to develop this new incision that I'm going to talk about and show a video of, we had to do a little bit of out-of-the-box thinking. We have to improvise a little bit. And the first question that we tackled is, do we really need to see the kidney during vascular anastomosis? Do you really have to be seeing the kidney during that part of the surgery? And the answer is no, you do not. We can do a kidney transplantation only by doing the vascular part and then deliver the kidney, as I will explain in a second. So the way we achieve that is by developing a pocket inside the patient's abdomen, extraperitoneal pocket, where you put the kidney in, do your vascular anastomosis, And then afterwards, you can deliver the kidney and take a look at it and then put it back in the pocket. In order to be able to do that, we have to modify a lot of what we do. We had to order special retractors that are thinner. We had to order some retractors that are specific to hold the kidney in the pocket. And also we had to modify the way we clamp the vessels for vascular anastomosis. And then the other question is, can we avoid the muscle cutting approach? And what I'm showing here is a picture of the abdominal wall anatomy. A typical paramedian incision goes in the junction between the rectus sheath and the abdominal muscles here. And what we thought about is, what if we move this incision a little bit more medially and we do it right on the anterior rectus sheath? And then once we go inside, we push the rectus belly medially and then access the extraperitoneal space from here. And that way we would be avoiding the muscle cutting part of the incision, which definitely is responsible for a lot of pain that patients can have after kidney transplantation. This technique was originally invented by Dr. Joseph Africa. He is one of our partners who works in West Virginia with Dr. Santosh, and he published those couple of papers on his technique in 2017. So just as a brief summary of what I'm going to show in the video so that we can follow up. This is what happens is we make an incision here, which is anywhere from 6 to 9, so really a small incision that goes about a couple of inches above the inguinal ligament. And then after we make the skin incision here, we open the rectus sheath, as I'm seeing in this dotted line here, as I'm showing in the dotted line. And then the rectus belly is pushed to the side. A kidney pocket is developed upward. The kidney is put inside. The vascular anastomosis is done. The kidney is then delivered to check for hemostasis and then placed back, and the ureter is finally done. This is the video I'm going to show. And just for the sake of orientation, the patient's head is supposed to be on the right side. The patient's leg is on the left side. And then this is the belly button of the patient, and this is the right lower quadrant. So again, this was a very small incision of stone. It's about 7 centimeter incision. And right when you go through the skin and the subcutaneous tissue, you can see we directly go to the anterior rectus sheath rather than going lateral. And the muscle that we see underneath us is the rectus belly. And then after this, we use some Alice clamps to just hold the sheath up. And then slowly, you can see my fingers pushing the rectus muscle towards me. And then slowly follow the rectus muscle laterally till we reach this extraperitoneal space. And by doing that, as you can see, we really avoid any muscle cutting. It's only the rectus sheath that we've opened so far. These are the inferior epigastric vessels that we've seen in the picture or in the video. And in this patient, they were in the middle of the incision, so we had to tie them up, but we don't necessarily have to do that in every patient. After tying those off, we open the fascia transversalis here, and then afterwards, we develop the extraperitoneal space. Here, this is the lower part for the vessel's exposure, and then I go up here and develop the extraperitoneal space above the psoas muscle, and also develop the pocket for the kidney, as I will show in a second. Now, this is placing the Buchholter retractors. These are, again, very small, thinner retractors than the typical retractors of the Buchholter. As you can see, all we need is just 3 retractors to have this access. Now, this incision gives us access only to the external iliac vessels. You can see here, this is the section of the external iliac artery. We don't really see the common, which is up here. A typical Gibson will show you all the vessels all the way up to the common. But this is definitely a smaller incision. So it's mainly used for patients you are planning on using the external iliac artery for anastomosis. If you're planning on using a common iliac artery, then it probably would not be a great option. Now, after the arterial dissection, we go on to do the venous dissection, as you see here. And again, what this incision also forced us to do is minimal dissection. We only dissect a part of the artery and part of the vein that is enough to do the anastomosis. Now, here's the important part. Here is putting the kidney in. This is the kidney. And as you can see, the kidney is being pushed up in the pocket. And then after it's being placed up in the pocket, we put what we call the finger retractor, or a very small retractor just to hold the kidney in place, as you can see. And as you see now, we do not see the kidney. The kidney is really hidden up inside this pocket, and we can still carry on to do our vascular anastomosis. We start here by the venous anastomosis. And again, I'm just showing you this case, the steps of the anastomosis, just to showcase that it's not really a problem doing anastomosis due to, from such a small incision. Now, just a surgical tip here, of course. In order to do this incision, you have to be okay doing your anastomosis all from one side, meaning not flipping the kidney right and left. I know some surgeons prefer to do this, but this is the technique we use anyways, even in our Gibson incisions, which is suturing the kidney or suturing the vessels all from one side. And we do this first by suturing the inside wall as shown, and now we're suturing the outside wall. Now the venous anastomosis is done, a bulldog is placed, and the clamp that was clamping the external iliac vein is removed, and we're moving on to the arterial anastomosis now. And again, a little bit of changes here from what we do in the Gibson. If you have seen this clamp being placed, all the clamps are coming from the feet side, and this just has to do with how the incision is. And then again, showing just again how the arterial anastomosis is done, and the ease of doing it even through such a small incision. There's definitely a learning curve for this incision. It's not just easy to go from a Gibson to a small incision, but I would say after 20, 30, 40 cases of those, you're pretty comfortable doing it, and it's easy and reproducible. Once we are done with the arterial anastomosis, as I'm going to show in a second, and check for the hemostasis and that the vessel anastomosis looks good, we then go on to deliver the kidney out of the pocket, as I will show. Right now, we're just doing the anterior wall of the artery. And again, the clamps are removed to check for hemostasis, which looks good in this case. And then the clamps, the bulldogs, are taken off the artery and vein, and the kidney is perfused. Now, and this is just to show the venous and arterial anastomosis. And then once this is done, as I just said, the kidney is delivered out of the pocket, outside of the incision, where we check for hemostasis. Everything that needs to be cauterized is dealt with, and once we can flip the kidney on both sides to check for the anastomosis as well. And then once everything is reasonably dry, the kidney is being placed back inside the pocket. And again, the finger retractor is placed to keep the kidney in position. And after that, the bladder is done in a very normal fashion as what you would do in a Gibson. I'm just going to skip now, but show you a few seconds from the bladder anastomosis, just to show again that it's easy to do through the small incision. This is the spatulation of the ureter, and then after this, we open the bladder and do the anastomosis. As I said, I'm going to skip a little bit here. Now we're placing the stent. And now doing the other side of the ureter. Sorry for the glitch. We'll open one more time. And what I really want to show here, the last part of the video, is the closure of the incision, which is, I think, is one of the most fascinating part of the incision, which is the fact that you only close one layer, as you can see here, only the anterior rectus sheath. It's much faster, it's easy, and there's less risk or harm for the peritoneal cavity. And then once this rectus sheath is closed, we close the skin in whatever way you like. This patient, we did a subcuticular closure, but of course, any skin closure can be done. And that's the final product. It's about 8 centimeter incision at the end with the stretching. And now moving forward, so after we did about 50 of those cases or so, and we got really comfortable doing it, we thought about doing a study just to really test whether this incision would carry benefit for the patient. So this is the study I'm going to be presenting now. It's a randomized prospective double-blinded study. And if you ask how it was double-blinded, so the patients were not told which incision they got. They were all having the same bandage after surgery. Of course, the surgeons were not blinded because they were the ones who did the surgery, but all the post-operative management was done by the nephrologists who were blinded for which incision the patients got. This is a study that included 150 patients, 75 were Gibson and 75 were this anterior rectus sheath approach, or the mini incision as we call it. We included all patients who are having a kidney transplantation, whether it's living or deceased. We only excluded patients who either have severe calcifications in the external iliac. As I said, this incision is not suitable or not optimum if you are targeting to do a common iliac artery anastomosis. We also excluded those who got simultaneous organs, such as a liver, kidney, pancreas, and patients who needed a nephrectomy on the same side, and also patients who had a previous surgery on the same side. And our hypothesis going into the study was doing the small incision will show lower rate of wound complications just because of the lower, smaller area of the section, and may translate also into less pain and lower narcotic requirements by the patients. This is just a flow chart of how we achieved the study design and how the workflow, but I'm not going to go through this for the sake of time. This is a very busy slide just showing the summary of the outcomes that we had. I'm just going to highlight the 2 or 3 points. The first thing is obviously the incision length in the ARS was shorter as what to be expected compared to the Gibson. Also, interestingly, the mean inpatient oral morphine requirements were nearly halved. And again, those are patients who do not know which incision they got, but you can see here marked improvement in the morphine requirements. And the way we did this is that all patients received the PCA, or the patient-controlled analgesia buttons, and our pharmacists were able to calculate the morphine requirement by each and every patient included in the study. There was no real difference in the wound complication rate, and this is probably just because we did not have a lot of complications to start with in both arms. Interestingly, also, the operative time, there was a tendency towards shorter operative time in the small incision. However, this did not reach statistical significance, but it might be something that can be demonstrated on larger studies and bigger number of patients. And I think this has to do with faster opening, faster closure, and smaller area of dissection for sure. Now, I know that the question that comes to mind is like, how will this fare in the patients with higher BMI, the larger patient population? And I'm going to show a few pictures here of patients who are on the obese side, and also demonstrate success in performing the same technique even in those patients. So this is an immediate post-operative picture for one of the patients who had a BMI above 40. Believe it or not, this patient had a kidney transplantation, but in order to see it, you really have to pull up his belly to see the incision, which is definitely quite small. And this is another picture, same thing, patients with a BMI that's above 40. And again, small incision was very successful in doing the kidney transplantation. And I have to be honest that I even think sometimes that the small incision is even easier to do in those bigger patients. The reason is the external iliac artery towards the distal part, when it's coming outside the pelvis into the leg to be the femoral artery, is actually even more superficial than inside the pelvis. And also, this is a thinner area of the belly. If you were to do a Gibson incision here, you would actually have to cut through even more fat before reaching the vessels. While if you go that distal here, it's actually a thinner area of the body and also a more superficial part of the external iliac artery. Again, obese patients are a surgical challenge, whether you go with a Gibson or mini incision. But again, just showing that we did not exclude those patients from our study and we were able to successfully use the same technique. Now, these are pictures 6 months and 1 year after the small incision study. And this is the scar from one patient. Again, I don't know if you can see, but this is another scar for a patient who had a kidney transplantation. Again, more pictures from our study. The scar is here, and believe it or not, this patient has a scar somewhere, but again, it's very cosmetically appealing. Unfortunately, our study was not powered, or we did not design it to study the cosmetic benefit of the small incision. So we cannot make any comments or conclusions on that. But obviously, the cosmetic benefit is also very remarkable when compared to a traditional Gibson incision. So the take-home messages here for me is that our study has shown that the mini incision or the anterior rectus sheath approach has been associated with a similar rate of wound complications. However, there was definitely a lower narcotic utilization by the patients, and there's a potential for shorter operative time. Again, this was not readily demonstrated by our study, but I think on a bigger number of patients or in subsequent studies, we might be able to show that as well. Now, in my mind, this is a minimally invasive transplant as well. This is a minimally invasive transplant with the existing technology that we have. It doesn't require any robotic approaches or the availability of fancy equipment that might not be available in our countries. This is a readily reproducible technique. It has a learning curve, as I mentioned before, but definitely once you get used to it, you're able to do it successfully. I can say now that 90% of my transplants, I typically do them through the small incision. I still, of course, use the Gibson for complicated cases when I need access to the common iliac artery or when I have 3 arterial anastomosis. But 90% of cases now I can use effectively the small incisions for. Now, what's next? Is this the end? No, we are actually now having a new study where we are combining the small incision with a tap block, anesthesia block that we do intraoperatively and see how patients do afterwards. And the results so far have been remarkable. We've had patients who got transplanted and required nothing but Tylenol after the transplant. So really, this will be the next step forward to even further make this transplant procedure less invasive. I feel that this is the way to go. We have to keep pushing the boundaries. We have to be innovative. We have to try and advance the field of medicine as much as we can. And by that, I conclude my presentation. Thank you for the opportunity, and I would be more than happy to take any questions.
A very highly talented achievement, Dr. Tamami. Congratulations for your efforts. Does it consume more time or less time?
So actually, the operative time is less. Once we got used to it, as I've shown in the results, our operative time with using the small incision is less. The anastomosis part, I would say, is similar. It's about the same time, but the operative time is less.
And the post-operative intra-hospital stay is shorter. How long?
No, there was no. So we are, and this actually is maybe a good bridge for Dr. Ruiz's presentation. We are very aggressive as far as sending patients home. We send patients home on day 2, and there was no change in this. So whether they had the Gibson incision or the small incision, they were still home by day 2. So there was no difference there.
Regardless of how much urine output they have or parenteral immunosuppression or whatever?
Yes, and that's again, I'm going to save this answer for Dr. Ruiz because he's going to talk about how we are able to achieve that. But yes, we target always day 2 to send patients home regardless of the kidney function or the requirement for dialysis, even, as he will talk.
Great, ya Muhammad, and please accept our shield of recognition for your contribution. شايفنا يا محمد؟
No, I actually can't. No.
الكاميرا هنا. الكاميرا بتاعتنا فين؟ لا بتاعتنا احنا. انت قفلت علينا الكاميرا؟ Here it is, ya Muhammad. Thank you very much. Hello.
Thank you. Yes. Thank you so much.
Yeah, please proceed.
Thank you so much, Dr. Gamal. Okay, so again, Dr. Gamal actually asked a couple of interesting questions about how sending patients on day 2 and what about the different, not all transplant patients are obviously the same. Some require more care, some require less care. So how are we able to achieve this? And again, this is a great bridge and gateway to introduce Dr. Alvin Wee. And Dr. Alvin Wee, who will be the presenter for the final presentation of this interesting session. He is the current program director of kidney transplantation at the Cleveland Clinic main campus. I would like to say that under his leadership, our transplant numbers have literally doubled. So in the past 3 years now, we've been showing an increase in the number of transplant that we doubled compared to 3-4 years ago. Not only have the numbers increased, but also our outcomes have improved dramatically, as he will show us. And this was a big part of this was due to his dedication, tireless effort, and bold ideas and changes. He's also my partner and friend. Dr. Wee, please go ahead and start the presentation.
No, thank you, Mohammed. Thank you again. In behalf of Cleveland Clinic, I would like to thank the society for inviting us to give us this opportunity to share our experience. So let me start with the side. This will be a good bridge, and I know that you guys, let me share your experience. Let me just put this here, how to share it. Share screen. This one, share. Can you see it, guys?
Yes.
Okay. So I'll be talking about just a package of everything. It's about early recovery after surgery. Okay. Of course, this ERAS is a common word that is applied to almost all kinds of specialty, but we wanted to show your experience how we applied here in our transplantation here at the Cleveland Clinic. Again, my name is Dr. Wee. I'm the program director, of course. And thank you from Dr. Altemami, all his kind words, but all these achievements can be done because I have a great team. So, of course, as we know, transplant what makes us unique, what makes us special, right? What makes us special, or at least different from other specialty, okay? Definitely, we have multidisciplinary approach in which all team members, as I can say, all different specialties like pharmacy, financial worker, ethics, psychiatry, all this plays a big role in order for a transplant to make it happen, right? And the beauty of it is because there's different paces, right? In which we have from all paces from before and during the transplant and after the transplant. And no other specialty is more important that we can see than in our specialty, that the partnership between the patient and the support system and the transplant team is very crucial for the success of the operation, right? Because we do not measure our success just that the kidney is making urine and then they go home and that's it. That's not how we measure our success. We want to make sure the graft lives long, and all these things. Unlike in other specialty, once they remove something, it's done, right? They can do some chemo, but it's done. They don't need to see those people. Of course, in all different countries, we have all different unique system, but there's a common things that we have. Of course, these are the common things. And of course, I can say that not all of this can be applied to all system because, again, the payment system, the mix of payment systems are all different. But hopefully with all this small experience that we want to share with you, you guys will be able to get some points and share and apply it to you guys, to your system. And we'll be more than happy to learn from you guys too. So I'm sure you guys are familiar. We have 3 phases, of course, the pre-transplant phase, the transplant episode, and the post-transplant. In order for us, the ERAS, to be successful, we cannot apply, what we notice, you cannot just apply on a certain face. You can just say, okay, I'll just do it on 3. That's it. No. It has to be on the spectrum of all these phases to make this happen. As Dr. Altemami has mentioned, yes, we sent our people home on second day, and it took a little time to convince it, because before I took over the program, we were sending people home on day 5, day 6, which is really the norm, right? That's a national average, even here in the United States. But yes, we have to keep on pushing. We have to keep on pushing ourselves to make it better. So that's how we came up, and how should we do it. And again, this all needs a team effort to make these things successful. So let's first go with the pre-transplant team. The pre-transplant phase, sorry. As we know, the pre-transplant phase is first where we meet the patient, and to us, I don't know if some other, education is where it plays a key role here. But what are the problems that we face? As you can see here, patients, I'm sure you know that, will only hear what they want to hear, right? So when an education takes about an hour, all they want to hear is when I'm going to get the kidney. That's all they want to hear, right? They're not going to hear anything. If you ask them anything about it, they won't remember. But this is a requirement in the United States, that we have to do education to them, and all of this is part of the requirement. So and we know that most people attention span is about 5 minutes. So it's really hard to let them remember everything. And therefore, what we've learned, the key in this education technically is to manage expectation. What do you mean by that? So there are key words that we mention to emphasize to people about what you expect, what you should expect. Of course, that thing that you focus on will definitely be less than 5 minutes. Of course, it's an hour education, but you're going to focus 5 minutes on which you put the expectation. So during this education, what are the things that we make sure that we emphasize and to tell them about the expectation? So main and foremost is you expect to them the length of stay. I'm sure just like in everybody's, most patients, they always think that hospital, the longer they are in the hospital, the better. So that thing, we have to change that paradigm thinking of the patient, saying that that's not true, right? So we mentioned to them that we expect them a length of stay of these days, 2 to 3 days, okay? And we emphasize it, like really stress it out, like kind of talk it about louder. So those are the things that really sticks to their ears. And then we stress to them, the following are no longer reasons to stay, right? Oh, we have a Foley and a drain. No, I don't want to go home with a Foley catheter. So you have to mention that way before that, okay? Pain is no longer, even kidney does not work right away, because now with our new allocation system, most of our cold ischemia time is 24 to 30 hours. Dr. Altemami is about to do a kidney with about 32 hours of ischemia time coming all the way from Texas. So these are the things. So we mentioned to them, yes, we're going to expect that some kidneys will not work right away. And some people who are diabetic, in which this is the most common cause of our kidney failure here, constipation is a big problem. So they'll say, well, I don't want to go home yet until I move my bowel, right? So these are the things that we stress as the symptoms. And these things that you have to make sure you really emphasize it. And of course, also emphasize the importance of early discharge, right? Mobility, you have privacy. Of course, our rooms here are not private. So that's maybe different. Maybe some of your what do you call this, hospital has like a hotel room, like, so that's a different, right? But I still tell them, like, you don't want to be walking on the hallway, exposing your rear behind or all this. It's very hard, right? Freedom, of course, they may say food is better at home. Of course, infection risk, especially now in this era of COVID, right? But this is where we really focus on the length of stay. And then, of course, I will emphasize to you guys again, when you send them home after doing this education, maybe 1 or 2 of these lines here will stick to their mind, but not all of them. So the next thing is when they get admitted before surgery, you once again remind them about the length of stay to the patient and to the family member. So we meet the patient, hey, Mr. So-and-so, congratulations, you're going to get a kidney. Oh, today is Monday. We expect this kidney to work. We expect it to send you home on Wednesday. And I will tell you, every time you tell them that, they won't hear it. So you have to emphasize this. Hey guys, Mr. So-and-so, I'm telling you, today is Monday. I'm sending you home on Wednesday. It's the same thing that we tell the family members, right? Because after you do the operation, you call the family member and say, hey, you know, the kidney looks beautiful, Mr. Miss So-and-so, blah, blah, so blah, blah. We expect to send him home on Wednesday. And most of the time they'll say, yeah. But this is where you have to stress them again. Again, ma'am, I'm just asking you to remember today is Monday. On Wednesday, 2 days from now, we will be sending your husband home. So please prepare whatever you need to prepare at home, whatever, all these things, whoever is going to drive him and all these things. So those are key. And of course, you emphasize to them about those Foley catheter and all those things. It's not a reason to keep them in the hospital, especially pain. Because they'll say, the pain and all these things. But emphasizing to them that there's no better place to recover than home. This to us is the first step to show them, once again, you kind of change the paradigm shift in their mind about sending them home early. Then we go to the transplant episode, in which Dr. Abdelmami has mentioned, Dr. Kayuk has mentioned about what are we doing. So I think this is where people ask me a lot of questions, okay? In terms of the anesthesia part, how about use of lines? So in the past, every one of our transplant patients gets central line. Everyone, okay? But now I will tell you only 5% or even less than 5% of our patients need a central line. All we need is a 2 big peripheral line. That's all we need. So the only reason now that we use central line is because they can't find a peripheral line. That's it. Okay, so they put a gauge 24 just to put them to sleep, then we put a central line. In fact, they try to put an EJ if they can, so they don't need to worry about it. Okay. Now, then the question always comes, Dr. E, we're giving thymoglobulin, you know, those have to be given sent by a central line. Yeah, before, but not now anymore. So we have our pharmacist is very good, as I said. We able to formulate that thymoglobulin. We add some heparin in it, and we're more than happy to share with you guys. Dr. Abdelmami can share with you guys what we mix on the thymoglobulin so that we will be able to give the thymoglobulin peripherally. So we don't need central line for that, okay? A-line, we let the anesthesia decide, but we can start even before they do the A-line anyway, where the arms are all apart, so we can proceed even without putting the A-line. And I think this is key, where the surgeons play a big role. The smaller incision, better Gibson, and versus the ARS approach. In fact, even our Gibson has really modified a lot now. We used to do our Gibson is about 15. The usual Gibson is about 15, 16 cm. But now our Gibson, if we need to, because of this approach that we have learned from the ARS approach, we're able to dunk the kidney in. We don't really need to do a big Gibson anymore. So even our Gibson is about 11, 12 centimeter, not as bad anymore. And as Dr. Abdelmami has mentioned, 90% of his cases are ARS. I can say in all our cases, I can say about 60% of our cases now are all ARS, because we just see the beauty of it, right? Less operative time, because one of the audience was asking, is because, of course, as you do more, it becomes easier, right? You become so familiar with it. So during that video, when it was approached, it was a time where it were about 6-8 months when we were doing it. But if you ask us our operative time, what we are doing now with ARS from what we were doing about a year ago, definitely there's a big difference. Of course, use of blocks, as Dr. Abdelmami is mentioning, this has really helped. And then after that, then this will answer some of the question in terms of about the fluid shift, right? So first, let's talk about diet. We don't put the patient on NPU, we proceed to regular diet. We know that most of our operations are extraperitoneal, right? So we don't wait for this, we start on regular diet, okay? Key here is analgesia, and that's the key. That's why we've been trying to push ourselves in trying to not to use narcotics, as some of our promising results from the ARS with blocks. Almost, of course, it's not yet final because we need about 200 patients. We're about 40 patients now, and we just started about a month ago. So just to it's a big difference. You can see people taking Tylenol now without any even oxycodone, right? But during this era when we were doing it, we were using PCA. But on post of day 1, we wean him out, and then I start to use oral narcotics, and then as much as possible, like really not to use narcotics because it makes you nauseous and all these things, and it contradicts and make it things more difficult. Of course, early ambulation is very important because that's why reason why if you can make your surgery less painful, it will be much better. Now, key here, of course, every system is different, but for us, that whole team rounds, the surgeon may not be there most of the time because we're doing another surgery. But in these rounds, during these rounds, we emphasize again to the patient that he better start moving, he better do that because the goal is to discharge him tomorrow. And I will tell you, they will start moving. Okay. So you have to create, you have to set the standard, you have to set the pace, because if it's going to be passive, that you're going to let the patient dictate it, then it's going to be hard. Again, every system are different, right? Because for us, the payment system is different. Some people want to stay longer because it's like fee for service and different. So everything is different. But of course, discharging people early is always good, regardless whatever the system status is, because there's no better place to work, than home, right? So in terms of fluid, yes, you are right. In the first, even on the post of day 0, there's a lot of fluid shift, right? There's a lot of fluid shift. And that's where it is. But on post of day 1, that's where we stop the replacement and we start to straight rate patients, okay? And it's very, very important that we emphasize that they have to weigh them daily. And the truth is, most of the patient that we send them home, they're always on a positive balance because we give them more fluid than what is really necessary. I mean, more than that, because that's what the kidney wants, right? So we're always positive. So this limiting fluid, not really, I don't know if that's the right word, limiting. I kind of maybe the better word is saying kind of balancing the fluid is very important. In addition to that, we also, I will talk to you about our post-op visit, which is key role to prevent dehydration and all of this, right? So, and then especially in living donors, watch the diuretics, because sometimes when we put order, it becomes an automatic order and we don't watch it. So we don't put like a standing order. I mean, our diuretic is more like a PRN. So it's not like you have to order it, because sometimes we order, we forget about it, right? And I think I get a lot of question about this is, can you give the induction agent outpatient? Absolutely, absolutely. Because, for example, the common dose for thymoglobulin is 4.5 to 6 mg, which you will not be well, you can give big dose if the patient is smaller, right? But with our bigger patient, you won't be able to give the maximum dose within those 2 hospital stay. So therefore, we give the thymoglobulin as an outpatient basis. Now, I know some people say, well, it's 0124 or 013. We're very flexible to it. We can give 0135, 0137. It just depends. But the key here is, for example, basiliximab is 0 and 4, right? So we give 0 to 5 or 0 and 5, 0 or 6, right? So that's the key. So we were not really stuck to that 0 to 4. And believe it or not, I mean, we have data to prove it, but we have no increase in rejection by doing that. In terms of post-transplant education, of course, we do that on post-op day 1. As you can see, post-op day 1 is a lot of things for the patient to do. It's a lot. And that's the reason why I'll tell you the next slide, what is very important to kind of reassure the patients and their family, is that you have to emphasize to them that this is a process, okay? You have to emphasize to them that even if they stay for 7 days, they will not learn all of it. They will not learn all of it. And that's the reason why in this next slide, as you can see, when they come out for the when they come home and start for their outpatient visit, this is where we emphasize to them. That is the reason why we see you 2 times a week, because that's where we do the fine tuning, and you can make mistakes. We have people who takes, instead of 5 milligram Prograf twice a day, They take 5 of the 5 milligram program, which is 25 milligram, and we have that 2 or 3, and it happens. Believe me, it happens. And we're able to catch it because, again, we see them twice a week, right? So we do biweekly labs. Okay, clinic, we did them 2 times a week. And how about those kidneys that kind of like not working yet, you know? So we do what we know as a delayed graft function clinic. Instead of seeing them twice a week, we see them Monday, Wednesday, Friday for dialysis check. Now, we're very fortunate that our institution has our own, not own, I mean, we have a dialysis unit in another building. Actually, it's in our own building, but it's a different floor. We send those people that we need to dialyze there for the following reason. Because some people will say like, well, Dr. we don't have that. We have to send them back to their dialysis center. So in that case, you really have to communicate to them, because the key here is when they go to that dialysis unit, you know, what happened is when you send them, they're just going to pull the same routine as what they usually do with all these people, right? So for example, when we send these people to our unit, we say like, hey, just clean the solute, only pull this amount, pull this out. So very, very limited, because we don't want something the patient's going to be dry. So those are very key results, because even in our HD outpatient, most of them, I will tell you, about 80% of them will not need dialysis, because we see them for 1 week, even though the creatinine is going up, but you'll see the urine output is going up. So it doesn't become an automatic thing. We'll just dialyze you, okay? So that's very important. And of course, with diabetes, which is the most common cause of our kidney failure, we collaborate with them, in which they will see the patients with us on Monday. So it's a different encounters for them. So all these diabetic people, when we send them home on post-op day 2, they are on sliding scale. You know, it's not yet. So they already know what our steroid taper is. So they already give them the sliding scale. As you can see, the beauty of this is that whatever day you discharge the patient will never, the longest time that the patient will not be seen is 4 days, right? So if we discharge them on Thursday, we see them on Monday. If we discharge them on Wednesday, we'll see them on Friday. So you can see nobody is like, oh, I operated this patient, I'm just going to see this patient 1 week later. No, the maximum is going to be 4 days. That's the maximum days that before. It's important. That's where you see, as the question you said about the fluid shift. We thought about IV fluids, where we give people dehydration. We have a patient who has a gastric bypass, who every time we come here, he's like, this is Monday to Thursday clinic, is always like down weight. So we give him IV fluid. So you can see those prevents that readmission. And at the same time, it saves the system and protect us. And you don't want to admit the patient, especially now our beds are all with capacity when we can then. So I'm going to show you the result. Before I show you the result, I want to share you one experience with one of the patients. Of course, this a lot of them. So there was a patient, he also worked here at the Cleveland Clinic. He had a transplant around 1993. And then we did another transplant about 2 years ago. So when we were sending him home in 2 days, he was really reluctant, because during the first time when he had that done, he was kept for 7 days, right? And he said like, he makes he really feel uncomfortable going home on second day. And I said, no, you know, that's a reason why you do this. And we explained to them. And you know, when he came back on his follow-up, he said, Dr. E, that's the best thing that your team has ever made. This early discharge, just a big difference of just, you know, recovering at home. So with that, so let me show you our results. As you can see here, here on this one, so the conventional, this was before 2018. Just the patient characteristics, yeah, maybe there's a little more functional status, maybe because we already removed some of the people who are not, you know, not really good candidate. But just to show you, as you can see here, first is the operative time has really changed. Of course, 50% errors, as you can see here. In the ERAS period, you can see the time close to an hour, more than an hour, as you can see here, right? Blood loss, lead blood loss, and all this, you know, all this. But I really want to emphasize really on the operative time. And how about the survival outcome? Actually, what I want to focus, which is very important, is the readmission, as you can see here. because of the endocrine, because two most common that we identified for early readmission are dehydration and hyperglycemia. So by having those two clinics and then catch them early while they're having dehydration and having the sugar, the endocrine people take care of that and seeing them Monday and Thursday, I will tell you in the last 2 years, probably we only have 4 admissions from hyperglycemia, just because these are diabetic type 1 who thinks they can do what is right. These were the reason why they were admitted, because of hyperglycemia. They didn't want to follow the instruction. But most of the time, I will tell you, majority of the time, they don't get admitted for that. And look at the delayed graft function. You may say like, well, you know, you might have more selective kidneys. The truth is not. We've done more DCD kidneys. In fact, when I was doing this slide, I was reviewing. Before 2018, before we started doing these eras, we only import 10% of kidneys, import 10%, okay? And we were doing less DCD kidneys. But now our import is about 50%. So 50% of kidney, that's why we're able to double it to close to 300 transplant now. And with that, longer ischemia time and all of that, we're still able to decrease the delayed graft function. Why? This DGF clinic, seeing these patients very more particular, more closely, this prevents it because you don't automatically do dialysis, even though the creatinine may be high, as the potassium is fine and the volume status is okay. There's really no point to dialyze the patient. And then the length of stay, as you can see here.
1 more minute, Dr. Wee, please. We can have 1 more minute.
Okay, just to show you this one, 6 minutes, 6 days. This was the before and the hospital day, and the upper part is the delayed graft function, as you can see. So this is the report from our official result, SRTR. And you can see our living donors too was decreased from 5 days to 2 days. Just to show you once again, the 30-day admission, the ERAS has changed it, and also the hospital length of stay. So in summary, as you can see, this is a multiple prong approach that we do in all phases in order to do this thing happen. And it really needs, a team approach to make this possible. So I thank you again for giving me the opportunity. I'm hopefully in these few seconds, I'll be able to answer your question. Thank you very much.
Yeah, thank you, Dr. Wee, for this groundbreaking presentation and approach. And I know we're running short of time. Are there any questions from the floor?
A very short question. Is the CVP still holding for fluid replacement or not?
No, they're not. They're not. We don't look at CVP because most of these patients also have they have also like stenosis because they have on dialysis for quite some time. Those, even the central line that they put, the CBP is not accurate either. So we don't check CBP. We don't.
Thank you very much, Professor Wee, and please accept our shield of contribution.
No, thank you very much for inviting. I appreciate it.
Welcome. Thank you.
Thank you.
Thank you, Mohammed, for the excellent presentations, and everything really was so good. Thank you. Okay, let's move to the next talk. Professor Sir Magdi Yaoub, he's with us. Yes.
Yes, I am.
We are really privileged today to have Sir Magdi Yaoub with us in spite of his very tight schedule and very busy days. Of course, you know Professor Magdi Yaoub, but he just for the knowledge is Professor of Cardiothoracic Surgery at the National Heart and Lung Institute, Imperial College London, founder and director of research at the Magdi Yaoub Institute at Harefield Heart Science Center, founder and president of the Chain of Hope, and founder and director of the Magdi Yaoub Heart Foundation, which created the Aswan Heart Center. Of course, he's born in Egypt and graduated from Cairo University Medical School in 1957, and he trained in London. Yaoub established the largest heart and lung transplantation program in the world at Harefield Hospital, where more than 2,500 transplant operations have been performed. He had many awards, and among his honors, he was awarded a knighthood for his services to the medicine and surgery in 1992, and awarded the Order of Merit by Her Majesty Queen Elizabeth the second in 2014 New Year's honors list, and many others really. So Professor Magdi, please go ahead.
Thank you very much indeed. It is an honor and a privilege for me to be addressing this group, distinguished group, and I apologize for not being there myself, because that would have been ideal for me. My talk really this afternoon or evening is not on transplantation, because we do not have cardiac transplantation in this country. So I have a plea, a very strong plea on behalf of the cardiac patients, but also other patients, other organs who terminal failure, who require cadaver organs. We do not have that in this country, as you know, Madam Chairperson. And it is time that we try and change that for the benefit of our patients. I'm talking now mainly on behalf of the heart patient, because for a simple reason, cardiovascular mortality is the leading cause of death in the world, but it's also heart failure is a massive epidemic in the world, and it is increasing. And our country here, Egypt, is not spared. As a matter of fact, it could be more. Statistics show that heart failure epidemic goes on unabated. Now, the next point is that the state-of-the-art treatment of severe so-called terminal heart failure is cardiac transplantation. That has been shown time and time again. And it has not only been shown, but it's validated. I see now some of our patients, all right, it's not 80%, it's like 20%, who survive more than 20 years. As a matter of fact, some patients I remember coming in cardiogenic shock 36 years ago are now practicing, enjoying life, or practicing a very difficult profession, paying back to the country. So it is about time that we establish cardiac transplantation, but other organ transplantation in Egypt. How are we going to do that? Is the first point is to establish awareness. It is not the religion which is standing in the way. I know that for sure, because all religions are favoring saving lives, and it is really a culture, and we need to change that culture by increasing awareness for the huge number of patients who could benefit. I'm talking about heart failure now because that's what I see all the time, and it affects all ages. People are in their productive life, children in particular, a whole lot of them with either congenital heart disease, other types of diseases where we see following chemotherapy for cancer and so on, children, and genetic factors, all sorts of things. Now, what is my talk going to be? Because I'm not going to change culture immediately, but I'm just giving a plea. And what we have been doing here is working around the problem. In what way? Is that when we see so-called terminal heart failure patients, we try and use another strategy, in this case, left ventricular assist devices. But that in itself is not a long-term solution either, because it has its own problems. It is extremely expensive, and we cannot go on like that because each left ventricular assist device costs about $100,000. Our charity here pays for all that because we see the need for the country. But to try and alleviate the problem further, we adopt other strategies in basic science to try and make the heart recover using the left ventricular assist devices. And that will be, is my talk. How long I have? Do I have like half an hour?
Yes, please go ahead. It's our privilege.
Thank you, sir. May I have the first slide, please? Can somebody change the slides? Yeah. Mahmoud, can we do it from here, or it can be done from? Yeah, here you go. Thank you for that. And so my talk is entitled, and I will try to be as quick as I can, from left ventricular assist devices to regeneration. What do I mean by that? Next slide, please. As you can see, the use of LVADs, as we call them, has been increasing massively, and I will talk about that. But the most important thing about them is they keep the patient alive and give us a chance to try and get the heart to regenerate. And we know now from many basic science work that actually we can, through, at least in some patients, which can amount to 40% or less in some centers if you don't monitor it or use other things. And how can we increase the incidence of so-called regeneration or recovery? Next slide, please. So that's how my talk will be talked about. This is shows the massive increase in the use of left ventricular assist devices over the years. Next, please. That's what do we mean by regeneration of the heart? We have very strict criteria.
We lost your voice, Sir Yaqub, please.
In any parameter, structural or functional, at that time as regeneration. We think that this is not fair. We should actually expand the device, particularly in our environment. Next slide, please. But change them from here. No. Next slide, please. Yeah, this is showing how non-communicable diseases, particularly heart failure, is on the increase, much more than communicable diseases or any other cause of death or disability. Next, please. That's from the global burden of disease. We need to have, if we're talking about regeneration, we must look at it in an expansive way rather than a reductionist way. For a long time, at least in the previous centuries, there was one gene, one disease, and this is not the case anymore. All or most of the diseases, particularly in the cardiovascular system, are multifactorial. Next, so we have to have an expansive approach. Next, please. That is because we have to realize that we have to fight all the factors, not just one. And we should have the strategies and the tools to fight these things, rather than this young lad trying to fight a massive swarm of insects using a broom. He has no chance whatsoever. So we need to address the thing in a multifactorial fashion and have the proper tool, not just a broom. Next slide, please. And that with the use of left ventricular assist devices, we do have a chance of addressing many, if not all, of the factors. And therefore, bridge to recovery, as I was putting in this article, which was published in Circulation some time ago, we need to look at multifactorial things and at complex networks. Next, please. The important thing, next, please, with complex networks and artificial intelligence, we have to use a paradigm shift. What do I mean by that? In science, when you have model drift, when there is a crisis that all the strategies you're using are not working, then you have what Kuhn has called a model revolution or paradigm shift. Come back to normal science to work out new strategies to deal with a multifactorial complex disease. How do we do that? Next slide, please. Our group and others have been establishing models in the clinic, which looks at multifactorials with the central idea of recovery. And time will not allow me to go through these, but it is complex, but it's doable. Next, please. Next slide, please. And some of the novel pathways we have identified, we and others, I shouldn't talk about we, because we are only a group of scientists, doctors, trying to do one thing, but working with many, many other people. And I have just singling out here 4 novel pathways or paradigm shift, like what Kuhn has done. And time will not allow me to go through many others, but I'll go very quickly through these 4 novel pathways, because they are novel and they are promising. Next slide, please. The first is the unfolding, what is called proteotoxicity in causing cardiac dysfunction. This has been dubbed the Alzheimer's disease of the heart. What does that mean? It means that proteins tend to into shape. They have aggregates, and like just what happens in Alzheimer's disease of the brain, you get it in the heart. And there are ways and means for the body itself actually to correct this unfolding problem. That is very new and very promising, because you can look for the factors which correct the unfolding and actually make use of them. This article here talks about that, and our group are looking at that very seriously in patients with left ventricular assist devices. Next slide, please. The next thing is mitochondrial
We lost your voice, Sir Yaqub, please. We lost your voice. Are you muted or any connection problem? Do we have a problem from our side here? Sir Yaqub, please. Am I projected? Am I projected? Can he see me? Please proceed, Sir Yaqub, please. Sir Yaqub, can you hear me? Sir Yaqub, please, can you hear me?
Yes, I can indeed.
Yeah, please proceed. We had a problem with the connection.
Okay, so this slide shows some of the corrective molecules which body can correct the unfolding process. And we are trying to exploit this first by measuring them and then supplementing them. Next slide, please. And the second point is that mitochondria actually degenerate all the time. If they degenerate too fast, we can detect the molecules in the blood, and that can be corrected by other strategies. Next slide, please. And one very interesting findings, we almost stumbled on them by chance, is the fact that connexin 43, a molecule which is actually connecting the two myocardial cells together, actually is affected in heart failure in a big way, like we have seen that from specimens during transplantation or left ventricular assist devices. And this is extremely interesting because it gives us a handle on correcting heart failure again through addressing different subtypes of connexin 43 or other connexins, as a matter of fact. Next slide, please. And finally, we've been looking at biomarkers because biomarkers and measure show that the extracellular matrix around the heart muscle cells actually instruct the heart muscle, and therefore we can make use of that in reversing heart failure. And this here shows different biomarkers which have been looking at, and that holds a fantastic opportunity to reverse heart failure in the future. All of that is in the future, of course. Next slide, please. And that is, in my final slides, I'll show the strategies being used, because not all the changes which are being observed are actually cause and effect. There are some nodes in the complex network which we call collecting nodes, and some nodes are decision nodes. And through strategies of artificial intelligence or complex network biostatistics, you can determine which is a collecting node and which is a decision node, and that can be used for reversing heart failure. Next slide, please. And you can do that also by creating, not all types of heart failure are the same, because the strategy of one size fits all just does not work. And therefore, we have to look at each type of heart failure and define them through both many deep phenotyping by many omics, and then generate what we call phenoclusters. And then through these phenoclusters, we can use artificial intelligence to see how we can reverse heart failure. These are some slides generated from our center. There are many others in other centers. I'm not claiming that this is original. There are other people working on exactly similar strategies for reversing heart failure. Next slide, please. So in conclusion, bridge to recovery using left ventricular assist devices actually
We lost your voice again.
Sorry?
We lost your voice again. Okay.
Can you hear me now?
Yes, yes, proceed.
So it holds the promise to solve the riddle of cardiac regeneration. So we should be, with a lot of young people, pursue generation, but in the meantime, we have to establish cardiac transplantation in this country. Thank you very much. It's a privilege to talk to you, and sorry for the troubles we have had. Thank you.
My extreme appreciation, Sir Yaqub, for this a very elegant and very honorable presentation. And it's a great honor for the African Society of Organ Transplantation to have you among its first annual Congress. I was also privileged to be co-chairing this session with my dear colleague, Professor Maya Hasaballah. She is the president of the Egyptian Society of Nephrology and Transplantation. Also co-chairing with Professor Muhammad Hani Hafiz, the immediate past president of the Egyptian Society of Nephrology and Transplantation. I am Gamal Saadi, the professor of internal medicine and nephrology, Cairo University, and the president of the African Society of Organ Transplantation. Please, Sir Magdi, accept our award of appreciation for your very highly appreciated contribution.
Thank you very much indeed. I appreciate it, and I hope to be more useful in your society in the future. It is, as I said earlier, an honor and a privilege. Thank you.
Yeah, I hope we can get an appointment to deliver it to your office any moment you order. Thank you very much.
Thank you very much, sir.
By that, we conclude this session, and we will move to the last session of the Congress. And I would ask the chairpersons to come to the stage and lead the final session. Thank you very much.
Right.
We shall start this session by about immunosuppressive strategies. We shall start by the hepatology part of this session. So I will give the mic to my co-chair, Professor Dr. Muhammad Said.
Thank you, Dr. Montasser. I have the honor to co-share with you. I have the honor to introduce Dr. Fawzi Saliba. Is an associate professor in hepatology and gastroenterology at the University of Paris, Sicily, France, and is in charge of the intensive care and endoscopy unit at the Hepatobiliary Center and Liver Transplantation at Bull Prowse Hospital. Dr. Saliba has conducted, coordinated, and participated in several international and national clinical trials in the field of transplantation, hepatology, artificial and artificial liver support, and he will speak about tolerance of immunosuppressive drugs in special groups. He's online with us, and the lecture is recorded. دكتور فوزي حضرتك معانا؟
Yes, thank you for the nice introduction and
for the delay.
I will be ready for any questions
Okay.
after the presentation.
Okay, and online with us, Dr. Ashraf Omar, Professor of Endemic Medicine and Hepatogastroenterology, liver transplantation consultant, and the President of the Egyptian Society of Liver Cancer. Are you with us, Dr. Ashraf? Dr. Ashraf Omar? Okay, we'll start the lecture of Dr. Fawzi.
Dear colleague, dear chairman, I would like to thank first the organizers for this invitation to this great meeting. I would be talking on tailoring of immunosuppression in special groups in liver transplant recipients. These are my disclosures. Tailoring is essential. We think today not all patients might receive the same immunosuppressive regimen. We need to regulate this balance between over immunosuppression that could probably enhance patient and graft survival, but increased short and long-term complications. Quality of life is essential, and putting these patients on low suboptimal immunosuppression to avoid acute T cellular and chronic rejection. And maybe now we have more evidence about avoiding acute and chronic antibody-mediated rejection. And the long-term complication, which mostly are related to immunosuppressive regimen, first and probably apart is the disease recurrence, which remains today hepatocellular carcinoma. Disease recurrence, hepatocellular carcinoma could be enhanced by over-immunosuppression. HBV and HCV, which are now more controlled by antivirals. And autoimmune disease, alcoholism, and NASH still are major issues. In relation to the immunosuppressive regimen and over-immunosuppression, the increased risk of infectious complications, cardiovascular event, chronic kidney disease, which with its consequences as also cardiovascular event. De novo cancer is now a major issue. And since we are increasing liver transplantation for NASH and NAFL, this is becoming also an issue after transplantation. If you summarize here the data we have on what occurred after transplantation, metabolic syndrome is present in 50 to 60%, systemic hypertension, diabetes, obesity, dyslipidemia, and cigarette smoking. All this could enhance either cardiovascular events or de novo cancers. If we go to, the incidence of acute rejection have declined during the last years. We can see on this figure. For the many years, acute rejection did not influence survival, but now recent data showed from the UNOS registry also presented from nearly 30,000 patients between 2013 and 2018. And when they compared to a previous episode before 2012, you see the incidence of acute rejection reduced from 17% to 12.6%, which was we have currently now in Europe. The predictive factors of graft survival in the multivariate analysis are acute rejection was predictive, hepatitis C, and donor circulatory death. You can see the acute rejection, the hazard ratio adjusted per 1 year, just increased over the last 5 years. We have nearly 2.5 to 3 point increased risk of graft loss or death per year in relation to rejection. So we need to individualize who are patients at high risk of acute T-cellular or antibody-mediated rejection, younger age, adolescent patients, younger age between 20 and 40 years old, African American and African or Black recipients, liver etiology, autoimmune diseases like hepatitis, autoimmune hepatitis, primary biliary cholangitis, and primary sclerosing cholangitis are increased risk of rejection. And there are donor recipient immunological factors to have a T-cell positive cross-match at time of transplant, which occurs in around 10% of the transplant recipients in most series, either in our series. High MFI preformed donor-specific antibodies at time of transplant. Usually this is more frequently seen in those patients who have immune disease or hyperimmunized patients or young adolescent patients. And also, despite we do not take into account the HLA-DR mismatch, we have enough data in the past that showed that the number of HLA-DR mismatch, for example, 3 to 6 mismatch, are at increased risk of rejection compared to those who have 0 to 2 mismatch and retransplantation. So these categories of patients should remain at high immunosuppressive regimen. When we communicated and we organized, I participated and now reported the first immunosuppression conference on first international consensus on immunosuppression with the ILTS. And what we said concerning eligibility to minimization, patients may be considered for immunosuppression minimization protocols, except those with biopsy-proven steroid-resistant rejection, those who are transplanted for autoimmune disease, initial or retransplant, and those who have a definitive episode of antibody-mediated rejection, which occur rarely in less than 1% of the patient. So this is, we now know that we should not consider minimization in these patients. So the strategies for minimization that already took into account, now we all know that we stop steroids by 3 months or by 6 months should be tapered and stopped, except for those at higher immunological risk, what I defined first. These patients should remain on low-dose steroids or replacement with anti-proliferative agents. Usually, these patients keep on 5 milligram prednisone per day. CNI monotherapy could be considered only for patients who are eligible for immunization, and in general, beyond 3 months or 6 months. These are, you see, the quality of evidence are moderate, and the strength of the recommendation are conditional. So not very, very strong because we don't have very strong randomized studies on this. Dual to monotherapy, can we put on monotherapy patients who are intolerant of CNI monotherapy or at higher immunological risk should be considered to remain on dual therapy. That means CNI plus MMF or CNI plus mTOR inhibitors, everolimus. Generally, after 1 year, non-CNI monotherapy may be considered in patients at low immunological risk, as per say everolimus monotherapy or MMF monotherapy. What we do for patients with post-transplant metabolic syndrome, NASH, NAFLD, diabetes, we know that immunosuppression influences this. And in the international conference, we hypothesize that corticosteroids we know that carry significant risk of metabolic syndrome, and this should be minimized and withdrawn usually by 3 to 6 months. CNI inhibitor contribute to liver hypertension and dyslipidemia. Mycophenolate and antibody-mediated antibody-based therapies, like for induction, basiliximab and thymoglobulin, are neutral with regard to metabolic syndrome. The mTOR inhibitors has been shown to be associated with diminished weight gain, a lower frequency of major cardiovascular events, but also with dyslipidemia post-liver transplant. And we know they are neutral with regard to diabetes and hypertension. So another special groups is patients with renal function. What is the best regimen to optimize renal function and to avoid chronic kidney disease, which we know could occur in 40 to 50% of the liver transplant recipients at 1 year and at 5 years. The best regimen is to do an induction therapy with basiliximab combined with steroids, MMF, and reduced or delayed initiation of CNI. This has been shown to be associated with better renal function. mTOR should be avoided during the first months post-transplant. This was based, as you know, on the Elite Respect study, which is here what we know compared 3 groups. The groups, normal group, TAC beyond 10 nanogram per milliliter of trough level plus steroids. The group B that we mostly do now, TAC plus MMF plus steroids, but TAC below 8. And finally, the group C, which is induction with daclizumab here, but now it's not in the market anymore, is a delayed introduction of CNI. And you can see the best regimen is to do an induction therapy and delay the introduction of CNI, is associated with better renal function, less loss of renal function with similar rate of rejection. Another point is to optimize renal function is to start at 4 weeks, between 3 to 5 weeks, early institution at 1 month of everolimus in combination with low dose of TAC. This combination strategy result in significantly better renal function, and this has been recommended with high strong evidence and strong recommendation. This strategy is more beneficial for patients with chronic kidney disease, stage 3, that means eGFR below 60. And this is, as you know, was based on the randomized controlled study, pivotal study that has been published, and these are the data of 3 years that you can see that significant improvement in renal function when you combine TAC plus low dose everolimus combined to below down tacrolimus alone. And also, this has been mostly beneficial if you took those patients with chronic kidney disease stage 3 at 1 month. And you can see those who will improve their renal function above 60 milliliter per minute. That means real improvement. You can see you have 2/3 of the patient have a chance to improve their renal function in the everolimus plus reduced TAC compared to 23% in the TAC control arm. And it also has been recently published this last year now, when we combined the H2304 to the H2307, which was performed in living donor studies. And we have now nearly then 380 patients per group, combining living donor transplantation and cadaveric donor transplantation to see that this renal function at 2 months is better. Another data we have on the mTOR that we published also a year ago now from the real life in France, more than 1,000 patients with mean introduction of 3 years. You can see when we look at the introduction of everolimus in this huge series, 55% everolimus was introduced beyond 1 year, and nearly 45% during the first year, 20% during the first 3 months. And we can see that what we showed importantly here, that if you look at the data at 3 years and at 5 years, when you introduce early in violet here during the first 3 months everolimus, you have most likely the better risk, the better chance to improve significantly renal function and to gain on renal function on the long term and to protect, avoid kidney damage, dialysis, and kidney transplantation. So early introduction during the first 3 months of mTOR inhibitors was associated with the best improvement on the long term of renal function. Finally, on the hepatocellular carcinoma, we can consider here, we have at least 3 major studies that show that the cumulative incidence of tacrolimus or cyclosporine here were associated with increased HCC recurrence. According to you see high dose of cyclosporine here versus low dose of cyclosporine at 1 year, the incidence of HCC recurrence. We have now just also a recent paper at ASLD just communicated similar data with the tacrolimus. And we know that the mTOR inhibitors have a good strategy to introduce in these patients. These are the data from the SILVER trial with sirolimus here, and that we show that mostly beneficial is probably the low-risk group. That means HCC within Milan and cirrhosis. You can see here the recurrence-free survival and the overall survival. Despite at 5 years, the data were similar, but if you look at the low-risk group here, the first 2 lines, the data was better beneficial in terms of mTOR inhibitors. The data from everolimus in the pooled study also published recently did show that in the group of patients, these patients have similar data. We have 123 patients under everolimus with HCC, with 128 under TAC with HCC, with comparative patients characteristic for number of tumors, number of nodules, and alpha fetoprotein levels. And you can see that only we have 1 patient over 17 who made recurrence outside Milan criteria, and 6 out of 26 who developed recurrence in the tacrolimus arm. Probably who must benefit are those patients who have alpha fetoprotein higher, between 100 and 1,000. Here, this group were very, very small, as these patients are mainly not contraindicated to transplant. The HCC, the recommendation from the consensus, finally, they said, beyond the generally minimizing overall immunosuppression, the optimal immunosuppressant strategy for minimizing the frequency and severity of recurrence, including the use of mTOR inhibitors, has not been yet very well determined. We know that mTOR inhibitors could reduce the risk of non-melanoma skin cancer recurrence that has been showed in a huge registries of more than 30,000 patients in kidney transplant, and also in non-HCC and non-skin cancers. We know that mTORs could have a beneficial effect for neuroendocrine tumors or renal cell carcinoma. I would conclude or summarize to say that finally, we need to identify well the high-risk rejection group that we said at the beginning: younger patients, Black recipients, autoimmune disease, retransplantation, positive cross match or retransplantation, and de novo DSA. The second point, induction therapy is essential to improve, protect renal function, is essential for patients with a high risk of rejection. And finally, to protect the kidney on the long term, mTOR inhibitors are of real benefit. And for hepatocellular carcinoma and to reduce de novo cancer, also the place of mTOR inhibitors, despite that needs to be determined still yet, but we have now enough data that always we have less numerically recurrence under or de novo malignancies in these patients under mTOR inhibitors. Thank you very much.
Thank you very much, Dr. Fawzi, for this elegant presentation. I have one question about patient with high risk for metabolic derangement post liver transplantation. What's your policy in according to your experience in selections of proper immunosuppression?
Yeah, just these patients, sure, they are at high risk. Many of them are diabetics, obesity, and also at high risk of dyslipidemia and major cardiovascular events. We try to, sure, for steroids in these patients, we try to stop early by 3 months. There are some centers who would stop earlier even steroids, which is the main cornerstone that could enhance diabetes and make it difficult to control. Otherwise, the issue, we need to keep them on either on MMF and low dose TAC for the long term. We know that also these are at increased risk of de novo cancer, and also there are at increased risk of also developing de novo NAFLD. But in fact, NASH is extremely rare after liver transplantation. So we need to lower the immunosuppressive regimen because of this. If the patients we are away from the transplant and beyond 1 year, we can also consider low dose everolimus with low dose of TAC or everolimus monotherapy in such patient.
Is there any other questions from the floor? Yes.
You mentioned in the start of your talk that some of your patients will end by monotherapy everolimus, and the other part is monotherapy MMF. So the question is, what is the rationale of choosing which is which, especially that each one of them is completely different immunosuppressive group?
Yeah, in the past, we used before the maybe like 10 years ago now, some of the patients went to MMF monotherapy mainly because of severe chronic kidney disease. And we realized that despite the risk of rejection is higher under MMF monotherapy, this could range from 5, 10 to sometimes a little bit higher. There are few centers now who continue to put MMF monotherapy. But since we are more putting these patients on monotherapy with everolimus, in the paper we just published now a few months ago in the everolimus study with more than 1,000 patients, merely half of the patients beyond 1 year was only on MMF monotherapy, on everolimus monotherapy. So we know that beyond 1 year and in patients with low risk of rejection, the everolimus monotherapy is safe, and despite that few side effects that could affect some patients like aft and stomatitis, but this is in general occur early and could be under control.
Thank you, Professor, for your elegant presentation. I want to ask about the trough level of TAC and everolimus you want to keep your patients on.
What is for the everolimus, we try to be between 3 and 8 nanogram per milliliter. What is important to remain always above 3, which is the lower margin that has been shown in kidney, in liver, and in heart transplant. Below, you can expect you can increase your risk of rejection. For the tacrolimus, this is, I think, the main benefit. We can reduce very, very low. We are below 5, and in those, we merely sometimes between just 2 to 3 nanogram, really low dose. Now, just during the first 3 months post-transplant, we try to keep the tacrolimus level around 5, 4 to 6. But beyond 3 months to 6 months, you can reduce less. And we know now, even though that beyond 1 year, many of these patients could be left also when you have also other important complications, you can keep them mostly on everolimus monotherapy, which is not the major recommendation, sure, because the data of randomized study beyond 1 year are lacking.
Dr. Fawzi, do we have a biomarker close to the real life practice to do some immunological stratifications for our patients, or still we are beyond, far away from these biomarkers?
No, even I think there have been several biomarkers published in the literature, but never came to the real practice. Their sensitivity remain low, and especially in the liver, maybe in the kidney, they are more in advanced compared to us in the liver, because the liver, we have this better tolerance to low immunosuppression. And so we do not have really clearly biomarkers, even for new studies which are started on tolerance. We know that has been several genotypic or phenotypic biomarkers, some also DNA in some issues, but really all this still under research, never came now to the real practice, daily practice, and we are still far.
Thank you very much, Dr. Fawzi, for your participation, and we'll move now to the second speaker. I have an honor to represent.
I have a question to Dr. Saliba.
Okay, short question.
Yes, Dr. Saliba, good evening. I'm Imam Muntasir.
Yes, how are you? I cannot hear you.
Operational tolerance. Can you hear me?
Yes, now yes.
Some cases, whether clinical trials or just observation, to withdraw immunosuppression completely. I think in patients non-compliance, some patients can stop immunosuppression, but did you do it in clinical trial context?
No, the clinical trial, I'm on a board on a on ongoing clinical trial. There are ongoing clinical trial, but if you, in the clinical trial we have over 100 patients, you are able to do it for 5 patients. Finally, 5 to 6 patients can go to tolerance, but you are still a little bit gambling. This needs serial liver biopsies, serial monitoring of these patients, serial and close monitoring of these patients, because these kinds of rejection can occur even 6 months or even 1 year after complete withdrawal. So really, despite that this was a highly selected population, that means very far, 3 years, 5 years after transplant, and never did rejection, no autoimmune disease. Despite selecting patients, only very few can reach real tolerance. And you are not today enabled really to say these patients can go and stop. It's really, we still need other studies and other biomarkers like we mentioned earlier.
Okay, thank you very much, Dr. Fawzi. And we'll move to the second speaker in the liver board. I have the honor to introduce my dear colleague, Dr. Iman Fawzi Muntasir, Associate Professor of Endemic Medicine and Hepatology, Ain Shams University, consultant of liver transplantation, and Ain Shams Center for Organ Transplantation. She will speak about strategies for liver transplant tolerance. Is it a real or fake?
I know it's very tough and very difficult to talk about tolerance, but it's more easier than in kidney transplant. So we'll talk about strategies for liver transplant tolerance. Is it real or fake? First, introduction, then I'll go to the pros and cons for this rationale, the postulated mechanisms of tolerance, and finally 2 slides for the future goals and future prospect of xenotransplantation. So as we all know, the liver has the unique tolerogenic characteristics, and although the liver is more tolerogenic than the other organs, solid organs, lifelong immunosuppression has always been considered the key in managing liver graft protection from recipient rejection. However, it is associated, as Dr. Saliba mentioned, with several adverse events, increasing morbidity and mortality due to infectious complications, cardiovascular and metabolic disorders, renal disorders, and de novo malignancies. This is the timeline for introduction of the immunosuppression. As we all know, the first liver transplant was performed in 1963 by late Professor Starzl, and it was not successful due to poor immunosuppressant drugs. In the 1980s and the 1990s, after the introduction of the potent CNIs, the rejection rate dropped to less than 20%, up to till now, as Dr. Saeed mentioned, we need new immunosuppression agents. We need more powerful biomarkers to go to what we call the personalized immunosuppression and tolerance. So the goals of any immunosuppression is to prevent the allograft loss due to rejection, and at the same time maintaining adequate health-related quality of life and minimizing the risk of infection, but keeping in mind that acute rejection has impact on lifelong long-term survival, and that treatment of each rejection episode is expensive and associated with morbidity. So what's tolerance? Tolerance, self-tolerance is the ability of a healthy immune system to produce a protective immune response to pathogens and foreign antigens, and at the same time maintaining tolerance to its own tissues. The transplant tolerance refers to accepting organs without the need for long-term immunosuppression and maintaining protective immunity. Tolerance is usually classified as complete immune tolerance, the operational tolerance, and we will discuss later, and the prop tolerance is referred to a condition of low non-toxic dose of immunosuppression, and I think we all do this in our practice. So the rationale for immunosuppression withdrawal: the liver is an immunologically privileged organ, as I said, compared to other transplanted organs, and liver recipients generally maintain a low level of immunosuppression, and hepatic graft can provide immunologically protection when transplanted compared with other organs, in combination with other organs like liver, kidney, or liver intestine. The first evidence came from studies in animals in whom the new graft was spontaneously accepted without immunosuppression, and that spontaneous tolerance to liver was also observed in humans, who sometimes, some patients didn't develop rejection despite poor immunosuppression adherence, and this what we call the operational tolerance. The first studies, or the first report, came in 1993 from Pittsburgh, where they reported 8 liver transplant recipients with poor compliance stopped the immunosuppression from 6 months to 11 years after transplant, and unexpectedly they developed the operational tolerance. Among them, 7 recipients maintained good function up to 14 years, and the remaining recipient underwent liver retransplantation for another cause for viral hepatitis. Subsequently, many liver transplant centers have conducted trials of immunosuppression withdrawal in both adult and pediatric recipients, and it has been reported that normal liver functions was successfully maintained in adult and child liver recipients, with 20% of patients achieving a complete immunosuppressant withdrawal. This is some trials about the immunosuppression withdrawal, and we can see that the time from liver transplantation varies in these trials, but most of the trials more than 2 years after transplantation, and the rate of rejection also varies in these trials, ranging from 6% and up to 70% in another trial. Another trial also to assess if sirolimus, as we all know, it has immunomodulatory effect, could increase the tolerability of liver transplant recipients. This trial recruited 15 recipients with non-viral and non-immunological hepatitis more than 3 years after transplantation. Of these patients, 7 patients failed to develop the tolerance, about 50% of the patients. 3 failed immunosuppression withdrawal, 3 developed the moderate rejection on liver biopsies, and 1 was withdrawn because of liver mets. This one of the prospective multi-center clinical trial on immunosuppression withdrawal. Out of 500 patients screened, 98 liver transplant recipients were enrolled, and of these, 41 patients achieved the clinical tolerance, about 42%, and 58% developed mild rejection. This is the survival curve for the patients, and we can see that during the 3 years follow-up after immunosuppression withdrawal, no significant histological damage was found on liver biopsies for the tolerant recipients. And this is the probability curve, and we can see that the statistical analysis in this study showed that years post-transplant correlate positively with the tolerance induction and could be the strongest predictor. The years as it passes, the longer the duration, the better the outcome we can induce tolerance. So the postulated mechanism for this, the interaction between recipient immune system and the unique microenvironment of the donor liver, what we call the crosstalk theory, including passenger leukocytes, which ultimately result in defective activation and depletion of allograft T cells. And overall, this interaction between the cells promote the establishment of immune-tolerant microenvironment. As we all know, the liver has its unique anatomy. 75% of the blood from the portal circulation, which is rich in antigens and microbes coming from the gut, and 25% of blood is oxygenated blood from the hepatic artery. The hepatic immune system is tightly regulated and controlled under physiological condition. And in addition to the leukocytes from blood through the liver, there is the liver itself containing both the hepatocytes and non-parenchymal cells, the hepatic satellite cells, the liver sinusoidal cells, and the cholangiocytes. So this crosstalk between the liver cells and immune cells play a central role in keeping the balance of immunity and tolerance. This is a different postulated mechanism, including, as I said, the donor passenger leukocytes, the parenchymal and the non-parenchymal cells, the high dose of antigenic effect, and the MHC class 1 molecules. So what is the cons? It is like playing with the enemy. These studies for the safety of immunosuppression withdrawal regimen are inconclusive. Most of them lack evidence of liver biopsy, and as we can see that most of the studies were retrospective and only in a small number of patients, which were heterogeneous group. They take off medications for a wide variety of reasons, including the non-adherence, the infectious complications, or intentional supervised withdrawal. And graft functions are often evaluated exclusively by the liver function test and in absence of liver biopsy in different trials. So the direct comparison of these trials is difficult because of the lack of standardization. And according to the current research results, the acute rejection varies up to, as I said, 70%. This is one of 2 Japanese studies on living donor liver transplantation, and they follow up patients 10 years after immunosuppression withdrawal. They reported an increased rate of fibrosis in the graft biopsies in patients with operational tolerance compared to patients on immunosuppression, even in presence of normal liver functions. So they concluded that operational tolerance may not be necessarily protected from the morphological changes in the graft. Induced tolerance, in short, it includes molecular and the cellular products. The molecular strategy based on profound suppression of immune response in early the post-transplant period, and the first study came in 2003. where they administered ATG before transplantation and subsequently attempted to wean off immunosuppression. And in this study, no patient tolerated complete immunosuppression withdrawal. We didn't use ATG regularly in liver transplant. And overall, the results of ATG induction in liver transplant were worse than the reported for other trials. The cellular strategy include inducing what we called chimerism through hematopoietic stem cell transplantation, whether autologous, allogenic, CD4 Treg regulatory cells, or the regulatory dendritic cells. Although there are some difference between allogenic and autologous hematopoietic stem cells as regard to tolerance mechanism, what is needed in both attempts is to reconstruct the recipient immune system, achieving what we called re-education. This is one of the very nice trial in Pittsburgh University. It is still ongoing, recruiting patients. They tried, it is on living donor liver transplantation, phase 1 to 2 trial. They recruited dendritic cells isolated from monocytes, then cultured for 7 days in vitro, then re-administered IV for the recipients. And this is the timeline for this study, still ongoing. After 6 months of transplantation, the patients who met the criteria are going to be weaned from the MPA, gradual withdrawal till 12 months, then TAC withdrawal will start reaching to 1.5 year complete immunosuppression withdrawal. The nice in this trial that liver biopsies will be done at 3 years post withdrawal, and also liver functions, renal functions, donor-specific antigen levels, cardiovascular risk factors, and quality of life will be assessed. So this study is very promising, and we all looking forward for the results. The future goals, as we said, there is studies on the clinical usefulness of the non-invasive biomarkers in immunosuppression management, and this could be used for the future personalization of immunosuppression and maybe immunosuppression withdrawal. Just a slide on xenotransplant as a future goal. The first successful pig to human transplant, heart transplant, was done this month, and the first successful pig to human kidney was in September 2021. Keeping in mind that the 3 main types of rejection that could occur are very aggressive, including hyperacute xenograft rejection, acute humoral, and acute cellular rejection. In liver, it seems to be more difficult to be performed compared to heart and kidney, and thrombotic microangiopathy in the graft and systemic consumptive coagulopathy appear to be more severe in liver xenotransplantation. So to conclude, mechanism of tolerance after transplantation is still not well understood, and because of difficulty to conduct prospective, multi-center, and longitudinal long-term studies on clinical transplant tolerance, the risk of immunosuppression withdrawal remain uncertain. Attempts of immunosuppression withdrawal must be done within the context of strict clinical trials, and protocol biopsies is mandatory in such cases. Prognostic factors for post-transplant tolerance include the etiology for liver transplant, non-viral, non-immune, the time from transplantation, as we said, and stable liver functions. Thank you all, and I like to thank my colleagues in Ain Shams Center for Organ Transplantation.
Thank you very much, Dr. Iman. Did you practice induction tolerance in your cases?
No, it's just operational tolerance. In some cases, like patients non-compliant to treatment, non-compliant to follow-up, or patients with severe side effects of immunosuppression. But we didn't do any clinical trials on tolerance, induction tolerance.
Even in the pediatric age group,
no,
they never stopped.
Most trials up till now in Egypt are carried out as observational trials on operational tolerance, people who stop treatment by themselves.
Okay, thank you.
But I think no one of us has
the courage
are so brave to do so.
Okay. اتفضل.
Dr. Iman, I really appreciate your very excellent presentation. I really enjoyed. I have several questions for you. Considering the process of tolerance, you can target either central tolerance or operational tolerance. And operational tolerance implies the initial antigenic stimulation and the switch from the helper state or helper reaction to the regulatory reaction. And this implies three important steps, including ATG induction and switching from the immunosuppressives, which would suppress the Tregs, which is the CNI. You need to stop the CNIs, and switch to the mTOR inhibitors, which are known to upregulate the Tregs. So this is the protocol. You can never reach operational tolerance under CNI because they suppress the regulatory population. Could you comment on this part, please, first?
Yes, I agree with you that sirolimus or everolimus mTORs have immunomodulatory effect and upregulating the Treg cells, but what we expecting is withdrawal of CNIs. CNIs is still the backbone of any immunosuppressant protocol. What we expect is gradual withdrawal of CNIs and shifting to another immunosuppression before achieving tolerance. ATG is not used so much in liver transplant recipients.
What I mean that you can't maintain a state of operational tolerance under CNI.
Yes.
Okay.
Yes.
The other thing is that in a trial to induce central tolerance, and you mentioned it elegantly, is that you are targeting the initial dendritic cell from the donor. Would you target this before the perfusion of the graft, so you can target the dendritic cell while in perfusion state to avoid its initial antigenic stimulation by targeted immunosuppression by delivery of mTOR inhibitors through the oxidized LDL carrier to deliver the mTOR to the dendritic cell and the endothelium of the donor. By that, you avoid the initial antigen stimulation and you can reach a state of central tolerance by a chimeric process.
Yes.
Do you have any data about this?
The study in Pittsburgh, still recruiting patients. They will infuse the study design postulated to do the dendritic cell infusion after in vitro cell culture 7 days after cell culture before the operation, before perfusion.
But this is
the design. We are waiting for the results.
This is in a different cohort of situations where you transfer the dendritic cells into regulatory dendritic cell. You reach a passive antigenic stimulation state, but in the targeting the passenger lymphocyte of the dendritic cell population by treating them with mTOR inhibitors, this is not a passive. This is an active process of central tolerance.
This is the study design. Of course, I have no experience in this in Egypt.
No, I am asking about your reading from the literature.
This study design, I think they are trying to do it more smoothly with tapering of immunosuppression, but they are not using mTORs and they are not using ATG.
The tapering of immunosuppression is not in the favor of a tolerant state. You need to do the switch to the immunosuppressants, which maintains the Tregs, not gradual withdrawal. My last point that you elegantly mentioned, the xenotransplantation trials and recently the heart transplantation, was it through a blastocyst chimerism or the CRISPR-Cas technology? The cluster regularly interspersed palindromic random repeats.
I think it is genetically engineering. It is the second type.
The second type.
Yes.
How far is this specific to the required gene editing? Yani we can give a CRISPR-Cas enzyme technique. It might act on the site we want and act as well on any other site in the genome and has deleterious side effects.
I think the long-term results is not yet understood. The heart transplantation that was done this month is for dead recipient. brain death.
Yeah.
So he is maintained on a ventilator.
And it's
what
for a
about
short
his
while,
long-term outcome? What about his immunosuppression? We don't know.
I believe the future will be for the blastocyst chimerism, because it induces human organs in the pig. But the CRISPR-Cas, unless we reach the specific enzymatic gene editing process, without this specificity, we won't be successful. It will have deleterious side effects elsewhere.
Yes.
Thank you very much. I really enjoyed your talk.
Thank you, Dr. Ayman.
لا خايف منك.
Now it is my pleasure and honor to introduce Professor Dr. Tariq Hussein, Professor of Nephrology, Cairo University. I would like to thank him accepting the title of this lecture, Individualization or Individualized Immunosuppression for Kidney Transplantation.
Bismillah ar-Rahman ar-Rahim. First of all, I would like to thank the organizing committee and my dear friend Professor Gamal Saadi, Dr. Muntasir, Dr. Muhammad على الميتنج الجميل واللقاء الجميل مع بعضينا. إن شاء الله هندسكس مع بعض a tough subject. Individualized immunosuppression in kidney transplantation. The idea of this talk is that how to tailor immune suppression for certain person to gain the benefit of the immune suppression and avoid the hazards of immune suppression. How to go into a balance between benefits and harms. The main scene of this talk depends on genetics, because genetics is our way to know which drug for which patient. Okay, let's go on. Compared to the general population, mortality of kidney transplant recipients is still 4 times higher. That's because under immunosuppression will cause rejection, graft loss, and during management of the rejection, we intensify immunosuppression, causing complications and maybe patient loss. And on the other hand, over immunosuppression will cause post-transplant infections, malignancies, which also will lead to patient loss. Then defining individuals at high risk for acute rejection may allow for better individualized management. You can see here that this is our goal, the adequate immunosuppression. This is our goal, but it is somewhere between the hammer and the anvil. We are compromised between the hammer and the anvil. The hammer is over immunosuppression, which in all the recipients and will cause recurrent infection, malignancy, and so on, while under immunosuppression will cause rejection, and especially in young recipients and in case of HLA mismatch, and so on, many factors. What's precision medicine? Now we are shifting from the era of evidence-based medicine to the era of precision medicine, precise management for certain patients. Precision medicine seeks to identify safe and effective treatments based on genetics and environments that are unique to an individual. Individualized immunosuppression, we will go through 3 main topics in this talk. Number 1, genetics and immune response, and precision pharmacology. And finally, we will discuss risk stratification shortly and briefly. Start with genetics and immune response. Here we will discuss the underlying genetic variation in the immune response itself. Not every one of us has the same immune response like the other. We are different. And donor genetics also has a role, not only the recipient genetic, the donor genetics and finally the recipient genetics. I will give examples because the matter is too vast. Example 4, individual variation in between us. Epigenetics has a role. Example for epigenetics is microRNAs. MicroRNAs are non-coding RNA that mediate post-transcriptional gene regulation. This is not DNA, this is not the HLA. These are microRNAs called small interfering RNAs. They interfere with post-transcriptional gene regulation, not the gene itself. Specific microRNAs has been shown to be associated with graft rejection زي الجراف ده كده. دي small RNAs، دي الشكل بتاعها الأول، وبعدين يحصل لها بروسيسنج، بعدين تيجي السمول RNA تمسك في الماسنجر RNA ده اللي هو الجين، هيبتدي الجين يبروديوس البروتين بتاعه، يحصل له ترانسكريبشن، يحصل له بوست ترانسليشن، فالجين بيشتغل عن طريق الموليكيول ده، يجي السمول RNA interfere with gene function. In this clinical study, I've shown that clearly, it was shown clearly that small RNAs can produce or lead to rejection, more rejection in the recipient. Donor genetics. Survival of kidney allograft has been observed that survival of allograft from deceased African Americans is shorter when compared to allografts from white donors. في فرق في racial difference. This racial difference drew attention of investigators, and subsequently it was found that two common variants, G1 and G2, in the last exon of apolipoprotein 1 are common in populations of African ancestry. These two variants account for increased graft failure and even for end-stage renal disease in the African ancestry. This study have shown clearly that apolipoprotein risk genes are associated with more graft rejection and graft failure. Not only that, but in this study, in the JSON, it has been shown clearly that in the African Americans, the presence of apolipoprotein high risk gene was associated not only with the graft failure or the reduced graft survival, but from the early beginning, the estimated GFR was even lower in the donors who have this apolipoprotein high risk genotype. Another gene, the MIC-A class related genes. MIC-A are non-HLA. MIC-A is highly polymorphic gene implicated in the innate immunity. Anti-MIC-A antibodies were associated with acute and chronic rejection. Donor MIC-A, donor, not recipient. Donor MIC-A A51 mutation is associated with increased proteinuria in the kidney transplant. And it was also associated with increased CMV. The donor MIC-A. This is the position of the MIC-A. We have MIC-A and MIC-B. MIC-A is on the short arm of chromosome number 6 related to HLA-B. This is the position, and the function of MIC-A is different from class 1 and class 2 antigens. You can see here that the cursor is not helpful. You can see that MIC-A is here, acts through the natural killer cells, innate immunity, not through the adaptive immunity T cell, T4 or T8. And this study has shown clearly that MIC-A negative patients do well better than MIC-A positive recipients. Now another gene, which ATP binding cassette subfamily gene. This kidney donor CC gene at this number was associated with increased risk of long-term graft failure. Not only that, but also another gene of the same subfamily ABCC1 was associated with increased risk of graft loss. Feculin, another donor gene. This is a good gene. Feculin is involved in the maintenance of tissue homeostasis through engaging apoptotic and necrotic cells. A variant of feculin in donors was associated with lower incidence of graft rejection and graft loss. This is a good gene. Then there is variation of the genes and variable effect. How about the recipient? The zinc finger proteins or zinc finger domains are implicated in transcription regulation, signal transduction, and DNA repair. And these are very common types of proteins in our nuclei. And the risk allele is frequent in individuals from European and African ancestry, but not present in East Asian. And in this study, it was shown clearly in this study that the presence of the risk allele was associated with lower graft survival. Then, to individualize immunosuppression, we have to know the makeup, the genetic makeup of the donor and the recipient, and to apply precision pharmacology. Now we will go into precision pharmacology. Precision pharmacology is the science that was based on the observation. Half-life of many drugs is similar in monozygotic twins, whereas different in dizygotic twins, suggesting a genetic underpinning, genetic variation between people. This was the original observation. And then we will go through our medications used usually in transplantation, like thymoglobulin. Anti-thymocyte globulin is a polyclonal IgG. It acts through inhibiting TNF-alpha production. So transplant recipients with TNF-alpha gene polymorphism are at high risk if not treated with thymoglobulin. And this is the study that's shown. In this risk allele, you can find that if this patient with risk allele not received thymoglobulin, rejection is very high. Rejection is high. Then belatacept is a hopeful drug to replace cyclosporine, but there is a drawback with belatacept. Belatacept also, it acts through STLA4 Ig fusion protein, and it acts by blocking CD28, اللي هي co-signal inhibition. Polymorphism in CD28 gene was shown to be associated with belatacept resistance. So in the clinical studies of belatacept, it was found that many patients rejected the kidney, unfortunately. Then they was discovered later to be due to the polymorphism in the CD28 gene. This study have shown that, and the patient who has stable graft these people didn't have the CD28 variant. Tacrolimus. We all know the CEP enzyme that metabolize tacrolimus. And this gene, CYP3A5 star allele 1, the star allele 1 is the normal variant, which metabolizes tacrolimus. This is more common in African Americans. They metabolize tacrolimus more than others, so they need higher dose of tacrolimus. While the loss of protein function, the CYP3A star allele 3, is poor function and don't metabolize tacrolimus, so they need lower doses of tacrolimus. This graph also shows the same. The red line, these people are extensive metabolizers and need higher doses of tacrolimus. This is more common in African Americans. Not only the dose of the drug and the drug level, but also CEP genes are related to nephrotoxicity, related to nephrotoxicity in the graft. CYP3A5, C3A4 are associated with tacrolimus nephrotoxicity. Cyclosporin, it was studied in pediatric transplantation, and a certain gene has shown higher oral bioavailability for cyclosporin. CEPIC is the Clinical Pharmacogenetic Implementation Consortium. This is an international consortium, and this consortium has recommended pharmacogenetic testing for certain enzymes before applying mycophenolate, which we prescribe commonly for our patients, because deficiency of hypoxanthine guanine phosphoriboside transferase can develop elevated uric acid level, gout, kidney stones, and then kidney failure. So they recommend this test. Allopurinol also, you can suspect which patient who will develop cutaneous conditions by a certain gene assessment according to CEPIC. Also, voriconazole, if was indicated to treat aspergillosis in transplant recipient, a certain gene assessment should be done to make sure that the drug will be effective. And these are the genetic study which is suggested by the CEPIC. And I think in the future, we may need to check our donors and the recipient for the genetic studies before transplantation, because these all genes can these genes can play a role in the kidney transplant outcome. And in this schema, we can see that pharmacogenetics can be studied, genetic modifiers in the donor and recipient can be studied and integrated together into an electronic health record. Then the clinical decision support system will be taken to adjust medications based on genotype and adjust medication based on GFR also. So we discussed the recipient and donor factors briefly and precision pharmacology. Now to the risk stratification. Demographic risk status of the recipient and donor, the age, the ethnicity, and morbid obesity. Younger age is associated with higher rate of kidney rejection, and African Americans, as I have shown, due to the presence of CYP3A5, have higher incidence of rejection. Immunologic risk stratification, you have to take into consideration the early loss of previous graft due to immunological cause, take into consideration delayed graft function, and previous desensitizations. All these are risk factors for immunological risk. The laboratory assessment of immunological risk includes CDC, cross-match, flow cytometry, DNA bioluminex, MFI, the intensity of DNA, and the type. Not only DSA, the intensity and the type, whether complement fixing or not complement fixing, IgG3 or IgG4. T-cell ELISpot test to study the T cells, not only the antibodies. Anti-angiotensin 1 receptor antibody is correlated to graft rejection. The definition of low-risk recipient is variable between different sources, and you can consider that about a minor group of patients, about 30%, who are negative for HLA antibodies, for HLA DSA, for AT1 receptor antibody, and ELISpot assay can be considered as low risk, and the immunosuppression to be tailored accordingly, like withdrawal of steroids and minimization of CNI. Intermediate risk, CDC and the flow cytometry should be negative in intermediate cases, but PRA if more than 5%, DSA, MFI more than 3,000, moderate positive test for anti-angiotensin and positive ELISpot test, but no DSA associated, these can be considered as intermediate risk recipients. High risk recipients, if the PRA is more than 25, DSA have happened after early previous transplant loss. C1q fixing DSCA after transplantation of especially IgG3, anti-angiotensin 1 if highly positive, and if highly positive test was ELISpot, these patients will be considered as high-risk recipients. Conclusions: donor and recipient genetics other than HLA play important role in immune response. Precision pharmacogenetic can help define which drug for whom patient in what dose, and risk stratification can help in tailoring immunosuppression. Thank you.
Thank you, Professor Tariq, for this elegant presentation. Any questions for Professor Tariq? So thank you.
Thank you.
It is now an honor and pleasure to present my dear colleague, Professor Dr. Ahmed Gaber Adam, Professor of Nephrology, Alexandria University, who will talk about immunomodulation and tolerance in kidney transplantation.
Thank you very much, Mr. Chairman, for this kind introduction. I would like first to thank the organizing committee, and on top of it, Professor Gamal Saadi, for giving me this opportunity to speak in this prestigious gathering. And I'm thanking him again for well done conference. To me, it is very well done job. Thank you very much. Although he did give me a great task, and I waiting for, because he's the expert in this. The topic which I was allocated to speak about today is about immunomodulation and tolerance in kidney transplantation. I'm not speaking about tolerance alone, but if there is a difference in between these, as I understand the title is, and it is only in 15 minutes, which I wonder if it will save the time. So I will start by just making a question to the audience, although I'm not surprising that they got, how many really does, at the show of hand, accept that immunomodulation is not similar to tolerance? All of us think that they are the same? Yeah, only one, right? So the other question, how much really you are convinced or believe that immunomodulation and tolerance is of importance for kidney transplantation? Of course, all of us, all right? And how much convinced that immunomodulation tolerance protocol is not settled? Only three, all right. So I'll get presumed most of these two questions is maybe most of you, but the others maybe is not convinced that immunomodulation is not different than tolerance. So the outline is the literature, the references. I got 3 references and a final conclusion, but I will start as I used in the last 5-7 years by debatable conclusion. And the rest of the talk is try to support and explain what is in my debatable conclusion is, because if the time elapsed, at least I got something. If you go to search about immunomodulation tolerance in kidney transplantation, you will get 3,500 references, and most of them in the last 2 years. And if you put immunomodulation and tolerance alone, it is 95,000. And if you use Google, you will get 291K reference about immunomodulation and tolerance. So it is a very hot topic. So what about this? Actually, one of the debatable issues in the kidney, we are the branch of a debatable issue like SLE, HDF, CRRT, preemptive transplantation, adequacy in AKI, cardiac dialysis in ICU, and COVID, and still this immunomodulation and tolerance to complete the list. Immunomodulation and tolerance are not alike. Either or both are needed for better graft survival, better quality of life with less immunosuppression. The dendritic cell, the things which Professor Sadi mentioned a minute ago, which is central in immune response, may be induced by some pharmacological agent to be tolerable dendritic cell. Decreased immunogenicity must be directed to both T and B cells. We all know that. Transplantation in immunocompatible ABO or against a tissue matching HLA considered to make a recipient tolerance to the graft antigen by giving immunomodulatory agents. Immunomodulation can be done by IVIG. Immunomodulation and tolerance is not one step or one drug regimen. It must be a regimen. Still, in the conclusion, the total replacement of the bone marrow of the recipient by the donor results in full chimerism. And that's actually the main tolerance and produce full tolerance. However, the infusion of mesenchymal cell, the prestigious work of Professor Sadi and Mervat Al-Ansari, can be of benefit and question mark. It is immunomodulation and not tolerance that is used to transplant against ABO or HLA. This is not tolerance, but using immunomodulatory drugs, as we shall see in a minute. That's an important item number 10. The B cell is awaiting the proper stimulus to come from the T cell to act. And the big armamentarium of tolerogenic drugs, which must be used in conjunction or combination and synergistic to induce tolerance, not only one drug. However, the same tolerogenic drugs, if used solo, can cause immunomodulation rather to induce tolerance. So they are different according to my understanding. So going to the literature, of course, the immune response involved in organ transplantation and the T cell recognition of an antigen is the primary event. And the key step acquires the T cell receptor with a presentation of antigen-presenting cell and a co-stimulatory receptor ligand interaction. And this activates the T cell to be directly cytotoxic to help the B cell antibody production. And proteins encoded by two classes, we know that, inevitably, if you organ transplantation between identical, that's good. If not identical, this is inevitably rejected in the absence of immunosuppressive agent. The antigen presenting products is the main key. The class 1, of course, is presented except in the red blood cells, and it causing what we call it CD8 positive T cells. On the other hand, the class 2 is presented in other cells as an interstitial dendritic cell, macrophage, and B cell, and expressive may be upregulated in epithelial cells and vascular endothelial cells. And this is causing another antigen cells called CD4 positive cell. The activation of co-stimulation pathway is required for these T cells to be cytotoxic, causing two CD28 and CD40. But the leukocytic migration is important, including what is new called selectin-mediated rolling, chemokine, integrin, platelet endothelial cells, and other. And the T helper cells are divided into two cells. And actually, both of them is involved in tolerance, the type 1 and type 2. The type 1 cell produce the interleukin, and this causing the rejection, and the acute allogenic rejection predominantly is this through type 1 cell immune cells. T cell activation results in what we call effector cells. So just if you go up, the T cell coming first, and then it will end by the B cell
but in between there is effector cell in between CD8 and CD4. And you cannot do tolerance without causing this all algorithm. If you tackle only one, that will not be good. And what we call it immunological synapse, which presenting the antigen to the cell. And if you see, it is more than integrin, more than one thing. And if you go to the HLA, I will just concentrate about, there is a DR and a beautiful lecture by Professor Mervat Insari about DQ, but I will expect that the DP will be in the time coming because it will help to make it. The T cell is directed by a direct alloantigen and indirect to be activated. Just concentrate. The antigen presenting cell is just on the top and the T cell just in the bottom. And in between, you have a lot of molecules which must tackle so as to get tolerance. And as I mentioned, the type 1 cell is related to the B cell, which causing activation through interleukin-2. But the type 2 cell is actually related to inducing tolerance, according to this paper. And the selectin in the migration of the leukocyte is important for this. And if you differentiate, if you want to introduce tolerance, you must tackle both class 1 and class 2, and there's a lot of difference. So the molecule or the pharmacological agent will not be the same because it is maybe intracellular versus extracellular, or nucleated cell, and CD8 versus CD4. Just to get a glimpse of incompatible blood transfusion, because I want just to mention that incompatible blood transfusion, we do immunomodulation of the recipient immune system by typically using IVIG, so as to transplant against ABO incompatible. So we are not doing tolerance, but we are using immunomodulatory agent as like IVIG, which block the FC receptor, but actually there is a rebound in the titer because you may get this naked receptor later on. Still, the B cell depletion is one of the protocol for incompatible ABO, but it by itself, it will not introduce tolerance. It is an immunomodulation to try to transplant against ABO using rituximab or splenectomy, which is lower the immunogenicity of the incompatibility, this immunomodulation with depletion of the B cell. But the AB incompatible must have different criteria. This is not the context to mention it, but it is still not known how to use either recombinant ATG or other ingredients. Just to mention, they started the immunosuppression 4 weeks. I remember the talk or the remark from Professor Qurei, because the thinking of increasing the immunosuppression is starting a little bit earlier in our transplantation. At least in ABO, this is the protocol. And you must aiming for a higher level of TAC, 8 to 12. And you must monitor by the titer. Although this is an old chapter of tolerance, but just I want to mention there is something called recognition and another called central tolerance, which is caused by the bone marrow and mesenchymal cell, and some called peripheral tolerance. And coming at the end, the B cell, the T cell is the crucial, but you must tackle both of them to get this two pathway active, and the B cell awaiting the signal coming from the T cell to act. And you must tackle all of these. So we got central and peripheral either including different mechanisms, depletion, apoptosis, energy, or reassure, whatever direction. The strategy and protocol to inducing tolerance, including molecule-based, cell-based, total lymphocyte irradiation, which is a little bit obsolete now. These teratogenic drugs include many different things as thymoglobin and anti-CD25. And the cell-based, including a donor cell infusion of a highly enriched CD34 hemobiotic progenitor cell, something like the work of Professor Saadi. And if you got a replacement of the recipient bone marrow, this is the only thing that you can get full chimerism if you making a bone marrow transplantation prior to the kidney transplant, and this will help to get a full tolerance. The total lymphoid irradiation is now more or less obsolete. The surgical procedure of doing splenectomy, although it has got advantage, but it may be only in Japan. And just 3 references 6 months ago. One is the antigen-specific regulatory T cell, and saying that the importance of the Treg is important to induce this mixed chimerism. And we have different types of the Treg, which is important. That's why I am totally supportive. You cannot induce tolerance with CNI on the board. You must remove the CNI if you want tolerance. And the mTOR is beneficial in this. The transcriptic analysis find a tolerogenic dendritic cell, and this dendritic cell is important to change the phenotypic cell. Can I have 1 or 2 minutes? Or if you don't mind, just I will finish. Thank you. Better define a gene signature of these dendritic cells. And these dendritic cells is a crucial thing. And the last paper which I choose is about the third mechanism, which is recently for tolerance, which is a demethylation signal. And this demethylation causing what is called in this trial about operation tolerance and not induced or prepared tolerance. By getting this cellular molecular pathway by this study, demethylation in the gene involved in the immune system. And Mr. Chairman and my dear colleagues, the conclusion, despite the advances in understanding the cellular and molecular mechanism of the alloimmune response, tolerance induction in renal transplantation remains an important clinical challenge. In clinical practice, prevention of graft rejection has combined tolerance mechanisms such as suppression of the activated T cell, interleukin pathway, decreased antibody, and tissue chimerism. However, not completely satisfactory. And the reason for these seemingly innumerable challenges is still on the board. And my last slide, in absolute term, tolerance is the hope, but still it is a dream. And immunomodulation can be done to transplant against barriers and reduce the need for aggressive immunosuppression later on. But immunomodulation is within the strategy of tolerance, but it is not. And thank you very much.
Thank you, Professor Ahmed, for your elegant presentation. But I want to have one question. What is the obstacle against doing bone marrow transplantation, which is done now perfectly before doing renal transplantation?
You want, before doing a kidney transplant, to do a bone marrow transplantation to get tolerance? That's another thing. I don't think intentionally they are doing it. But if the patient needs bone marrow transplantation, he will be tolerant to the kidney later on by the same donor, I mean.
Do you read any papers or about that event of patients who on?
Yes, that's a common fact, I think. Bone marrow transplantation by the same order will lead to the kidney tolerance after a while from immunosuppression. Dr. Sadia Isaac.
Actually, the strategy of performing bone marrow transplantation and changing the immune system of the individual and then giving him the same kidney from the same donor sounds very logical. But in practice, it proved not to be successful. And there were reports of both bone marrow transplantation and the stem cell transplantation, which could not achieve a tolerant state. And I recall one of the cases in Cairo University where a sister gave her brother bone marrow grafting for a primary disease, and after probably 5 or 6 years, he got renal failure, and he got the kidney from the same sister, and he was maintained on immunosuppression. And while I was following up the case with my dear colleague, Professor May, in the outpatient clinic, probably 3 or 4 years after the kidney transplantation, we decided to try why not to withdraw the immunosuppression. He is getting the bone marrow and the kidney from the same donor, from his sister. Once we tried to do this, in a couple of months, he got acute rejection.
Can I respond?
Please.
Definitely. The stem cells and the mesenchymal infusion cell definitely not working. Yeah, that is questionable. But total bone marrow transplantation, the paper I read just prior to the kidney transplant from the same donor, and it makes logic, as you said, will get tolerance. That's
it is logic, but the report about these cases are not successful. I will get you the reference. وكان في عاملين studies على يمكن لو انا فاكر الرقم صح around 50 or 60 cases, and they failed to induce tolerance.
Right. You got point. I read the paper. Yeah. Right.
We can exchange the papers.
All right. Sure.
Professor Said.
Early in the 90s, they started to talk about what's called local immunosuppression, and after that, we didn't hear for this maybe for 20 years or so. And then I attended maybe 2 or 3 lectures for Professor Saadi about the use of nanotechnology or nanoparticles to induce some sort of tolerance or immunosuppression before organ transplantation. Can I hear any comment from you and or Professor Saadi about this issue, please?
Nanotechnology, I don't know. Sorry.
Actually, what you are speaking about is perfusing the graft with molecules, which is the oxidized LDL, which would have receptors on the dendritic cell and on the endothelial cell, اللي هم الانtigen presenting cells. If you transfer mTOR to these cells, you will suppress them. They are going to switch to a regulatory dendritic cell and do not perform the initial antigen stimulation.
No.
I don't have data because these are clinical trials in the USA, and we don't have data about it.
I'm sorry, Professor Saadi, I'm totally against, because the tolerance must be a regime to induce tolerance, whatever the operation is, and it must have program from the antigen presenting cell till the B cell. You cannot say the dendritic cell I will tackle and this will induce tolerance. As you said, because you mentioned this to Dr. Imam, you must have a program, a full program with the consequences to get tolerance.
أنا موافق.
Only one step will not induce tolerance.
أنا موافق حضرتك. أنا بقول لحضرتك this will avoid the initial antigen stimulation.
This will be immune modulation, like ABO incompatible or HLA tissue incompatible, to get the lower immunosuppression and transplant against this barrier.
You are fully right. اللي هو بيسأل عليه ده هو ده will induce avoiding of the trained immunity, of the innate immunity, to avoid developing a trained immune response and antigen stimulation. But this is not tolerance.
Yes, that's the point I want.
This
yeah,
is
this
not
not tolerance. Yeah,
it is not. It is avoiding the training of the immunity, and you tackle the innate immune response, not to.
In this context, I agree. Not tolerance, right? Yeah.
هو سألني على كده.
حاضر يا باشا.
فأنا جاوبت. طب يا سعيد.
Thank you, Professor.
Now I have the honor to introduce my co-chairman, Dr. Muntasir Zaid, Professor of Nephrology and Director of Kidney Transplantation in Alexandria University. He will speak about induction and maintenance immunosuppression in sensitized renal allograft recipients. تفضل Dr. Muntasir.
Thank you, Mr. Chairman, for your nice introduction, and I will talk about induction and maintenance immunosuppressants in sensitized renal allograft recipients. Sensitized patients are a unique group of allograft recipients having memory B and T cells that elicit immunologic recall response, which may lead to early and often severe antibody-mediated rejection. The use of induction agents with cell depleting capabilities appears to be a reasonable and efficient way to reduce the size of donor-specific clones and improve graft outcome in sensitized renal allograft recipients. We have many questions to be answered. Does ATG have an advantage over interleukin-2 receptor antagonist as an induction agent in sensitized kidney transplant patients? Does rituximab or bortezomib have a role as an induction agent in sensitized patients? And what is the most appropriate induction regimen for sensitized kidney transplant patients? Anti-thymocyte globulin is a purified polyclonal immunoglobulin harvested from rabbits after immunizing them with human thymic tissue. While it predominantly depletes T cell, ATG has numerous other immune modulatory actions because this polyclonal antibody also contains antibodies against B cell, plasma cell, dendritic cell, natural killer cell antigens, adhesion molecules, and the chemokine receptors. ATG appears to reduce the risk of antibody-mediated rejection in patients with preformed DSA, presumably by removing T cell help for allograft B cell and via B cell depletion by antibodies that directly bind the B cell. Of course, it have an increased incidence of infectious viral infection. ATG may reduce the incidence of de novo DSA in sensitized patients, and two retrospective cohort studies evaluated the optimal induction dose of ATG in high immunologic risk patients. Turner et al. Compared the outcome of an ATG dose less than 7.5 milligram per kilogram versus more than 7.5 milligram per kilogram in 96 adult patients with regraft or PRA more than 40%. He concluded that the results suggest that in high-risk kidney transplant recipients, a total rapid ATG doses that less than or equal to 7.5 milligram per kilogram are safe and effective in achieving a low rate of acute rejection and graft outcome comparable to higher dose. Another study by Kellem et al. Concluded that a 3 or 4 dose course of rapid ATG 1.5 milligram per kilogram dose provides excellent protection against acute rejection, even in patients at increased risk, with the potential for cost saving from reduction in hospital stay and medication doses. These results suggest that 3 daily doses of 1.5 milligram per kilogram ATG provide good protection against acute rejection, even in patients with increased immunologic risk, with the benefit of reduced cost and the potentially decreased infection risk. In conclusion, ATG appears to be beneficial in sensitized renal recipients and should be used as a single or as a part of a combination of induction agents in these patients. There are only few randomized controlled trials of ATG versus interleukin-2 receptor in patients treated with tacrolimus with high immunologic risk. Noel et al. Reported a multicenter randomized controlled trial comparing ATG with interleukin-2 receptor antagonist daclizumab involving 227 patients with high immunologic risk. And the high risk was defined as current PRA more than 30%, peak PRA more than 50%, loss of kidney from rejection within 2 years of transplantation or 2 to 3 previous grafts. ATG was administered daily between day 0 and 7 at a dose of 1.25 milligram per kilogram per day. The maintenance immunosuppression comprised TAC, MMF, and the steroids, and the primary endpoint was biopsy-proven acute rejection. The ATG group had a lower incidence of post-biopsy-proven acute rejection and steroid-resistant rejection at 1 year. Daclizumab versus anti-thymocyte globulin in high immunologic risk renal transplant recipients. Noel et al. Also reported concluded that among high immunological risk renal transplant recipients, thymoglobulin is superior to the eculizumab for the prevention of biopsy-proven acute rejection, but there is no significant benefit to 1 year graft or patient survival. As regards rituximab, it is a chimeric murine human monoclonal antibody active against cell membrane protein CD20 expressed on the surface of B lymphocyte before their terminal differentiation into long-lived plasma cell. Rituximab is known to eliminate circulating CD20 B cell to reduce the number of these cells populating spleen and lymph nodes. In secondary immune responses seen in sensitized patients' memory B cell expand rapidly and generate a burst of plasma cell, mostly donor-specific, that peak on day 7 in peripheral blood, followed by secondary memory B cell that peak on day 14 to 21 days. These plasma cell bursts coincide with a sharp increase in serum antibodies that reach a plateau at day 10. Carey et al. Demonstrated a preventive effect of rituximab on an amnestic response in patients with cryptic sensitization to HLA antigen. They identified HLA-specific B cell by staining with HLA tetramer. 26 patients who had tetramer-stained B cell and thus considered sensitized to HLA antigen, but had no detectable anti-tetramer antibody prior to transplantation were identified. Of these patients, 16 were treated with rituximab and 10 were not treated with rituximab. And post-transplant anti-tetramer antibody was detected in 13 of 16 patients not treated with rituximab, but none in the treated patients. And these results suggest that rituximab has the potential to control immunologic recall response. Randomized controlled trials and the retrospective analysis of the efficacy of rituximab as an induction agent have also been conducted. Tyden et al. Reported a double-blind randomized controlled trial in 140 low standard immunologic risk patients, and the mean PRA was less than 5% in both groups. And the 96% were first transplant. There was no significant difference in acute rejection, patient or graft survival at 6 months between rituximab 375 milligram per square meter and the placebo group. Another double-blind single-center randomized controlled trial of 280 kidney transplants compared rituximab induction with no induction. Patients were stratified into immunologically high risk or low risk. The primary endpoint was the incidence of biopsy-proven acute rejection. In high-risk subgroup, the incidence of biopsy-proven acute rejection was significantly lower in rituximab-treated patients compared with placebo-treated patients. However, within low-risk subgroup, there was no difference in biopsy-proven acute rejection rate between rituximab and placebo group. These two randomized controlled trials and the cohort studies suggest that rituximab is effective in preventing the development of de novo DSA or acute antibody-mediated rejection in sensitized patients, but has little benefit in immunologically low standard risk patients. For bortezomib, which is a selective inhibitor of the 26S proteasome, which is present in both cytoplasm and the nucleus of eukaryotic cells, actively proliferating cells are more vulnerable to bortezomib because of its interfering action on cell cycle progression. Bortezomib is as an induction therapy in organ transplantation has not been adequately evaluated. A pilot randomized controlled trial evaluated safety toxicity profile of 4 B-cell targeted regimen as a prelude to a larger randomized controlled trial. Immunologically high-risk renal transplant recipients were randomized to induction with ATG plus rituximab, ATG plus bortezomib, or ATG plus rituximab and bortezomib. Each treatment arm comprised 10 patients. Acute rejection incidence was comparable between the arms with or without bortezomib. Half of the bortezomib-treated patients developed or experienced worsening of peripheral neuropathy. Since sensitized kidney transplant patients develop secondary immune response characterized by rapidly proliferating donor-specific plasmablasts. Within days after transplantation, bortezomib might be a valuable option for reducing the number of donor-specific clonal cells. Alemtuzumab is a humanized anti-CD52 pan-lymphocytic for both B and T cell monoclonal antibody that is approved for treatment of chronic lymphocytic leukemia. Several randomized controlled trials and observational studies have compared alemtuzumab with ATG. One of concern regarding alemtuzumab is that its benefit in reducing acute rejection may decrease over time. Other long-term outcomes, including graft and patient survival and development of chronic allograft nephropathy, may also be worse in patients receiving alemtuzumab compared with ETG. And thus, alemtuzumab may not be an appropriate induction agent for sensitized patients. In a randomized trial, 139 high-risk patients, risk defined by regraft, PRA more than 20%, or black race were treated with alemtuzumab or ATG, while 355 low-risk patients received alemtuzumab or basiliximab. All patients received TAC-MMF and underwent early steroid withdrawal. In high-risk cohort, there was no difference in acute rejection between alemtuzumab and ATG groups at 12 months. However, late acute rejection defined as rejection after 12 months up to 36 months in patients who did not have acute rejection in the first 12 months was more common with alemtuzumab, although this difference did not reach statistical significance. In post-hoc analysis, C4D positive acute rejection was more prevalent in the alemtuzumab group. Interleukin-2 receptor antagonist tocilizumab in highly sensitized patients who failed desensitization with high-dose IVIG and rituximab, tocilizumab has been successfully used in combination with high-dose IVIG and rituximab to desensitize patients who failed standard of care desensitization therapy. For maintenance immunosuppression, what is the most appropriate maintenance regimen for sensitized kidney transplant patients? A triple drug regimen consisting of TAC, MMF, and BRID appears to be most appropriate in sensitized high immunologic risk transplant patients. Alternative regimens that use cyclosporin in place of TAC and sirolimus in place of mycophenolate have shown inferior outcome, such as higher incidence of acute rejection and or graft loss. Steroid withdrawal or avoidance and the calcineurin inhibitor withdrawal or avoidance should also not be considered in sensitized patients, since these regimens have shown to increase acute rejection. Belatacept, which is an inhibitor of CD28, CD86 co-stimulatory pathway with a tacrolimus-based regimen, showed increased acute rejection in the belatacept arm. Since memory T cell lacks CD28 expression, belatacept appears to have limited efficacy in sensitized patients. The optimal trough level of TAC in sensitized patients has not been established. It is obvious that the higher the exposure to tacrolimus, the lower risk of de novo DSA and rejection, but higher trough levels at the same time increase risk of infection or nephrotoxicity. The efficacy limiting toxicity elimination symphony trial, low-dose TAC, mycophenolate, and glucocorticoid with daclizumab induction produced superior allograft survival and fewer acute rejection when compared to cyclosporin and sirolimus-based regimen. The immunologic risk of enrolled patients was low to standard, and the target trough level in the low-dose tacrolimus arm was 3 to 7 nanogram per milli. We looked for the correlation between the novo DSA and tacrolimus trough level in a cohort of 596 primary patients without pre-existing DSA in the context of HLA-DR DQ-ablet mismatch. HLA-DR-DQ ablet mismatch was an independent predictor of DN, DSA development, and mean tacrolimus trough level less than 5 nanogram per milli were significantly correlated with de novo DSA. And these results indicate that higher trough levels are associated with lower incidence of donor-specific DSA, and the minimal trough level to be maintained for the prevention of de novo DSA is 6 nanogram per milli. In the absence of acute rejection, tapering to 5 milligram by 1 to 3 months is a common practice. Steroid withdrawal should not be attempted in sensitized patients since this increases the risk of acute rejection. To conclude, Mr. Chairman and dear colleagues, induction with depleting agents should be implemented in sensitized patients. A triple drug regimen consisting of TAC, MMF, and corticosteroid seems the most appropriate maintenance immunosuppression for sensitized kidney recipients, and the trough level of tacrolimus should be maintained at a minimum of 5 or 6 nanogram per milli. And thank you.
Thank you very much, Dr. Muntasir, for this elegant presentation. Is there any questions for the speaker?
Thank you, Professor Muntasir. I got two simple questions. This protocol will be adapted whatever the level of PRA, if it is more than 90, or you must decrease the PRA first. The second question, if you are confronted by a couple of patients, the PRA for the recipient is 20 to 50, for example, but the flow cytometry and the cytotoxic by Luminex is negative more than one time. Which category are you categorizing this couple? High risk or low risk or medium risk? Thank you.
For induction of immunosuppression or for desensitization for patients in high risk immunosuppression, we start by rituximab 3 weeks before day of transplantation, and then 2 weeks before transplantation, we start plasmapheresis plus low dose 100 milligram per kilogram body weight IVIG. 6 plasmapheresis sessions will be conducted over the 2 weeks. 3 sessions every week till the last one day before transplantation. At the same time, 2 weeks before transplantation, we start with a triple therapy of TAC, MMF, and prednisolone. At the same time, we have to perform cross-match and Luminex before 1 week before transplantation and 2 days before transplantation. And on the day of transplantation, we start ATG regimen for day 0, day 1, and day 3, and we can extend it up to 5 doses. This regimen is not one drug regimen, or as you see, we need to have many drugs in the desensitization protocol. We have to consider desensitization for anyone above 20, but it depends upon the severity or risk stratification. We can modulate the regimen of immunosuppression or desensitization regimen.
Okay, is there any other question? Thank you very much, Dr. Muntasir. And now we are closing the session.
It was a very interesting and stimulating session. Thanks for all the speakers and moderators. And now we will move to the last part of the Congress, which is a symposium sponsored by AstraZeneca. And we are privileged to have Professor Muhammad Hani Hafiz as the speaker. And he will cover the topic of, can we delay the progression of CKD? Professor Hani, please.
Thank you very much, Professor Gamal, for this outstanding. And it is my pleasure and honor to be the last speaker in it. I will try to go rapidly because you know that we are hungry. And I will try to ask yourself, is there any way to delay the progression of chronic kidney disease? This is actually an important target for all nephrologists. As you know, the CKD represent nowadays more than 840 million people all around the globe. Actually, a big percentage of those are in the era of stages 1 and 2, but the CKD 4 and 5 that we met frequently is increasing in our regions. As we are speaking about the kidney, we should not forget that many of our patients have mortality because of cardiac disease. As you know, protecting the kidney may protect the heart and vice versa. And we see that these are different mechanisms beyond the RAS activation. We have the kidney damage, hypoperfusion, apoptosis, fibrosis, and glomerulosclerosis increase and may progress to affect by the sodium and water retention, by the vasoconstriction, may affect and lead to cardiac complication. We have some data about Renal on chronic kidney disease outcome in type 2 diabetes, and it has got beyond the use in diabetes, this mineralocorticoid receptor antagonist. You know, this is the pathway of their use since 1938, but in 2019 and 2020, we have some promising data in the Fidelio DKD study about improvement of the kidney in addition to the cardiovascular efficacy. So this could be, as you see here, the difference between the arm of placebo and the arm of Finerenone. There is some improvement. And on the left side of the middle line here, you see the Finerenone better in the key cardiological secondary endpoint, and more important to us, the secondary composite kidney outcome also improved. And also we have here something very important, which is the improvement of the proteinuria. You see here, the proteinuria is decreasing in the Finerenone arm in comparison to the arm without Finerenone. This is one of the important study. A very important study is the SGL2 inhibitors.
لو سمحت أستاذ، لو سمحت كله، بس ما فيش داعي نتكلم عشان نسمع الدكتور هاني. يعني eat but give him your ears.
SGL2 inhibitors are an important aspect in the control of diabetes. As you know, diabetes is increasing globally. And if you see the developing countries, you see that South America is increasing by 55%, Asia is increasing by 75%, and Africa, in which we are speaking in the last 2 days, is increasing by 150%. So we have an epidemic of diabetes all over the developing world. And it is very important to ask ourselves, is there a relation between the intensive glucose control and the renal disease or not? According to many studies, Oghr, Advance, UKPDS, all the studies, you see here the curve. I think this is not working, but you see the curve to the left. All the studies show favors more intensive glucose control. So definitely, if you control the blood sugar in a better way, you will end with less renal disease. Since long time, many of these studies are since long time. Therefore, the emergence of the SGL2 inhibitors actually are a very important advance. And you see here how these drugs work by different mechanisms. Vasoconstriction, after transient drop of the GFR for around 2 weeks, they decrease the inflammation, the extracellular matrix, and the fibrosis. And a reduction in the sodium and glucose reabsorption induced by SGLT2 inhibitor reduced the tubular workload, ameliorate the renal hypoxia. This is very important, resulting in improvement in tubular cell structure, integrity, and possibly function. Anti-inflammatory effect, activating the tubulo-glomerular feedback and reducing hyperfiltration. These are the pathogenetic mechanism by which SGLT2 inhibitors may be helpful. Controlling the hyperglycemia, controlling the hypertension, alter the tubulo-glomerular feedback, podocyte loss and improving the albuminuria, decreasing the obesity, decreasing the inflammation, decreasing the hypoxia, and decreasing the fibrosis. So therefore, in the last decades, you see many studies about these drugs. We got first the IMPA-REG outcome, then the Canvas, then the DECLARE. We have the Credence 1, we have the Credence 2. Recently, we got the Emperor study showing again cardiovascular and renal outcome with empagliflozin in heart failure. And we have here what we will concentrate about is the dapagliflozin in patients with chronic kidney disease after this important publication in the New England Journal of Medicine. Therefore, in 2020, the KDIGO guideline recommends putting, as you see here in this pyramid, SGLT2 inhibitor are present for most patients with the RAS blockade. And not only the KDIGO, but the European Society of Cardiology, the ERA EDITA, American Diabetes Association, many societies put them in their recommendation, as you see. So now it is becoming one of the important milestones. Now this is part one of my talk, that do we have some drugs that could be beneficial? Yes, I spoke about the mineralocorticoid, and I spoke in general about the SGLT2, how they work. In the second part of my talk, I will tackle another subject, which is this SGLT2 inhibitor could be helpful to the nephrologist beyond the diabetes. I mean, if the patient is not diabetic, could we use these drugs or not? And in the last part of my talk, are there any new drugs coming after the SGLT2 which may reduce the progression of CKD? So let's embark to the second part of the talk, which is the possibility of DAPA beyond diabetes. You know that there have been many studies on DAPA, not only the DAPA CKD, but before they were the DAPA heart failure and the DECLARE study. And these were more addressed for cardiac patients. And nowadays, DAPA offers patient protection from serious cardiac disease and renal disease according to the 3 studies that I mentioned. This is an example of a patient at risk to end-stage kidney disease, heart failure, and death. His GFR is 35, urinary albumin excretion of 220, receiving maximum tolerated dose of RAS therapy and treatment for diabetes. This patient could benefit because he is not only a diabetic patient, he is also a cardiac patient, and diabetes and hypertension will lead to this sequence of RAS activation, ischemia, fibrosis, and oxidative stress. Therefore, it is important. The life expectancy in adults with early stage CKD 5 to 6 years shorter than in adults without early stage CKD. Therefore, if we want to put that patient on a drug, let's think of a drug that would in a way decrease this improve this short life expectancy in a more dramatic way, because this will lead the number of life years lost due to cardiovascular disease increases with the severity of CKD. This patient is classified, as you see, in the C3b because he has GFR between 30 and 44, it is 35, and urinary albumin excretion between 30 and 300. And he is already on maximum therapy with RAS blockers. So if according to the DAPA-CKD and according to the cardiac studies, this patient is a very good candidate for this drug. This is another patient which is a little bit earlier with a GFR of 75. She is on losartan and metformin with HbA1c 7.8, I mean not well controlled, with blood pressure 140/90. This patient is in our class 2 CKD without proteinuria. Could this patient also benefit from that drug? Again, according to the DECLARE study, this will decrease her possibility of having cardiac effect. And in this patient, Forxiga reduced the risk of kidney endpoint by 47% and reduced the risk of heart failure with good baseline kidney function. How can you integrate these data? Let's see, this drug works by afferent vasoconstriction. And as you know, the ACE inhibitor acts by efferent vasodilatation. So in a way, this will offer a complementary pathway to RAS inhibition to lower more the intraglomerular pressure and protect the nephron. So it could be an add-on in the treatment of CKD. The landmark DAPA-CKD actually included not only the 68% patient, I mean 2/3 of the patient with type 2 diabetes, but there were 32% without diabetes. 1/3 of the patients were not diabetic. And those patients also got delay in the progression of CKD. And this opened a very important question. Could we use it in patients who are not diabetic? And I think there was a recent, how we call propaganda about their use, even in the media, speaking that there is in England a new drug which will decrease the CKD progression, and even some famous people like Amr Adib spoke about that. So every patient is coming now telling you what is the new drug which will stop the CKD. This was actually based in a way about a recent FDA approval for the use in non-diabetic patients. Of course, diabetic patients are the majority in this, but let's see in this DAPA results, there is 39%, around 40% risk reduction in the arm of DAPA, and the number to treat, needed to treat, is only 19 patients. So it's a very small number. Therefore, this drug is effective. Reduce the risk of primary composite endpoints in patients with or without diabetes, patient with diabetes by 36%, and take care of this patient without diabetes by 50%. So this curve at the end here, patient without diabetes, the improvement of declining kidney function and the stage kidney disease, renal or cardiovascular death was by 50%. Very astonishing and important result. Also decreased the risk of all-cause mortality by 31%, reduced the risk of cardiovascular deaths by 29%, and this is a very important, take care of this, in a group of IgA nephropathy. IgA nephropathy, now we are away from the diabetes, demonstrated efficacy in this group by 71% risk reduction rate. And the number needed to treat was only 9. So this actually opens a new era because you may use this drug in indication beyond diabetes. The adverse events, of course, you will ask about it. Infections and infestations are rare. Now, the Fournier gangrene and the things that were published in the early reports are very, very rare. Diabetic ketoacidosis is rare. Some dehydration, you should not give strong diuretics with it to avoid dehydration. Angioedema is very rare, and in general, they are very well tolerated in most of patients. Conclusion, DAPA has been approved to advance the treatment of patients with CKD with or without type 2 diabetes. Now, let's go to the last part of my presentation. Are there any other ways to decrease the progression of CKD or not? Let's see the literature, and we have the ACE or RBs since long time. The combination of ACE and ARBs was condemned and stopped. The glycosaminoglycan, we'll come to this a little bit later. The anti-inflammatory or bardoxolone was banned, but it came back, and I will tell you why. The endothelin antagonist, avozantan, GLP-1 antifibrotic, anti-inflammatory, I will mention it, and of course the SGLT2 inhibitors that I explained to you in detail, decreasing the inflammation, the extracellular matrix, and fibrosis. So it seems that the pessimism that was because everything was red is now decreasing a little bit. Let's start by the first arm to affect, which is obesity. And you see here the global prevalence of obesity. Unfortunately, our area in the Middle East is one of the first 10 countries in the world having the highest obesity rate. So we have a problem. And again, that drug, which was removed from the market after the Bacon study and the publication of the New England Journal of Medicine 2013, because of higher degree of heart failure. Nowadays, in the Kidney Week of the American Society of Nephrology, it came back. And we are speaking now about clinical observation that this drug could be used, phase 3 randomized double-blind parallel group multinational study in patients with stage 4 CKD and type 2 diabetes. And the primary endpoint composite outcome, majority, more than 93% of patients overweight or obese, and the primary results are encouraging. Again, the GLP-1 receptor antagonist, as you know, we have the liraglutide and we have many other drugs. According to the LEADER study, this drug may, in a way, control obesity, but also, as you see, they can decrease the progression of the CKD, and can be, a GLP-1 RAS can be safely used in advanced CKD. This is the primary old paper of bardoxolone, and now we have more promising results. We have in the kidney many determinants of organ injury, including the ischemia reperfusion, the caspase regulation, many mechanisms that I will not bother you, tumor necrosis factor, etc. Recently, they are again trying to speak about trying to decrease tissue fibrosis, playing on the myofibroblast proliferation and angiogenesis, playing on the senolytics, antagonizing the fibrogenic cytokines and signaling. All of this, of course, is coming in the future, like Professor Magdi Yaoub was telling, but not only in the very far future, because now we have some studies, as I will show some of the therapeutic approaches that has been successful. This is an example of the clinical trial targeting the TGF-beta, because these drugs are already used in other indications. You see here, in the last one, it is used in glioma. So it could be also used in renal disease. The one in diabetic nephropathy, the perfenidone. So it could be used in FSGS. So there are some promising lines here affecting the TGF-beta. Again, the senolytics, we have very promising results coming from Mayo Clinic about the combination of two senolytic, dacitinib and quercitidine, in decreasing the senescence and prolonging the lifespan of the kidney. And safety and tolerability study of an intravenously administered small interfering ribonucleic acid post on the pump to decrease the cardiothoracic surgery in patient at risk of acute kidney injury. And this is another paper which has been published showing this QP1 1002 efficacy. Thank you very much. The future is brilliant.
Thank you very much, Professor Hani, for this elegant presentation. لا استنى ما انا نوشك شويه.
اتفضل.
طبعا احنا دايما انا بيرسونلي بستفاد وبتعلم من المحاضرات القيمه اللي انت بتقولها.
الله يخليك.
وحضرتك تطرقت الى نقطه مهمه جدا which is the use of the SGLT2 inhibitors in non-diabetic patients. وطبعا احنا في الدايابيتس والسي كي دي it is recommended not to use them beyond a
very low GFR.
يعني below 45 او below 30.
لا نزلوا شويه يعني في الستاديز up to 25.
up to 30. up to 30. Although there are many studies of still using the SGLT2 inhibitors even lower, and even in dialysis patients who have urine output and on incremental dialysis, there are some trials, but not yet in the guidelines. فاحنا ممكن نستفيد منهم even in stage 5 CKD.
Yes.
The recommendation for non-diabetic patients is to use them في the early phases of CKD ولا حتى كمان في end stage.
يعني هو طبعا ما فيش publications كتيره in this direction لكن الافيلابل publication كانت in early cases of CKD.
انا عايز اوصل معاك الى كده لان احنا ممكن استخدامهم في non diabetic with advanced CKD ممكن occasionally يدخلنا في hypoglycemic attacks partially. فيعني it's better to be used early in CKD لو هم مش
بالظبط. يعني الحقيقه يعني انا لما شفت البروجريشن او الامبروفمنت بتاع الاي جي ان نفروباثي significantly في الاستادي كده up to 70%. يعني it is very promising لان احنا actually ما عندناش ادويه كتير قوي في الاي جي ان نفروباثي مثلا.
يعني الخلاصه ان احنا لو هنستعملهم في نون دايابيتك هنلتزم
بالجي اف ار الاولاني،
الجايد الاولاني اللي هو يا اما 45 او 30 ماكسيمم.
يس.
not below. الحاجه الثانيه ان it is not a class effect, it's a molecule effect. يعني مش كل الاس جي ال تي 2 انهبيتورز زي بعض.
هو طبعا البروجريشن في مجموعه الاستاديز اللي طلعت كانت كلاس افكت، بس البروفن هو الدابا سي كي دي ستادي ات واز ا موليكيول افكت في الاستادي الاخيره. لكن برضو الامبا في الامبرور ستادي عمل some improvement on the kidney disease. يعني احنا عندنا 2 منهم دلوقتي نقدر نقول، ان مش قادر اقول قوي ان هو molecule only. It is a class effect definitely with some confidence انه الموليكيول دي هي اللي جابت الريزلت في الاي جي ان نفروباثي، او هي اللي جابت الريزلتس دي.
يبقى حضرتك عايز تقول ان هي كلاس افكت، بس الوحيد اللي واخد اف دي اي
ابروفال في الحته دي هو ده بالظبط كده. بالظبط كده.
الحاجه الثانيه ان في حضرتك حاجات ثانيه غير الاس جي ال تي 2 inhibitors which proved to be beneficial in non-diabetics as well including الميتفورمين. could you elaborate شويه على الحته ديت؟
ما انا طبعا يعني ديت اكزامبل في الاوبيزيتي امبروفمنت الحاجات اللي هي اللي قلتها. فطبعا الميتفورمين is one of the oldest regimen and cheapest drug. لكن الليراجلوتايد والحاجات دي كلها برضو بينيفيشال على الكدني كمان.
يعني بينطبق على الميتفورمين ان هو كارديو بروتكتيف ورينو بروتكتيف even in non-diabetics.
Yes.
في trials to use الميتفورمين even in non-diabetics.
صح. وعشان كده حضرتك هتلاقي ان الريكومنديشن بتاع الهرم اللي انا عملته بتاع السوسايتيز هم حاطين الميتفورمين مع الاس جي ال 2 جنبا الى جنب. هجيب لك الايه الهرم الاولاني ده اهو بالظبط. مش باين دلوقتي. يعني موست بيشنت هياخدوا يعني هيبقى في ميتفورمين وهيبقى معاهم راس واس جي ال 2.
ايوه
يعني ما زال الميتفورمين واخد وضعه.
يعني انا بنوه بس عن الكاتيجوري. وطبعا بشكر حضرتك على منشننج المينرالوكورتيكويد انتاجونست بارتيكولي البلينيرون والثيرد جنريشن لهم رول مهم.
واللي انا عرفته كمان الدكتور جمال دلوقتي ان في ستادي اون جوينج بتجمع الدابا مع المينرالوكورتيكويد. يعني في ستادي بتحط الاثنين مع بعض و they are expecting ان يبقى في more benefit لما يتعمل الكومباينيشن together.
اكسلنت. وارجع انوه تاني ان احنا ده هيبقى في الايرلي فيزز اوف سي كي دي، مش في 4 و5 علشان الهايبركاليميا. اخر جمله هقولها لحضرتك ان في كاتيجوريز مهمه جدا حضرتك تطرقت ليها برضو، اللي هي الانتي او الفايبرينوليتيك ايجنتس. وفي كاتيجوري كمان مهمه هتطلع في النير فيوتشر which is the closso stabilizers والclosso regulators. دي هتبقى ليها رول مهم جدا في delaying the progression of. At last, I would like to thank Professor Hani and congratulate you for the first AZOT. All of you are welcome, and it is a great pleasure to welcome all our colleagues from Egypt and from our African countries, colleagues from Sudan, from Tanzania, from Ghana, from Kenya, from Congo, from Zimbabwe. And I hope next time we will be having you, all of you, face in face. We were opposed by many regulations for the COVID and for the weather conditions, not to have many of our colleagues traveling to Egypt, and hope to have it on an annual basis for the Egyptian chapter. And probably any of our African colleagues would be encouraged to perform the African Society meeting in his country as well, and we will all be happy to join. I would thank also the pharmaceutical companies for their support for achieving this Congress. I would like to thank ECOS for their efforts establishing this Congress as well, and accept my personal apology for any mistakes or any mishaps which encountered in that event. And كل سنة وانتم طيبين, and welcome all of you and have safe trips to all our colleagues. اللي عايز يتصور بعد الاكل بقى، احنا الناس دلوقتي بتاكل، هيتصوروا ازاي؟ يعني بعد الاكل لو حد قاعد يبقى يتصور. Thank you very much.